Yes, everyone, very good morning. So, like yesterday, like FMG exam was there, and I hope all of you have done actually a good job. Yes, when I saw the recall questions of psychiatry, approximately uh, a number of questions from psychiatry, they have asked approximately 12 to 13 questions, right? Fine. So that's a big number from a short subject. So this time actually there was some kind of imbalance in the paper also, like some, like even like surgery had huge question, like ObGyn had huge questions, right? So we are going to discuss only about psychiatry questions now. So first question, what you see in psychiatry? First question, what you see in psychiatry here? A 45-year-old man with a history of long-term alcoholism had been abstinent for the last 3 months while on de-addiction therapy. He consumed 60 ml of alcohol at a social gathering. Within 15 to 20 minutes, he developed nausea, vomiting, red ashes, and throbbing headache, palpitations, and hypotension. Which of the following drug was he most likely taking for alcohol? Like for see here, alcohol de-addiction. Very easy to understand. So basically this question is related to disulfiram like reaction, which we already have learned here. Yes, we already have learned, right? Alcohol will be, so this will be converted into aldehyde, and after that this will be converted into acetate. Finally this will be converted into water and CO2. Here one enzyme was, see, aldehyde dehydrogenase, right? Aldehyde dehydrogenase. So this enzyme was being blocked by disulfiram. Disulfiram. We also have learned that, like, see, like if a patient is already on disulfiram, if he is going to consume alcohol now, because of the over accumulation of acetaldehyde, what will happen here? Because of the over accumulation of the acetaldehyde, see, because acetaldehyde, this is going to work on histaminic receptor also, serotonin receptor also, right? Because of the histaminic receptor, no, remember, because of the histaminic receptor, now patient will be having red rashes, itching, nausea, vomiting, right? Low BP, severe headache, right? Severe headache, like patient can go into shock also. And because of serotonin, patient can have what? Patient can have the neurological symptom also, like seizure. See, even there can be death also. And this reaction, now I'm sure you are able to recall that this reaction is called as di right? Okay, this is called as disulfiram ethanol reaction, right? Now, so disulfiram ethanol reaction. So the same topic we have learned during the class in detail, right? And that time also I explained you that disulfiram like reaction, most important topic, right? Most important topic. So here we can easily rule out all these. Okay, disulfiram. Okay, remaining all like this, naltrexone and the topiramate and acamprosate. These are anti-craving drugs. Anti-craving drugs, right? And disulfiram is a deterrent drug. Next question. Which of the following ECG change is most likely to be associated with lithium therapy? Okay, see here, this question, I think in last 5 years, ECG changes about lithium therapy, they have asked for the first time. So here, but we should know here the fact that lithium toxicity, this has always been an important topic for the examination, right? So lithium can affect your CNS also, where there can be the coarse tremors, right? So lithium can affect like endocrine part also, where it can cause hypothyroidism, right? See, GIT problem like nausea and vomiting. After that, renal, lithium was causing polyuria with polydipsia. Finally, diabetes insipidus, right? Nephrogenic diabetes insipidus, red rashes around the body. And during the pregnancy, this can cause abstinence anomaly, right? Abstinence anomaly. But ECG changes, remember here, most important, most characteristic, most characteristic you are going to see is T wave inversion. T wave inversion. Next question. See here. Okay, next question. 5 milligram IV morphine was given to a 45-year-old patient for post-operative pain management. You are monitoring him for opioid toxicity. Which of the following findings can suggest your diagnosis of morphine overdose? Last time also they have asked this question, opioid overdose. What will be the symptom? Basically, this question is related to opioid overdose, where we have learned symptoms will be CPR, right? Patient will be in coma. There will be, see, now there will be the pinpoint pupil, right? And respiratory depression. And because of respiratory depression, now patient will be having low BP, patient will have low heart rate, patient will have what, hypothermia, right? So overdose, CPR. Out of these, very easily you can mark the answer here, कि constriction of people, this will be the answer for opioid overdose or overdose for morphine. What is the antidote for opioid overdose? Answer is naloxone, where half-life was only half an hour. This much point is clear to everyone. IV naloxone, this can be right, right, okay, this can be life-saving. And after that, for relapse prevention, we can use, right, okay, naltrexone. All these we have learned in detail. Next question. A person is getting sexual gratification after wearing the dress of opposite sex. This paraphilia is called as, you can say, eonism, which is also known as the transvestism. After wearing the dress of opposite sex, if a person is enjoying, if a person is having sexual gratification, it is called as eonism. Eonism, which is also called that, yes, which is also known as the transvestism. Now, what about frotteurism? Frotteurism means what? A person is getting sexual gratification after rubbing against the person in a public place. Okay, scotophilia, right? See, scotophilia and voyeurism, same thing. After watching the act of sexual intercourse, if a person is getting sexual pleasure, right? That is called a voyeurism or a scotophilia. I think some options might be different here, but like here, say this was the question and this was the answer here. Eonism, you can say the transvestism. Next question. A 45-year-old person is getting irritated, having fluctuation of emotion. He has poor eye contact with the people. He wants to stay alone, means socially detached. Socially detached. So one symptom is actually negative symptom is, you can see a negative symptom, socially detachment, right? After the, see, poor eye contact, after that fluctuation of emotion, fluctuation of emotion. So one emotional problem is also there. There is what, like irritation also. Now, most important point, these symptoms are there for more than 2 months. More than 2 months here. Which of the following is indicating that he has schizophrenia instead of delusion? Remember, like what I have taught you during the class, delusion means what? False belief that. And a delusion is what? False, firm, fixed, and the unshakable belief of a person. If there is only delusion, then it will be called as delusion. But remember, if a person is having delusion also, hallucination also, or some other symptom also. So what I have taught you, minimum two or more than two symptoms for more than 1 month, then it is called as schizophrenia. I have explained you that you have to focus on delusion, hallucination, formal thought disorder, motor symptoms, or negative symptoms, right? Okay, fine. All these points are clear to everyone, like even disorganization symptoms. Minimum two or more than two symptoms, then 100% answer is schizophrenia. But duration criteria is most, see, this is most important here. More than 1 month as per ICD-11. But as per old classification, it was for more than 6 months as per DSM-5. Next question. Now, a young female feels that she is not being loved by her family members. She often feels irritated after being questioned by her mother. She feels heaviness of lower limbs and she keeps on eating a lot. What is the most likely diagnosis here? First of all, see, I think some students were saying that some more symptoms were there, but overall, what I could recall, these were the symptoms. After seeing the symptoms, like in a young patient, depression, yes, there can be irritation. Irritation can be there. She is not being loved by, right? Okay, so feeling of discrimination from the family members, right? Okay, now the question is that I have taught you different types of depression. One depression I have taught you, that was the typical depression. Second, I have taught you atypical. See, in typical depression, like everything will be decreased, low mood, low food, low energy. After that, see here, like lack of sleep also, so low energy. After that, see, lack of energy, lack of attention, lack of concentration. And then see, negative thoughts, right? Feeling of guilt, suicidal tendency, weight loss, anhedonia. So what I'm saying is that when I talk about the typical depression, no, like everything will be decreased, right? Everything will be decreased here. But like there was a type of depression which I have taught you, where there can be reversal of biological symptoms, where a person will start eating more, hyperphagia, sleeping more, hypersomnia, है ना? So because of that, obesity, weight gain. And after that, I have taught you like interpersonal sensitivity, feeling of discrimination from the family members, and leaden paralysis. I have taught you, like patient can say कि, sir, I'm not able to elevate my limbs, heaviness of limbs, that is called as leaden paralysis. And there can be happiness, like episodes of happiness in between the episodes of depression, right? That was called as mood reactivity. So as per this question, easily I can answer here that major depression with atypical symptoms, atypical depression I have taught you. Next question. A child with a low IQ means autistic type of symptom and presented with the loss of bladder control. Some students said, "Ki, sir, they have mentioned urinary incontinence, whatever." So what I have taught you, that symptoms of autism with loss of bowel and bladder control, with loss of acquired skills after 2 years of age. This is called as Heller syndrome, which is also called a disintegrative disorder, regressive disorder, or dementia infantilis. So this was the question related to Heller's syndrome, right? Loss of bowel and bladder control, anywhere child can defecate and pass the urine. Next. A 70-year-old woman is brought to OPD by her daughter with complaints of the progressive forgetfulness. For the past 1 year, she has been seeing people and animals in nearby house that has been unoccupied during this period. What is the most likely type of dementia? I think they have asked one more question of dementia, right? So this time actually, like see, dementia also, so minimum two questions they have asked. So, but this was one of the questions which I felt 100% psychiatry type. Right now, so where I have taught you also in a Lewy body type of dementia, where there will be severe visual hallucination, and like related to Lewy body dementia, I've explained you that like so there can be a delusion of misidentification also. Patient can patient can misidentify a person also. So here basically see, like visual dementia, like visual type of hallucination we can see in some other types of dementia also, but in Lewy body dementia there will be severe visual hallucination, severe. Next, a person has symptoms as per the given photo, like right, okay, see what students have explained me here, ki sir, they have given a photo of rabbit, like there was a photo of rabbit like in the examination room. So basically, see, I have taught you about EPS, extrapyramidal symptom, right? So that can be the side effect of antipsychotics, but which antipsychotic? Remember here, EPS is most commonly associated with first generation antipsychotic. First generation antipsychotic, or you can say typical antipsychotic like haloperidol, flufenazine, and chlorpromazine. So what are the EPS I have taught you? All acute EPS like acute dystonia, acute akathisia, neuroleptic malignant syndrome, after that drug induced Parkinsonism. But the long standing I have taught you, no, long standing side effect, that was the chronic, right? No? So where rabbit like features they have mentioned, rabbit like feature, that was called the tardive dyskinesia, right? Now tardive dyskinesia, and the drug which we are using for that, that is called a valbenazine. So fluoxetine is SSRI, ziprasidone and risperidone, these are second generation atypical antipsychotics. So very easy to rule out here, very easy to rule out. Answer will be chlorpromazine. Next. A severe drug abuser is brought to hospital with complaints of long-term liver disease. Liver disease, when examiner has mentioned, oh, then it is what? Alcohol. Which of the following, right? Okay, which of the following you are going to add in the line of the treatment here? So yes, we have to add vitamin B1. Vitamin B1, right? We have to add right, okay, thiamine, because there will be deficiency of vitamin B1. This much point is very easy, right? This was very easy question for you people. Next, a patient with schizophrenia reports that his neighbors are calling him and and controlling his actions so a false belief that someone is calling my name or someone is going to control my action, so delusion of influence also we have learned all these points. So simple question, this was very simple question, right? Now a boy who was a good student used to secure good grades in class. Now he is not performing well in the class. He appears to be less interested in study. Often he comes late to his home. What can be the probable cause here? Here, when I see these symptoms, no, like first of all, I can understand that these are symptoms like depression only, symptoms like depression, but like some other symptoms, like earlier he was very very good, suddenly now he's not performing well, he's coming late to his home. So these are early symptoms of the drug addiction. Okay, so answer C will be more appropriate here. Okay, fine. Okay, so I think, see, like we have discussed all the psychiatric questions which they have asked, like in yesterday exam. I hope you people have performed well. So thank you so much. I wish you all the best.
Hi everyone. I hope you had a good exam and whatever. Now we just have to wait for the result, and definitely I'm sure you must have done with good like mark the good options, mark the right options. I know most of you will clear. My best wishes from my heart. Let us see what are the questions I got and what were the answers which I think is right for that questions, right? But my best wishes for your result. If I forget to tell in the end. So I got total 9 questions, and questions were pretty easy, and most were from what we were discussing throughout our preparation. So I think it must not have been a problem. But let's see. Which Malampati class is shown? So this was an image-based question. Malampati, so many times I have told you, it's one of the most important topic. And I told you 3 important questions from Malampati. Why we use Malampati to predict difficult intubation. Then they give the 4 grade and ask you to identify. And then they can give one Malampati and ask which class this patient belongs to. And this was what was this time. So they had given an image of a patient's oral cavity and they asked which class Malampati. So what we have discussed, that we just have to see the uvula and we have to see the distance of uvula from the tongue. If uvula is far away from tongue, definitely this is Malampati class 1. We are able to see everything. We are able to see the tonsillar pillars, fauces, hard palate, soft palate. If uvula was just touching the tongue, then I would have gone for Malampati class 2. And if the tongue was just overlapping the uvula and only the base was seen, then I would have gone for Malampati class 3. And if no uvula would have been seen, I would have gone for class 4. So here we can see the uvula will go for class 1. A simple, easy question. I know mine 100% students must have answered it correct. Okay, now let's see the next question. Okay, the next question. A patient is planned for breast surgery as a daycare procedure. So ambulatory or daycare procedure. Last time also on ambulatory surgery, there was a question. I told you, remember the drug list we use for ambulatory surgery. Which of the following agent is choice for induction and maintenance of anesthesia? And what we discuss that for daycare, only one drug come in our mind: propofol, 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 right? So propofol is the best for daycare surgery, right? So propofol is the answer. Propofol gives a rapid, let's say, regain of the consciousness after stopping it and has no residual effect, is antiemetic, and gives a very pleasant recovery. So it's the best, the agent for daycare surgery. So propofol is right. Yes, yes, Jay, the propofol is absolutely right. And I know all of you must have done it correctly. Okay, next question. So again, an image-based question. The image which we have put so many times in your tests and also discussed in our workbook, the rapid fire session, the the critical review portions, everywhere we have discussed this. So this needle they asked, what is this needle used for? Name the needle shown in the image used for regional anesthesia. Very clear, right? Okay, the answer is this is an epidural needle. How did I ask you to recognize between epidural and spinal? Spinal needle does not have markings on it. Epidural needle has markings on it. So if a needle with markings on it is there, then it is a epidural needle, right? Yes, it was in the test as well. So the answer is epidural needle. Again, what do I say? In Hindi, we say halwa question. These were all so simple question. So three question, I know 100% till now, right? So let's see the fourth question, what you have done in the fourth question. Okay, the fourth question, an ABG was shown. Again, a very simple ABG, very straightforward, simple ABG. If you had followed the rule, you would have answered. So, okay. And ABG shows following value. pH is 7.25. Okay. PaCO2 is 60 mm of Hg. HCO3 is 26 and PO2 is 80. So let's leave PO2. I told you, how do you interpret? How do you interpret this ABG? You have to see three things. You have to see pH, PaCO2, and HCO3 for diagnosing acidosis or alkalosis. pH normal is 7.35 to 7.45. So here the pH is less than 7.35, so this is acidosis. Now we have to see whether HCO3 is deranged or PaCO2 is deranged. Now PaCO2, the normal value is between 35 to 45 mm of Hg. So PaCO2 is way out of range. It is 60 mm of Hg. And both pH is decreased, PaCO2 is increased, the opposite direction, right? So this is respiratory acidosis. Patient is breathing slowly, CO2 is not getting exchanged. Now, as a compensatory mechanism, the HCO3 should also increase, because we know that pH, to balance the pH, to keep it normal, we should have a CO2 and HCO3 balance, right? So CO2 is increasing, HCO3 has to increase. But here, the HCO3, which is between 22 to 26 milliequivalents per liter, this is the normal HCO3, it is within the normal range. So compensatory mechanism has not yet started, right? So this is your acute respiratory acidosis. No compensation has started. Yeah. So guys, very good, Jay. I'm so happy for you that you marked it right. So answer is acute respiratory acidosis. So fourth one is also my halwa question. Still all four questions that we have discussed, but I know most of my students have scored 100% in this. So, right. So now let's see another question. So everyone, this was the question. This was the question. Yes. Jay is asking, OBGYN was also intubation where three trim patients, so we will have a shallow breathing. I don't know what you are talking about, but if this ABG is there, the answer is acute respiratory acidosis, right? It is acute respiratory acidosis. Okay, now next question. Now identify the type of breathing pattern shown in the image. Well, this may be, I haven't discussed in my sessions, but you may have discussed in medicine. I got this question, so I'm discussing it. So this is a typical crescendo, decrescendo type of respiration, breathing pattern. This is Chen stroke breathing. pH is 7.45. No, it's 7.25. pH was 7.25 in the question. 7.25. Yes. It was not 7.45. Savint, right? Okay. Yeah, this is the chain strokes breathing pattern. So since the four breathing pattern is there in the options, I just brought the let's say graph for four different breathing pattern. This is a normal respiration. For biots respiration, which is also called ataxic respiration, we have a periodic breathing, that is period of hyperpnea followed by period of apnea, right? So this is hyperpnea followed by period of in between two hyperpnea there's a period of apnea, no breathing. So this is biots breathing. Then biots, then Kushmal breathing, the patient is hyperventilating, the breathing rate is very high, it's a hyperpnea. So Kushmal breathing pattern will be normal, and we'll have a normal breathing, we'll have a hyperventilation. And for chain stroke breathing, that is also called periodic breathing. Biots is also called periodic, chain stroke is also called periodic, but there is difference that in biots we have let's say period of tachypnea, period of like hyperpnea, more breathing, and then no breathing. Here we have a gradual hyperpnea, like crescendo, the breathing is built up, crescendo and then decrescendo, right? Gradual hyperpnea and apnea, right? So this was our chain Stokes breathing pattern, right? Chain Stokes breathing pattern. Okay, there's a history of trauma and then they show bio. No, if this is the graph, guys, if this is the graph, it was chain Stokes breathing. If this was not the graph, this is a typical crescendo decrescendo graph, this for chain Stokes breathing. If the graph was something like this, that is the period of hyperpnea and then apnea and then period of hyperpnea, right? Not the crescendo decrescendo type, right? Then it would have been biots respiration, Abhishek, right? So whatever, uh, if you see the graph and if you have to make the diagnosis for this graph, if this was the graph, can you confirm it in the chat box? If this is the graph, this is for sure chain Stokes breathing. Got my point? This is for sure the crescendo decrescendo type breathing pattern is for chain Stokes breathing. So yes, this is chain Stokes breathing. I hope. Okay, so I hope you all have done it fine. Okay, again, a very, let's say, easy question which was asked. A patient under anesthesia develops respiratory depression. So patient develops respiratory depression. Which of the following capnography finding is most consistent? So respiratory depression, this means the patient is breathing less. So patient would be in hypoventilation. And what we have discussed in hypoventilation, that the CO2 will not get cleared. We'll get respiratory acidosis as we saw in that ABG pattern. That is a typical ABG pattern of respiratory acidosis. So CO2, PaCO2 will increase, EtCO2 will increase, and there will be gap between two capno, the graph which I showed you in our regular discussion. So let's see all the option. Sudden loss of waveform with end tidal falling to zero. This will happen in apnea or sudden extubation. So this here it is not the case, it's a respiratory depression. Then reduce end tidal CO2 with increased respiratory rate. This will happen in hyperventilation. Hyperventilation. This is not hypoventilation. Increase end tidal CO2 with normal waveform and reduced respiratory rate. Yeah, waveform shape will be normal and increase end tidal CO2 value and reduce respiratory rates. This is the answer. So I hope all of you have done it right. Jay, was you all marked this question correct? Because I discussed so many times with you that for hypoventilation, and so please, if the question was different, please Chiranjeevi, give me the right question. I was be provided with this question for hypoventilation and for hyperventilation, right? For hyperventilation. For hypoventilation, the graph is normal. There is gap between the two graphs. The respiratory rate is less. The graph is normal in the shape. The CO2 value is increasing. So PS, the EtCO2 is increased. The respiratory rate is decreased. This is hypoventilation. For hyperventilation, the rate will be faster and the CO2, EtCO2 will decrease, right? They asked, okay, Chiranjeevi has posted, they asked there is a sudden decrease in ETC, in decrease in capno. Well, tell me, so many times, if that was the question, Chiranjeevi and rest of the students, if that was the question, if there is a sudden decrease in EtCO2, what is the condition? What will be the condition? What is the answer? What was the option? These were the options. If sudden pulmonary embolism was mentioned, capno question was easy. Language was just twisted. Okay. Option was mentioned embolism. Sudden decrease in EtCO2, I have told you so many times. The answer was pulmonary embolism. If that is the question, answer is pulmonary embolism. So you are telling me the question was the patient under anesthesia, there's a sudden decrease in EtCO2, sudden decrease in EtCO2. So what's the answer? For this, the answer has to be pulmonary embolism. Pulmonary embolism, right? Okay. 15 to 5. Okay, then it has to be pulmonary embolism. I told you sudden drop. If the mention in the question is sudden drop, the answer has to be pulmonary embolism, nothing else. Right? Okay. If this was not the question. Okay. Next question, which I got. Please correct me if this is also wrong. A patient in emergency department has severe facial trauma. Severe facial trauma. So remember, in severe facial trauma, bag and mask ventilation is something which is like 99.9% we are not able to, we cannot do. With airway edema, attempts at endotracheal intubation has failed. So failed intubation. And the patient is rapidly desaturating. So I discussed about difficult airway. And I said cannot intubate and cannot ventilate or cannot oxygenate. I said in SECO, what do I do? Put in the chat box. What do we do in SECO? What do we do in SECO? Anyone? What's the answer? What do we do in SECO? Yes? Yes, the answer has to be cricothyroidotomy. The patient is rapidly desaturating. In emergency, that is cannot intubate, cannot ventilate. We have to do cricothyroidotomy, right? We will do cricothyroidotomy, and once we have maintained the oxygenation, then ultimately we will do a tracheostomy. But tracheostomy is more of an elective procedure, will take some time. Cricothyroidotomy is done in emergency, and here we have a emergency rapid desaturation. So nothing else we can do at this point. We can do cricothyroidotomy. Yeah, got it? Okay. So answer is cricothyroidotomy. Okay, next question, which I got. Patient is brought to emergency department after house fire. Okay, ma'am, question mentioned doctor was available, so crico was confirmed. I couldn't get again, Jay. Doctor was available means, so what would the doctor do in this situation? Yeah, anyone handling the airway and has not been able to intubate and cannot ventilate has to do it, and patient is desaturating, has to do cricothyroidotomy. We have discussed in our flow chart that cannot intubate, cannot ventilate, cricothyroidotomy. Got it? Okay. A patient is brought to emergency department after house fire. So house fire. Blood gas analysis shows carboxyhemoglobin 18%. Guys, if carboxyhemoglobin is more than 0.3% in non-smokers and more than 10% in smokers, we call it the carboxy. The patient has, let's say, carboxyhemoglobinemia. Patient has more carboxyhemoglobin. And we all know carboxyhemoglobin, your carbon monoxide. Carbon monoxide binds to the hemoglobin in faster manner, and what does it do? It decreases the oxygen delivery, so hypoxia and cyanosis happens. And how can we combat it? What is the initial management? Initial management is to give high flow of oxygen. If we give oxygen, then the half-life of carboxyhemoglobin go on decreasing, right? Normally it is 300-400 hours, it starts decreasing to 45 to 75 hours, right? So guys, in this, the answer is the first thing which we do in let's say carbon monoxide poisoning. Carbon monoxide poisoning. This is a case of carbon monoxide poisoning is attached non-rebreathing mask. If in this question I had an option HFNC, high flow nasal cannula, I could have gone for that as an answer. That could have been best. But if it is not there, HFNC, the answer has to be non-rebreathing mask, right? Okay, in question they have mentioned high concentration of oxygen. High flow oxygen was there in the option. High flow oxygen was there in the option. If HFNC was there in the option, guys, I'll go for HFNC as an answer. I'd go for HFNC. HFNC is a better device. It can give a higher oxygen concentration. Non-rebreathing mask can also give a higher concentration of oxygen. Therefore, these are the preferred device. But by non-rebreathing mask, we ventilate at the rate of 50, I mean, the flow is 15 liter per minute. By HFNC, I can give 100% oxygen at the rate 60 liter per minute, which could be even beneficial in this patient. So if HFNC, high flow oxygen through non-rebreathing, well, then that would be the answer. High flow oxygen through non-rebreathing. Yes. High flow oxygen. Yes, I would give what we do in carbon monoxide poisoning. We increase the oxygen flow meter to its highest, attach non-rebreathing mask, the tubing, and attach it to the patient. We try to decrease the carboxyhemoglobin half-life by giving a high flow of oxygen. That is the treatment. That is the treatment. And if patient does not respond to this, or oxygen concentration, I mean, let's say patient starts getting unconscious and all, then we can go for hyperbaric oxygen therapy. But initial treatment is always high flow with non-rebreathing mask or a high flow nasal cannula, HFNC, right? Simple nasal cannula cannot be the answer. Simple conventional nasal cannula cannot be the answer. So answer has to be non-rebreathing mask with, through it, high flow of oxygen. High flow oxygen by non-rebreathing mask. This is the best option. And this is what is recommended. This is what is today we do in our emergency. So anyone has any doubt on this question? Okay. Okay, next question. Identify the correct anatomical location for performing tracheostomy. So again, this was an image that we have discussed so many times. We have discussed this is your thyroid, this is your cricoid, this is your trachea, this is first tracheal ring, second tracheal ring, and third tracheal ring. And the best site for doing tracheostomy is between second and third tracheal ring. So between second and third tracheal ring, this is the, I mean, this is cricothyroid membrane, right? This is thyrohyoid membrane. This here we don't do. Here we don't do tracheostomy. Here we do cricothyroidotomy, not tracheostomy. So this would be the answer. Between second and third tracheal ring would be the best. Okay, now Jay is asking cricothyroidotomy was asked. If they ask cricothyroidotomy J, then it has to be cricothyroid membrane. Here they had provided me with the question tracheostomy. If tracheostomy is asked, it is between second and third tracheal ring. If cricothyroidotomy image-based question is asked, and if they have mentioned like was it ABC? Okay, cool J. ABCD was marked, and they had asked cricothyroidotomy. So let me reconstruct the question for you. ओके क्रिकोथायरोडॉटमी पूछा था ठीक है तो अगर इमेज कुछ इस तरह का था इफ दिस वाज द इमेज दिस इज थायराइड दिस इज क्रिकॉइड and this is the trachea, the first tracheal ring, second tracheal ring, third tracheal ring, and maybe above this the hyoid bone was also formed. So this is A, this is B, that is cricothyroid membrane, and this is first, second, and third. This is C, right? And I don't know what was D. What was D? What was the D option where they had marked D? But if ABC option I get, and the question was cricothyroidotomy, if you remember, cricothyroidotomy. We have discussed so many times this question in our surgical airway lesson, right? The answer would be B. The answer would be B, right? That is here between thyroid and cricoid, right? Okay, 1, 2, 3 mark. और 3 number mark था पता नहीं okay anyways Chiranjeevi just remember this for cricothyroidotomy it is between thyroid and cricoid, that is cricothyroid membrane. If whatever option was here in between cricothyroid membrane, that would have been the answer if cricothyroidotomy was asked. If tracheostomy was asked, then it would be between the tracheal ring. The best site for tracheostomy is between second and third tracheal ring. So this would be for tracheal ring, tracheostomy, right? So this was all for this image based question, I think. Okay, so this is all the questions that I got. Yeah, halwa question, right, Jay? Okay. Okay. Any other question you want to tell me, which was asked and I didn't get? Any other question which you want to tell me from? Was any question asked from CPR? Was any question asked from any other question from inhalational or regional anesthesia or IVRA? Nothing? Okay, these are the only questions which I got, Tarang. So let me very quickly revise all 9 questions. Identify the correct anatomical location for cricothyroidotomy, you are asking. It was asked in the question. It is between between thyroid and cricothyroid membrane. So here, if the question was like this, answer is B. Okay. Now, if the question was the patient is brought to emergency department after house fire, that is carbon monoxide poisoning. What is the first initial step? And always in carbon monoxide poisoning, high flow through non-rebreathing mask. So this non-rebreathing mask would be the answer. High flow oxygen through non-rebreathing mask. Okay. A patient in emergency department with severe facial trauma and airway edema, intubation was unsuccessful. Patient was rapidly desaturating. If this was the question, the answer we have to do cricothyroidotomy. See, cannot intubate, cannot ventilate, cricothyroidotomy. If this was not the question, you will give me the question. Okay. Then a patient under anesthesia, a sudden drop of CO2 was seen, as you said. I told you again, this is a favorite question. The answer is pulmonary embolism. Pulmonary embolism. Okay. Then image-based question. This image of breathing pattern of patient was given and they asked to identify. Whatever is the clinical scenario, don't go for that. This breathing pattern, that is crescendo, decrescendo, is chain stroke breathing pattern. So chain stroke breathing pattern, right? Okay, and ABG shows this value, that is acidosis, PaCO2 60, HCO3 26, PaO2 normal. So this is acute respiratory acidosis. Some students in the chat box mentioned the pH was 7.45. Well, if pH was 7.45, then the answer would, I mean, definitely would change. It would not be acute one. But if this was the pH 7.25, as many students have told me, it is acute respiratory acidosis, right? If the pH was going towards normal, right, then the answer would change. Okay, then which needle? This is epidural needle. Very simple question. Then a patient for daycare surgery, agent of choice, propofol. And the Malampati class, this is class 1. So 9 questions I have discussed and all 9 were Halwa question. I know you must have scored 100%. My best wishes. Anything else you want to ask from me, put in the chat box. I'll take the question or I'll pass to the next faculty for the discussion. Anything else?
Hello, my dear students. I'm Dr. Jayaprakash K, the Professor of Forensic Medicine. This time I have got about 13 questions from Forensic Medicine and Toxicology. Let me discuss one by one. Here it is from Forensic Ballistics. A gunshot wound shows an abrasion color and grease color. There are no signs of burning, singeing of hair, or charring, but tattooing is present. Tattooing is peppering. What is the range of the shot? Let me discuss briefly about this question, especially. Different ranges of rifle firearm. Number one, contact shot. The gun is in touch with the skin. Number two, close shot or close range, where the target is within the reach of the flame, more than A, less than B. Near range or near shot means the victim is beyond the reach of the flame, but within the reach of the smoke and soot, B to C. Intermediate range means the victim is beyond the reach of the smoke and soot, but within the range of powder particles. Distant range means the victim is away from all the products of firing except bullet. Okay. So now, in brief, if in case of distant shot, what you see is wound of entry surrounded by grease collar and abrasion collar. If the victim is in intermediate range, in addition to that, you got tattooing. Now we got the answer. The wound of entry with only tattooing is seen in intermediate shot. You already got the answer. If is in near range, there will be tattooing plus blackening. If is in close range, tattooing plus blackening plus singeing plus burning and contact shot muscle impression. So now you see here the distant shot, there is only crease collar and abrasion collar with wound of entry. Intermediate range, there will be tattooing surrounding the wound of entry. The near ring, there is wound of entry with tattooing plus blackening, as you see here. And in case of close range, there is wound of entry, abrasion color, grease color, blackening, singeing, and burning, as you see in this picture. And in case of tight contact shot, there will be muscle impression. So all these you can see in a single PowerPoint. Okay. So now you got the answer. The answer is intermediate range. Okay. Easy question. Number one is number two. A deceased individual involved in a road traffic accident is brought for medical legal examination. History reveals a dashboard injury. Most probably, he must be a front seat passenger. His knee has hit the dashboard. Then what happens? Once it hit the dashboard, there is transmitted force from the knee to the femur, which may give rise to especially posterior dislocation of the hip. There may be a fracture of the patella, fracture of the femur, but most commonly the posterior dislocation of the hip. Two easy questions. In a patient present with opioid overdose, which of the following effects is seen? You know very well. Opioid, it is a somniferous poison. At the same time, it is seen as depressant and respiratory depressant. Everything will be reduced. Okay. So, answer is bradypnea. There is no tachypnea, there is bradypnea. The pupils are pinpoint. The pupils are pinpoint people. At the same time, it gives rise to bradycardia, not tachycardia. All three are highly doable. Number four, a male derives sexual gratification by wearing female clothes. The person gets sexual gratification by wearing the clothes of opposite sex is known as transvestism, also known as eunism. So here the answer is eunism. Fourth question also is Z. Okay. The radiograph of the shoulder joint of an alleged sexual assault victim is shown. Estimate the age of the victim. I'm extremely sorry. We don't know exactly what sort of X-ray has been given, but it is at level. They just ask whether you have to see whether the upper end of the humerus is fused or not. You know, shoulder, it fused at the age of 18, elbow 16, wrist 18 or 19. Okay. So now here you can see the upper end of the humerus has fused with the jaw. Age is more than 18 years. Okay. The fifth question also comparatively easy. A completely burnt body is brought for medical examination to assess the cause of death, detect pre-existing injuries, and identify the fractures. Which procedure is most appropriate? You know very well, the X-ray, the best thing is virtual autopsy. What is virtual autopsy? We don't open the body, we just do with X-ray, USG, CT, MRI, especially when there is fracture of the skull bone. The ideally CT scan is good. So virtual autopsy is the answer. All six, especially five questions are easy. Okay. Now coming to the seventh question. 59-year-old victim present with 24 hours with an alleged issue of sodomy by co-worker. Which of the following is the method to detect evidence of that? Here you should know what is sodomy. Sodomy means anal intercourse. Anal intercourse. Oral cavity you can rule out. Anal swab for cells and semen is the answer, not the nail clippings and blood serum. So here, best evidence is anal swab for the presence of spermatozoa or semen or any other male epithelial cells. Okay. Seventh question is also easy. Sample for DNA advanced burn, dead body, advanced burn. Okay. Remember very well. Normally, in such cases, if blood is not available, soft tissue is not available, we go for bone and teeth. But in case of burns, ideally, teeth is well protected. Well protected. So the answer is teeth. Femur. Femur is also okay, but in case of burns, even femur, it is advanced burnt body. Femur also must have been burnt, but teeth pulp, you can take the DNA. So eighth question also easy. Identify the given fingerprint pattern. I think all of you must have answered properly. You know, fingerprint pattern number one, loops, hairpin bend loops. It is most common, 60 to 70%. Holes, maybe clockwise or anti-clockwise, about 25% to 35%. Arches, around 6 to 7%. Composite combination of maybe loop and loop or loop and whirl or whatever it is. But here, you know the answer very well. You can see the words. Okay, ninth question. Principle of DNA fingerprinting. I don't know whether I studied or not, but I have mentioned in my forensic science chapter. You know, DNA fingerprint, some few nucleotides continuously repeated like CA, CA, TTA, CA, CA, TTA, CA, TA, TTA, CA, CA, TTA. It repeats. It is known as mini satellite or short tandem triplets, which is cut by using restriction endonuclease or RE, which is also known as chemical scissor. And this is the basic principle of DNA fingerprinting, mini satellite, restriction fragment length polymorphism, or variable number tandem repeats. It is not constant number tandem, VNTR. So answer is VNTR. I don't say that it is very, very simple, but if you have gone through the video, definitely you could have answered. Look at the CT scan shown. What is the most likely diagnosis? Very, very simple. Extradural hemorrhage, you see, biconvex shadow. Whereas subdural hemorrhage, you say concavo-convex or crescentic shape. What we say is like orange and banana, they compare. So here, some people say they ask about lucid interval. Lucid interval is seen in about 40% of the cases in case of extradural hemorrhage. So answer is EDH. A male is able to achieve erection and perform sexual intercourse normally, but is unable to consummate marriage with his wife. That means he is not totally important, but is important to a particular woman. That particular woman is his wife. This question may be asked in psychiatry, but absolutely, this is not a very easy question. Even so far, UNICEF and NEET PG also, they are not asked such question. Impotentia assumed means is totally important. Inability of male to perform coitus with anybody. Impotentia generandi means inability to procreate. We cannot fertilize a fertile woman. Whereas you must have heard of impotent coat hang. Impotent coat hang, you have studied, and I told you also, impotent coat hang, a person is particularly impotent to a particular woman. And if the particular woman is his own wife, the specific Latin term is impotent coat uxerum. Uxerum in Latin means wife. Frigidity, it is impotency in case of females. Okay. Last question. An alcohol-dependent patient consumes alcohol along with the prescribed drug and develops abdominal discomfort and bloating and distension. Which drug was prescribed? I'm sorry, the answer is overlapped here. Always the drug anti-abuse, what you give is the disulfiram. Disulfiram is the answer. Fomepizole, you know very well, it is given in case of methyl alcohol or ethylene glycol overdose. Naltrexone is used in case of opioid antagonism. Okay. Clopramazine is one of them. Antiemetic. Okay. So here the answer is disulfiram. Which drug was prescribed? Disulfiram. I'm sorry again, he cannot see properly. That regarding all 13 questions in forensic medicine, out of 13, 12, or at least 11 were very easy. Okay, wish all the best. Bye-bye.
Good afternoon, dear students. I hope that your exam went well according to your hard work and the expectations. We are waiting for the happy news at the earliest possible. This is just a memory-based recall, and the proper discussion will be done later once we get the appropriate options. We are not going to discuss more upon why, but we are going to focus more upon what. Yes, okay, if an art was very easy, you should be able to score at the maximum. I see that 70 to 80% questions came from what we keep teaching in the class, Ajay, 1985. So that, it'll help to boost up your score. Now I have got some 31 questions and we have to finish within 15 minutes. So each question 30 seconds, as you get in your exam also. Very first question. Testicular histology was given, cluster of large polygonal cells, interstitial space between seminiferous tubules. Means you had seminiferous tubules with sperms inside, but your focus was upon these large polyhedral or polygonal cells. It was Leydig cells which will give testosterone. So choice number A should be your answer. I think seminoma. Okay, we'll have to work upon the details. Question number 2, mid-sagittal MRI, C-shaped white matter, superior to fornix, superior to septum pellucidum. Like in sagittal section, you'll find the structure will appear like this. The septum pellucidum will be inferior to that. So the question was on corpus callosum, in fact. If the question were different, I'll find out the details and give it to you, but there was a question on corpus callosum. Now, this is left upper limb and left lower limb. If both the lower limbs and upper limb are involved, see, if only lower limb is given, anterior cerebral artery. But if the upper limb is also given, it's better to take your answer as middle cerebral artery, because middle cerebral artery, though it is the chief artery of lateral cerebrum and take care of upper body homunculus, that is the head and the upper limb area, but it also supplies internal capsule, and in the internal capsule lower limb can also come. So in this question, middle cerebral artery will be the best possible answer. In this question, they are asking about the speech problem, speak fluently, but there is nonsense aphasia, or the understanding of the language is not there. So Broadband area number 22, that is the superior temporal gyrus, more posteriorly. As I'm telling, all these questions we'll be discussing again with proper details. I have to go very fast with the details here right now. Congenital prominent ear, bat ear, that means the auricular hillocks 3 and 3 plus total 6, they have not fused properly. Ideal age for giving otoplasty or pinoplasty before school age to avoid the social stigma. But then the options are such that you have to wait for some time till the ear, external ear properly developed. So the best option will be after 6 years of age. Yeah, I understand there'll be so many options which are there, which are not there. I'll find out proper options and then we'll discuss the proper discussion will be done later. This is image-based question, floor of primitive pharynx, paired swellings, first pharyngeal arch, anterior two-third of tongue. Anterior two-third of tongue, you'll find first pharyngeal arch, there'll be lingual swellings, and along with lingual swellings, there'll be tuberculum impar. So that is coming from first pharyngeal arch for the development of tongue. The answer to this question will be lateral lingual swellings. This question, parotoidectomy, main trunk, facial nerve, how will you be marking that? This is a repeat question, in fact. Before branching into the parotid gland, you have to mark the facial nerve. That will be the tragal pointer, this tragal pointer. So that should be your answer. All are image-based questions. Most of these are image-based questions. 40-year-old male singer, speaking voice is relatively normal, but unable to reach the high-pitched voice. Cricothyroid muscle, external branch of superior laryngeal nerve. So external laryngeal nerve. That is how the answer will be. Choice number C here. As you look at this question, mandibular foramen was there in the mandible and guarded by lingula. You were talking about mandibular canal, lower teeth. So lower teeth supplied by inferior alveolar nerve. Inferior alveolar nerve also supply lower muscles like mylohyoid and anterior belly of digastric because they are developing in first pharyngeal arch. It's a branch of mandibular nerve, trigeminal. So in this question, the answer will be choice number B. Anterior triangle of neck, they were giving carotid sheath, and then there's again image-based questions, ansa cervicalis, which muscle is not supplied. Normally, we teach this to PG entrance exam questions, means the students, not to the FMGE, but as you know, there are a lot of questions coming from NEET PG, INSCT also. So thyrohyoid is one of the answer because maybe sternohyoid or omohyoid or sternothyroid, they are all supplied by ansa cervicalis, a loop in the neck, but not the thyrohyoid. Thyrohyoid and genohyoid will be supplied by C1 fibers carried by 12th nerve, hitchhiking it. So here the answer will be thyrohyoid. See, all the muscles may be coming from sternum to thyroid or omohyoid. They are all supplied by ansa cervicalis. But genohead and thyroid, they'll be supplied by the C1 fibers carried by 12th nerve, hitchhiking it. Progressive dysphagia, regurgitation, halitosis, Zenker's diverticulum, inferior pharyngeal constrictor, inferior pharyngeal constrictor also, thyropharyngeus and cricopharyngeus. That is your answer. Choice number B should be the answer. We'll be doing detailed discussion later. GI endoscopy, physiological constriction, 40 centimeter from upper incision. So if it is 40 centimeter from upper incision, you know it is esophageal opening, esophageal hiatus. Choice number D is your answer. Anterior triangle of neck, bounded by anterior belly of digastric, midline of the neck, inferiorly by hyoid bone. They are talking about the submental triangle. So here the answer was submental triangle. Yeah, it is good that Dr. Dhawan discussed, because ENT plus anatomy, they are friends. A lot of questions overlap. Penetrating injury between cricoid and the angle of mandible, air bubbling, means maybe trachea is compromised. Immediate surgical exploration is to be done. You cannot wait. So choice number C, it is zone 2 as per surgical details. They're all image-based questions, as I'm telling. Most common for tracheostomy, it is you have to cut the isthmus, ring number 2, 3, 4, but more specifically, it is second and third ring. So it is 2, 3, 4. If you want to go for one answer, ring number 3. So ring number 3, needle compression. If it is needle compression, you can do cricothyrotomy. Then it will be cricothyrotomy. Then you can go just above that. If it is tracheostomy, then this is the answer. Drooling of saliva, difficulty swallowing, radiopoic, appearing like a full circle. If it is like a full circle, then you know it is esophagus, because in trachea it will be anterior-posterior arrangement of the vocal cords. So if it is like a full circle, then your answer will be esophagus. Yeah, okay. If they asked cricothyrotomy, that is your answer. No issue with that. Anterior interventricular groove, say if this is the heart, you are putting a marker here on one artery like this. That will be anterior interventricular artery. That is left anterior descending artery. So choice number B should be your answer, anterior interventricular groove. All of these things we keep touching in the class. So, and also they are repeat questions from the previous year topics. Cyanosis, clubbing, boot-shaped heart, tetralogy of Fallot. If you also have ASD, then it is not tetralogy, it will be pentology of Fallot. For pentology, you will add ASD. Otherwise, in tetralogy, you will have pulmonic stenosis. There will be overriding aorta. There will be this RVH also. There are 4 things. Right ventricular outflow tract will be compromised, because blood will be not only going from the left ventricle, but also from right ventricle. But ASD is a feature of pentology, not tetralogy. T of image. They are all image-based questions actually. Ductus venosus, they were asking shunting the blood, bypassing the liver. If you want to bypass the liver, left umbilical vein will come, bypass the liver by ductus venosus and join the inferior vena cava, draining the body below diaphragm, venous drainage. So it will join IVC when it was bypassing the liver. We are talking about left umbilical vein here. Yes, they might be giving X-ray, they might be giving cadaveric images. 40 centimeter from upper incision, esophageal hiatus. So T10 vertebra is the number. 15 centimeter, it is 23 to 25 centimeter. It is then 28 centimeter and 40 centimeter. This will be, even vertebral levels are required. So in this question, if they're asking esophageal hiatus, T10 is your answer. Hypertension, tracheal deviation, absent breath sound, tension, pneumothorax. If it is tension pneumothorax, immediately second intercostal space. Yeah, diagrams are given. Ajay, diagrams are given. Most of these are image-based questions. So tension pneumothorax, you have to do needle decompression, second intercostal space, mid-clavicular line. Fracture, surgical neck of humerus, the axilla posterior circumflex humeral artery passing the quadrangular space also. So it is axillary nerve with posterior circumflex humeral artery coming from the third part of the axillary artery. I'm not giving you, see, even if there is no such question, there is no issue. You can just go through the details. I know, because it is recall based question. Some questions students give, we prepare our own, we add our own details, and maybe questions have appeared or not. Your job is, because I have collected 31 questions, maybe some 20 questions came. The rest we have to manipulate the information to prepare the questions. ABCD mark was there. It was an X-ray, clavicle, coracoid process, manubrium, etc. So maybe it was scapula, acromion, coracoid process, clavicle, or maybe it was some question on your ossification centers. So yeah, questions may read differently. I understand, Ajay. So coracoid process is fused, but the acromion is not yet fused. This is more of a, you can say anatomy plus forensic. But if this is the presentation that the proximal humeral epiphysis has not fused with the shaft, then your answer will be 16 to 18 years. We'll be discussing the details later. This is just what rather than why. Why this is the answer. What is the answer is the job, my job at the moment, not why that is the answer. So just keep the answer. Permanent intraossei image-based question, mostly in PG INSET exam, but this time given to you also. So if it is permanent intraossei, pad, palmar for adducting the fingers. Especially, you have to move the fingers towards the middle finger because middle finger is the axis. Then bed of the kidney. This also, I think in your FMGE, there was a question on thoracolumbar fascia. When we teach thoracolumbar fascia, we'll be talking about these muscles. So yes, Ajay, pad and dab. So posterior relation of the kidney, medial to lateral, if you want the muscles, this is how the arrangement is. Psoas major, most medial, then lateral. So lateral most will be transversus abdominis. This is your answer. All the bold options, choice number C, wherever I have kept the bold, that is your answer. Massive upper GI bleeding. Again, all of these questions we keep discussing. As I'm telling, 70 to 80% questions are from what we teach. So gastroduodenal artery passing behind the first part of the duodenum, posterior perforation of duodenal ulcer. Choice number B should be your answer. 1 to 2-year-old child, intermittent groin swelling, more when the child is crying or putting strain. Yeah, if it is lumbricals, see, if it is lumbricals will be lumbrical 1, 2 are unipinnate, lumbrical 3, 4 are bipinnate. They originate from the tendon of FTP. So accordingly, you can, if it is lumbrical, then you will have MCB flexion and interphalangeal extension. So that will be your answer. So depends like which type of question was there. Here, this baby has indirect inguinal hernia. So patent process vaginalis, the intestine coming from the deep inguinal ring. It is basically a dislocation. The lower limb is shortened, flexed, adducted, internally rotated. It is a case of posterior dislocation of hip joint. We are going fast, very fast, in fact, the same speed at which you give your exam. Football, kabaddi player twisting injury, triple triad, basically. The medial collateral ligament, ACL, medial meniscus. So ACL tear, the anterior test positive, Latchman test positive. Most of these are previous year questions, in fact. Varicose veins, medial side of leg, anterior to which bony landmark, medial malleus, anterior and superior. Yeah, image based. Most of these are image based. That's all. So about 31 questions I have collected and we had to finish in time. That's all. All the best. God bless. Give us the positive news, happy news at the earliest possible. Take care. Bye-bye.
Hello everyone. Good afternoon to you all. I hope I am visible and audible. Yes, 60 plus questions from OBG. Okay. Yes, we had a fair share of questions this time. How was OBG, guys? Did you find it easy? Majority, I would say it was like moderate to easy level. All the questions were from our notes itself. I'm very happy to say that. And yes, even the rapid revision had a very good strike rate as such this time in ObGyn. I would say now they are shifting more towards the image-based questions as predicted, and also those conceptual questions rather than asking the direct one-liners. Those important core areas were asked, like the management, next step of management, or make you to identify from the core clinical concepts as such. We are going to discuss them one by one. Yes, all questions were notes. Thank you so much, Ria, for sharing that. Yes, easy. I'm so happy. Yes, saved me. Okay, thank you so much, Ria. Yes, so we will discuss the questions. I know you are just going through the questions. I am not going to do a very detailed review of the questions. We have time for that. We are going to come up with again a very detailed review. As of today, we are going to discuss the main questions and the answers so that you can just understand whether you got it right or wrong or whatever it is. Yes, so that you can just analyze your questions. That's it. We'll quickly have a discussion. There were nearly 30 questions from ObGyn. Initially, students were telling that the weightage were more from gynecology as compared to obstetrics. But once we got whole set of questions, I found that the weightage was still this time also slightly more from obstetrics. There was nearly 17 questions from obstetrics and 13 questions from gynecology. Probably as obs questions were slightly easier. Maybe that was the reason why initially it was not recollected completely by the students, and they emphasized more on the gynecology aspect. In gynae, there were areas which was heavily concentrated, like contraception, even the endometrial pathologies, endometrial polyp, endometrial cancer, endometrial hyperplasia, all these areas. There were some areas which were like heavily focused on. We are going to quickly discuss all of those. But in a nutshell, I would say if your concepts are clear, if you had gone through the previous year topics and the notes, it was a completely doable exam. So let's go through the questions one by one. Bluish discoloration of the cervix. Yes, I always say early pregnancy sign, you are going to get one question and an image of cervix is given. Even if you see that it's not bluish, even if you cannot appreciate the blue tinge, it is Chadwick sign. What is Chadwick sign? It is the bluish discoloration of ectocervix as well as vagina. So this was Chadwick sign. Apart from that, they have previously also asked the Hagar sign, the Goodell sign. All these have been repeatedly asked. Here, correct answer is Chadwick sign. Yes, cervix image is shown. That is Chadwick sign there. Even if that blue tinge you cannot appreciate also. Yes, such a relief by attending ObGyn. Thank you so much. Yes. So the next question. This was our classical string of pearl appearance, and they had given all the buzzwords for you right there. Hirsutism, delayed periods, patient has obesity, what more they can give, right? Yes, this is our classic PCOD or PCOS, polycystic ovarian disease. In the next question, which of the following is the most commonly used permanent sterilization method in female? As we discussed, the commonly used method is modified Pomeroy technique. We make a loop of the fallopian tube and you are going to put in 2 sutures, and the suture that is used is plain catgut. In contrast, older Pomeroy, they use this chromic catgut. Now the plain catgut is used. This is modified Pomeroy's technique. So this was the first question from sterilization. Okay, there were 3 questions. This was an image-based question from twin pregnancy. They had given this classical lambda sign. Lambda sign is there. Inter-twin membrane thickness is thickened more than 2 millimeters. This is typical of your DCDA twin. Whereas in case of a monochorionic twin, you are going to see a T sign. Yes, this is DCDA. Yes, dear. Lambda sign. This was the lambda sign. In the next question, again, this paper was so heavily image based. As you can see, this was also a much predicted question where they had shown you the classical snowstorm appearance. And where do you get snowstorm appearance? It is in complete molar pregnancy. A molar pregnancy topic itself start with this question, right? The complete mole, you have the snowstorm appearance, which is very typical of complete mole. Even you will see that partial mole is in the option. Partial mole, you don't see this diffuse proliferation of villi and this typical snowstorm. You have more of that focal proliferation of villi, and often it mimics a missed abortion. Here you can see that snowstorm appearance pointing towards complete mole. Yes, correct answer here is complete mole. Next question is from the menopausal chapter. Again, the hormonal changes in menopause. It's the first box that we learn again in menopausal chapter, as is the key hormonal changes. What will happen? The follicles are not developing. There is low levels of estrogen, low levels of progesterone. Low estrogen means no negative feedback. So levels of FSH will increase. Again, no progesterone means levels of LH will increase as there is no negative feedback. So high FSH, high LH, low estrogen, low progesterone. These are the key hormonal changes in menopause. Exactly, dear. Yes, exactly. So these are the key changes that you're going to see in menopause. Next question goes from our vaginitis. That vaginitis is always an asked question. Either candidiasis, trichomonas, or bacterial vaginosis. They always ask at least one question from this. In this, they had given you so many buzzwords. There is curdy, white, discharge on examination, KOH mount. You have budding, E cells, pseudo, hyphae. All those key buzzwords are there. This is your vaginal candidiasis. Vaginal candidiasis. Whereas trichomonas vaginitis, even there also you get itching, but difference along this, you are going to get the green frothy discharge, the strawberry cervix, all of those things. Bacterial vaginosis, there is no itching. You get the thin, gray, white, profuse vaginal discharge, and along with that, all the other buzzwords, Amsel's criteria, clue cells are positive. All those things are associated. Let's go to the next question. This was from the physiological changes in pregnancy. They had given a pregnant woman has come to you on examination. You hear an early mid-systolic murmur. Nothing else is there. No thrill, no heave, no other abnormal findings. So again, in pregnancy, there are so many changes which are quite normal and natural. These are the physiological changes. This is physiological murmur. We discussed that systolic murmur less than or equal to grade 3 is normal. We discussed that whenever you have systolic murmur more than grade 3 or diastolic murmur, presence of S4 is there. All these things are considered as pathological. This is completely normal. This topic came from physiological changes in pregnancy. Next question from our Anemia Mukt Bharat program. Yes, an ever favorite. This exact question was there even in the workbook as well. We had discussed that whenever a patient comes to you for in pregnancy, if you are giving a prevention dose, I'm going to give it once daily. That is for 180 days. 180 days antenatal, 180 days postnatal. And that itself, the dose is 60 milligram of elemental iron and 500 microgram of folic acid. Yes, so what is recommended as per IFA? It is once daily. But if they ask you regarding the treatment of anemia, pregnant woman has come to you, some of the students were telling this scenario-based question. This was recollected by few. Some were telling that patient had come with a hemoglobin of 8.5 or something like that, and they had asked the management. So in that scenario, she is having anemia. So whenever she has anemia, treatment of anemia is twice daily. You have to give it twice daily. So depending on the scenario, I just want you to confirm, was anemia given? Patient is anemic. Yes. So students have also confirmed that in the question, patient is anemic. So in the same question, patient is given as anemic. Now your answer shifts to twice daily. Prevention dose is once daily, whereas treatment dose is twice daily. Yes, patients are anemic. Thank you for confirming that, dear. So yes, so the answer is going to be twice daily. All right. The next question, this is from CTG. CTG, early deceleration, late deceleration, variable deceleration. This was again an expected question, how to identify. If you see that both of them are mirror images, it is early deceleration. But in this image, as you can see, contraction has happened. The deceleration starts after onset of contraction. Every time it is related, and the deceleration ends after the ending of contraction. Basically, there is a phase shift. Basically, the contraction has come there and it's waiting. The deceleration is late. This is typical of your late deceleration. The answer is late deceleration. Whereas in variable deceleration, you will see that there are no relation at all between the contraction and deceleration. Contraction apne time mein aata hai aur deceleration apne hi time mein aa raha hai. There is no relation between these two. That is variable deceleration. Variable deceleration actually has this abrupt fall. There is the sharp fall. Whereas early and late, you have a gradual fall and recovery. This is how you differentiate. First, look at the contraction. Second point to notice, how is the fall as well. These 2 points are going to help you to identify the type of deceleration. Yes. This question, again, this was the second question from the topic of twin pregnancy. They had given that a patient has come to you, first baby has delivered and second baby is in transverse lie. We always emphasize this information. What is the only and only indication for IPV in modern obstetrics? It is second twin in transverse lie. I will do IPV only for second twin in transverse lie. Again, in this, you can see the hand going inside. It was an image-based question, catching hold of the feet. This is internal podalic version. You catch hold of the feet internally and you are going to deliver it, followed by breech extraction. This is IPV, internal podalic version. Contraceptive contraindicated in hypertension patient. In the topic of contraception, we have discussed in detail the contraindication for OC pills, such as severe hypertension, patient who is having diabetes with complication, patients who are having severe dyslipidemia, migraine with aura, smoker more than 35 years, so many contraindication. Among this, as you can see, contraindicated in hypertension is OC pills. And as we always say, whenever you give OC pills, you have to take a brief history from the patient, rule out all these contraindication and only then give OC pills. Next time, if they ask the same scenario, they are asking what is the contraception of choice in a patient with hypertensive. Now your answer is going to be IUCDs. Now your answer will be IUCD. Why not barrier method? Barrier method has higher failure rate. So we are not going to choose that. IUCD at the same time does not have any systemic effects. So I'm going to prefer IUCDs. In this question, few of the students had read it very fast in the exam and they did not see this word contraindicated and few had marked IUCD. So that's the importance of emphasizing the words. This was a contraindication question. Answer is combined OC pills. But that happens in the stress of exam. If you are someone like that, don't worry. We only emphasize on those topics now which went wrong. So do not feel sad or dejected if you are finding only the wrong questions from this among this, or you're finding that you have more number of wrong questions. That is how the mind works. Whenever after an exam, we always focus on those topics that went wrong rather than so many of them which went right. Okay, so at this point of time, just go through the recall, but don't over stress yourself as well. Yes, this was a very classical question from primary amenorrhea chapters. The buzzwords are given for you. Normal breast development. There is absent pubic hair as well as axillary hair, and ultrasound shows that there is absent uterus and ovary. What is your diagnosis, guys? Your answer is complete AIS. Same scenario if it was Mullerian agenesis, they would have given breast is developed and pubic hair and axillary hair is present associated with absent uterus. Here, well-developed breast, absent pubic hair and axillary hair, buzzword for you to detect or diagnose it as AIS. Excellent answering is AIS. Now, in the next question, a diabetic woman who's on insulin, she is planning to conceive. Her HbA1c is 8.5. Yes, HbA1c is the best marker that you can do to predict congenital anomalies. The target one is 6.5. It should be always less than 6.5. That's the upper limit. What is the next best advice? Any pregnant woman who is not controlled with diabetes, you have to control her blood sugar. Yes, this is what we do. Any medical condition, you have to ask her to reduce HbA1c and then conceive only after that. She has to conceive after reducing HbA1c. Yes, in this question, a female has come to you with rectal bleeding every time she has menstrual cycle. Yes, the buzzword for you here is it is cyclical. Every time cyclically, if you have any symptom, what is the answer? Cyclical symptoms are there. Your answer is going to be endometriosis. Patient has cyclical hematuria. Patient has cyclical epistasis associated with menstruation, because all these deposits which are there at other parts of the body, they are going to bleed right at the time of menstruation. The cyclical symptoms, they are pointing to endometriosis. Yes, I hope you got that right as well. Yes, endometriosis. Next question. As we discussed, there are 3 questions that actually came from this endometrium related things. This was another question from your thickened endometrium. Patient has come to you with painless vaginal bleeding. She is obese. She has hypertension and there is thickened irregular endometrium. Based on these features, what is the most likely diagnosis among this? This is the corpus cancer syndrome, which can be associated with endometriosis, where there is obesity, hypertension, even diabetes. In a postmenopausal bleeding patient, your first diagnosis is C. endometrium. Yes, we had discussed the same question as the first topic in CA endometrium topic as well. Whenever you have this, or as we always say, whenever patient has postmenopausal bleeding, in Indian scenario, first differential is CA cervix. But once you have this obesity, hypertension, and especially in this scenario, they even give thickened endometrium. Now, there is no doubt your answer is CA endometrium. Next question, a female patient with postmenopausal bleeding for past 1 year, her endometrial thickness is 8 millimeter. And what is the next step in management? Yes, evaluation of postmenopausal bleeding. Any patient with ET more than 4 millimeter, what will you do? You are going to proceed with endometrial biopsy. Yes, correct answer is endometrial biopsy. Again, this was also our postmenopausal bleeding algorithm that we learned along with CA cervix, how to evaluate for cervix. Any patient with postmenopausal bleeding, first thing is evaluate for cervix. Cervix is normal, you take the pap smear. Cervix is abnormal, you take biopsy. If you see endometrial thickness is more than 4 millimeter, you proceed with endometrial biopsy. Yes. In the next question, a 42-year-old female has presented with intermenstrual bleeding. You are seeing that there is a well-defined area within uterus with feeder vessel sign. We always emphasize on this buzzword, feeder vessel sign. This is endometrial polyp. How will you manage endometrial polyp? The gold standard investigation is hysteroscopy, and management of choice is hysteroscopic polypectomy. Again, from the workbook question, we had discussed this feeder vessel sign, intermenstrual bleeding, hysteroscopic polypectomy. So many questions have come this time directly from the workbook which I have provided as well. So yes, I hope all of you did really well in all those questions. In the next question, a patient has come to you with 2 second trimester abortion and ultrasound is showing cervical incompetence. They showed this funneling with a short cervix. What are you suspecting? Anytime you have repeated painless T2 loss is there. T2 loss is there, your answer is cervical incompetence, especially in the context of a short cervix, painless expulsion in the second trimester. Yes. In this question, again, this was also provided in the workbook. Patient has come to you with an IUCD with bleeding and mild pain. The question that was given, we discussed, was only bleeding is there. The most common complication with IUCD is bleeding. Second most common is pain. Most common reason why the patient takes out the IUCD or removal of IUCD is pain. But this is only mild pain and bleeding. What will you do, guys? You will just reassure her. Tell her this is common. Even you can give her some analgesics for the same, and you are going to follow up these patients. Yes. So reassure and provide NSAIDs for the patient. All right. This question from the obstetric emergencies. Let's go through this question. A very nice scenario as such. Patient who is undergoing augmentation with oxytocin, artificial rupture of membrane is performed. On examination, you see after ARM there is fetal bradycardia. The head is 5/5 palpable, unengaged. That means head is high. What are they giving you? The buzzwords they are giving you after rupture of membrane. There is severe fetal distress. What is your first diagnosis? After rupture of membrane in a high head, there is sudden severe fetal distress or bradycardia. This is mainly because the umbilical cord is coming down. This is pointing towards a scenario of cord prolapse. The key pointers in this question, after rupture of membrane, there is fetal bradycardia. Again, there is high head. Now, the second differential will be placental abruption. Usually when it is abruption, they will not give this fetal head high, all these things in the scenario. Apart from that, bleeding can be associated with the patient. If it is a revealed abruption, yes. If it is a revealed abruption, there is going to be bleeding as well. I got confused between A and this thing C. Then finally choose A. Okay, I'm very happy here. Yes, I'm very happy. Finally choose A itself. Yes, the second differential which goes very close in this scenario is placental abruption, which can have similar findings. But usually if it is revealed one, there will be bleeding, and all the more reason to choose this. Head is not well engaged. When a head is not well applied, whenever you rupture the membrane, there is chance for cord coming out. All right. is the next question. A female who is undergoing cervical screening, her pap smear is abnormal. There is atypical glandular cells, no obvious lesions. Okay, if there is obvious lesion, I would have directly taken a biopsy. Here that's showing that there is atypical glandular cells after you did the pap smear. What will you do? Any pap smear abnormality is there, I will proceed with colposcopy and biopsy, especially as they are giving atypical glandular cells. Glandular cells can be either from cervix or from endometrium. So along with colposcopy, I will definitely check the cervix as well as endometrium. Colposcopy with endocervical curettage and endometrial biopsy. So any abnormal pap smear is there, your next management evaluation would be colposcopy. And depending on the type, we can add in the further subheadings like endometrial sampling to it. Biopsy was written. Yes. So best thing is colposcopy and biopsy. That was the option. The next best answer would be colposcopy and biopsy. Yes. If head is palpable, then why would it be cord prolapse? Okay. So imagine, yes. Imagine this is the baby's head, okay? This is the pelvis, which is way below. 5/5 palpable means all your 5 fingers can be kept above the head. That means head is high up. Once the head goes down into pelvis, you can't put your all 5 fingers over it. It will be like 2/5 palpable once it is engaged. Initially, it will be 4/5, then 3/5, then 2/5, 1/5, and finally 0/5. Nothing is palpable as the head goes down. Here, 5/5 is palpable or unengaged means head is high. Usually, we don't do rupture of membrane when the head is high. We only rupture the membrane once head has fixed, head has engaged. If you do artificial rupture of membrane in a mobile high head, what will come out? The cord can come out. Yes, again, the topic of cord prolapse risk factors, high head, mobile head, that is a risk factor for cord prolapse. Yes? Yes, exactly. All right. In the next question, this was again directly from our ectopic pregnancy, the indication or the contraindication for giving methotrexate. Whenever there is fetal cardiac activity, you will never give methotrexate. Beta HCG level more than 5,000 is a contraindication. Size of ectopic more than 4 centimeter. What will you do? All these scenario, I'm going to do surgery. Here, correct answer is presence of cardiac activity. We have discussed the indication for methotrexate and also indications for surgery. Whenever cardiac activity is there, it is an indication for proceeding with surgery. In this question, a 24-year-old female diagnosed with complete molar pregnancy, they asked regarding the management of choice for the same. What will you do in molar pregnancy? Treatment of choice is suction evacuation. And after suction evacuation, we can even give oxytocin infusion. How will you follow up these patients? I will follow up with beta HCG. For how many months? 6 months. Until follow-up is complete, contraception of choice is OC pills. All these are must-know one-liners. They always ask this. Molar pregnancy, 2 questions came this time. Yes, correct answer is suction evacuation. Sometimes they will give you DNC also in the option. Which will you choose, guys? Don't choose DNC. Uterus is very soft. We will proceed with suction and evacuation for these patients. Okay, so in this question, a 27-year-old primigravida has come in active labor. On examination, sagittal suture is felt in oblique diameter. Key buzzword here is posterior fontanelle is directed towards the sacrum and labor is prolonged. Yes, this is our do nothing, eat 5-star wala scenario. Yes, what is this scenario? There is slow descent of head. It is taking a lot of time to progress. What is the likely fetal head position? Whenever you are telling the position, look at the occiput. Occiput is anterior, it is towards the pubic symphysis, occipito anterior, whereas occiput is towards sacral promontory, it's occipito posterior. How will I know the occiput? It is depending, you can check the posterior fontanelle, which is closely related to occiput. This is basically a occipito posterior position. OP position, as we always say, takes a lot of time to deliver. Even if they ask you, what will you do next? Management is a commonly asked question, what will you do? Okay, eat 5-star, do nothing. Yes, you are going to wait and watch in this scenario. Wait and watch in this scenario. So correct answer, if I'm yes, this is occipito posterior. Depending on whether it is right or left, you can tell accordingly. The next question, I few of the students have recalled this question. There are two probability. Either there was a cervical incompetence they recalled again, but this was again, some students were telling they had asked the management also. This was again second question from cervical incompetence. Patient with 2 second trimester loss, ultrasound shows a short cervix. So if you have more than or equal to 1 T2 loss associated with short cervix, what is short cervix, guys? Less than 2.5 centimeter. We had written this as an algorithm also. What will you do next for the person? The next management would be cerclage. Your answer is cerclage. This is what you're going to do. Yes, you're going to answer it as cerclage, cervical cerclage. If you get only short cervix as an incidental finding, we will give progesterone. We have discussed 3 scenarios on this topic. If you get more than or equal to 3 T2 loss, always cerclage. More than or equal to 1 second trimester loss associated with short cervix, such as this scenario, cerclage. You get only short cervix, no other history is there. Just give her progesterone. Here, correct answer is cerclage. I hope all of you got this question, right? Okay. Yes, maybe, yes, even I feel, because these two questions are so similar, either this could be a recollection error, maybe they had given 2 questions, or it will be that one image question as an image-based question as such. All right. What you can do is, after the discussion is over, or in between also, if you have any new question or any additions to the question, feel free to let me know also. So I'll be waiting for your input as well. A woman in labor undergoing augmentation with oxytocin, there is sudden rupture of membrane, there is severe bradycardia. What is the most appropriate management? This is very similar to the crowd prolapse scenario. Bradycardia, all these things are there. Your answer is immediate delivery. You will deliver as soon as possible. And usually the mode of delivery is via cesarean section. Next question goes from postpartum. After delivery, you want to suppress the breast milk because the baby is stillborn. What drug are you going to give for the person? For breast milk suppression in postpartum, we generally give cabergoline. Even bromocriptine is given, but among these, which is the preferred management, we give cabergoline for the patients. We usually give cabergoline post-delivery to suppress the breast milk, especially when you have a stillborn baby. Correct answer is cabergoline. Which fruit is believed to cause abortion? And it is a misconception. This is a common misconception among the general population that if you eat papaya during the time of pregnancy, it can cause abortion. So papaya is the right answer, and it's only in very high quantities that causes this, and also ripe papaya, the effect is negligible. So actually it is considered as a misconception rather than an actual fact in this. So these were the questions. Yeah, finally one more question. Patient with heavy menstrual bleeding, uterus is diffusely enlarged, globular uterus. Just 2 days back, I had posted this image-based question in my Insta also, comparing adenomyosis and fibroid. Fibroid, you have this irregularly enlarged uterus, whereas adenomyosis, you have diffusely enlarged, globular uterus. You won't be able to appreciate the mass separately. Everything is enlarged as a whole, as you can see here. Even there is deposits of endometrium within the myometrium with bleeding inside. This is typical of your adenomyosis. So these were the 30 questions that I could get. Okay, students are telling that cabergoline was not given in the option. If cabergoline is not there, single best answer here is cabergoline. If it is not there, your answer is bromocriptine. Then your answer is bromocriptine. The single best answer, if cabergoline was there, definitely you have to choose cabergoline. If it is not there, next best answer you can choose in this scenario is bromocriptine. Yes. To differentiate fibroid as well as adenomyosis, fibroid, you will have this multiple irregular swellings, which is there. Majority of the students had given this image, which was a diffusely enlarged globular uterus. Totally enlarged, it is adenomyosis. Whereas in case of fibroid, you will see this multiple irregularly enlarged uterus. It won't be as a whole enlarged in case of adenomyosis. Yes. So if you have any more questions, you can share it to me. This is my Insta link as well. There was like 60 OBG questions, not 60. I wish there were 60 OBG, but yes, definitely there were 30 OBG questions. Till now, of whatever I could get, and I'm thankful for all of you to share me all those questions and give you your valuable feedbacks as well. And if anything else is there, please feel free to add the points and like send me the questions also. We would be doing a final complete recall Again, with all the extra points added, this was a brief overview of all the questions. I hope you found ObGyn very much easy and doable. That's all. Anything you wish to add or ask me? So I think more than 30. Okay. Thank you so much. So I'll meet you again. We'll have a detailed recall session also. I think Vandana ma'am is waiting with the next session. So I'm going to leave with that.
Okay. So hi guys, I'm sure you would have done your FMG paper well, and thanks for sending questions to us. And this is just a recall session. I hope this recall helps you to know how you've done. But although whatever is said, you have done your paper well. Now it's a time to relax, and whatever is done good. So whatever will happen according to the God's wish. So don't worry on it. And with that, let's start today's recall. We'll do it quickly so that at least you should know what are the answers to the questions. Okay. So coming to the first question. So this is a very typical question. The typical question says that this was a tall male presenting with the disproportionately long arms, arm span is longer, arachnodactyly, upward lens dislocation, also aortic root dilatation is given. A very typical history which suggests you that you're dealing with Marfan syndrome. And all of you know Marfan syndrome is because of gene defect in FBN1, which codes for fibrillin. So there is a defect in fibrillin gene here. So you remember that. So that is fibrillin here, and this is Marfan syndrome. Okay. Collagen type 1 defect is osteogenesis imperfecta. Coming to the next question, this is a 12-year-old child presenting with progressive abdominal distension. This was one of my jinx question also. I posted this question on the Instagram as a jinx question for FMG. This came in the exam. I'm happy everybody knows this. This is Gaucher's disease, and this is crumpled tissue paper appearance, and one of the very frequent PYQ also. So remember, this is Gaucher's. I hope everybody did this correctly. Coming to the next one. Now, this is a tricky question here. So there are some recall error, what I feel is there in this question, but still. So the patient typically gives you an history of curdy white discharge, but they have given you microscopically clue cells along with the budding yeast and hyphae. So something is wrong here. Some abnormal recall is there. Remember, curdy white discharge with budding yeast and pseudo hyphae will take you towards candida. Okay. Whereas clue cells will take you towards Gardnerella vaginalis or bacterial vaginosis, and absence of lactobacilli is the strongest suggestion. So it cannot be both of them. So what I feel, there is a recall error. There is no clue cell. If there is no clue cell and it is a curdy white discharge with budding yeast and pseudo hyphae, it is candidiasis. So remember, they can also give you as an image-based question. So if you see spores and pseudo hyphae, this is candida. Whereas when you see clue cells here, this is bacterial vaginosis. Both of them usually do not coexist, but if it does, it is called as, what is this called as? Mixed vaginitis. Okay. So definitely there is some recall error in this. Think about it. What was the exact question? Okay. So if they've given both of them together, then it is mixed vaginitis. If it is only curdy white discharge with pseudo hyphae and the spores, then it is candida. And if it is only clue cells, then you're dealing with bacterial vaginosis. So that pointer should be very clear here. Okay. Coming to the next one, a middle-aged woman presents with weight gain, cold intolerance, and painless thyroid enlargement. So weight gain, cold intolerance, okay, pointer towards hypothyroidism. Painless thyroid enlargement also points towards some autoimmune thyroiditis. So this is very typical history of Hashimoto thyroiditis. I hope you remember this, and this is one of the repeat questions which I have also posted in a lot of quizzes again and again. This is one of the questions which always is asked. So whenever we are talking about Hashimoto thyroiditis, it has to be anti-thyroid peroxidase antibody. Graves' disease has anti-DSH antibody. Primary biliary cholangitis has anti-mitochondrial antibody, and SLE has anti-double-stranded antibody. All of these are repeatedly asked questions. They are PYQ, and I'm sure you would have done this correctly, right? Okay, coming to the next one. Which of the following is an IHC marker of neuroendocrine tumor? Again, a very, very tentative PYQ. We always remember chromogranin. We remember synaptophysin. We remember NSC. We remember INSM1. Okay. So all these are very, very important IHC marker of neuroendocrine tumors. So that is what are the neuroendocrine tumors, which you have to be very, very clear. S100 is positive for melanin and nerve tumors. Okay, so nerve tumors. Cytokeratin is for all the epithelial tumors. Napsin A is for adenocarcinoma of lung. Okay, so that pointer should be very clear here. Okay. Coming to the next one, so the hemat constituted nearly 1/3 of the pathology questions. So I'm sure you would have answered this correctly because this is one question which we keep practicing again and again. So this was an image where the OR rod was shown, and irrespective of the history, there were more than 20% blasts that were given and OR rod. You don't need to think anything else. This is very typical acute myeloid leukemia. They have also given that they're CD19 negative. That means this is not B cell ALL. Okay, so that is why the answer to this is just AML. Okay. Now coming to the next, this is a 24-year-old pregnant woman and her hemoglobin is low, that is 9, on antenatal. Peripheral smear was shown, and what do you see in the peripheral smear? What was shown here? So these were the target cells. You can see there is a central hemoglobinization and there were nucleated RBCs. Looking at this, you know that you're dealing with thalassemias. Okay, so this is probably a case of thalassemia here, which you know, this is thalassemia. And also many times in repeat exam, they have also given Menzer index. Okay, if Menzer index is less than 13, it is very suggestive of thalassemia. That's another PYQ that is asked. Okay, so that is your thalassemia, which you should be clear. What should be the next investigation? Hemoglobin HPLC. Okay, a perimenopausal female presents with abnormal uterine bleeding, and this was a tricky question which came this time, and it was more of a histopathology question. There was an enlarging mass in the uterine wall. HPE from endometrial biopsy is shown, and what is it? So what catches your eye here is these spindle-shaped cells. Okay. Again, if you look at these spindle-shaped cells here, so we have also covered in the video, also in the gynae, and also on Instagram, I've posted this so many times. So whenever you have these spindle-shaped cells with blunt ends, okay, so all of them have blunt ends. So these are called cigar-shaped nuclei. So cigar-shaped nuclei, that is spindle cells which interlace into one another with blunt ends, with cigar-shaped nuclei. This is very characteristic of leiomyosarcoma. Plus, you are seeing a lot of pleomorphic cells. A lot of pleomorphic cells. Some are smaller, some are bigger, some are darker, some are lighter. Pleomorphic cells, along with spindle-shaped appearance, that nearly seals your diagnosis of leiomyosarcoma. They can also give you areas of necrosis in this. Remember, so what is the typical feature of leiomyosarcoma? So they are made up of spindle-shaped cells and man. Okay, so this is like Spider-Man. Okay, so they are spindle-shaped cells with man-made mitotic activity, atypia, and necrosis. Okay, endometrial carcinoma will have glands in them. Rhabdomyosarcoma does not occur in perimenopausal age. This usually occurs in children. Okay, and they usually have small round cells. Okay, so small round cells. Endometrial stromal tumor are also made up. They are also very important. They have finger-like projections into the myometrium, and they are also made up of very vesicular rounded cells. Okay, and they have prominent vascular arrangement. So these tumor cells try to arrange themselves around the blood vessels. So that is your endometrial stromal tumor. So the answer to this question is leiomyosarcoma with such spindle cells. You don't think of anything else except leiomyosarcoma. Coming to this, accumulation of glucocerebroside indicate dysfunction of which organelle? So this is again very classical. We teach you so many times. So whenever we have glucocerebroside abnormalities, they all accumulate in lysosomes. So they are all lysosomal storage disorders. That is why the name itself says lysosomal storage disorder. And Gotcher's or Niemann-Pick, all are lysosomal storage disorder. Paroxysmal defect is basically seen in Zellweger syndrome. Okay, so Zellweger, that is one only. Golgi is only dealing with protein, folding properly, and mitochondria has only oxidative phosphorylation defects. Okay, so the answer to this question is lysosome. Coming to the next question, again a PYQ asked so many times, people got confused that ma'am why HCG is elevated. So remember, I've told this so many times in that in seminoma, sometimes you can have some syncytial trophoblast which can secrete HCG. So HCG can be a marker of seminoma apart from choriocarcinoma. So that's one point you have to remember. Apart from that, the typical morphology of all these clear cells and the septa containing lymphocytes is so suggestive. Okay, all watery clear cytoplasm with septa containing blue cells, that is lymphocyte, it is seminoma. So that is it. So seminoma is the marker here, and definitely it will not have any other tumor marker except it can just have mildly enlarged, mildly increased HCG levels. So that's seminoma. You know, York-Sac tumor will have alpha fetoprotein. Teratoma is no marker, but it will have totipotent cells, hairs, and everything coming out. Embryonal carcinoma, very rare. Usually nothing is asked except that it is CD30 positive. Okay. Coming to the next, patient presents with episodic hemoglobinuria, anemia, and thrombosis. That's a typical triad. I hope everybody remembers in PNH, we have a typical triad of PIT. What is PIT? So there is pancytopenia. They can have pancytopenia. They have intravascular hemolysis. So there is hemoglobinuria and thrombosis. So whenever you see this typical triad, you know that you're dealing with PNH. Okay. So here also you can see intravascular hemolysis, pancytopenia, so anemia and thrombosis. This is PNH. Also, they have given you such a strong clue that what is the diagnosis of choice? Flow cytometry. That is, there is absence of CD55, 59 and flare. Okay, so that is the diagnostic method of choice. So that is PNH. PNH is a complementopathy. There is a defect in the PIGA gene, which codes for complementary regulatory protein, that is DAF and MERL. So it's a complement regulatory protein defect. So therefore, you have to give a drug which manages the complement, and the drug here that was given was eculizumab. Prednisolone is no rule here. Prednisolone is given as a first line of therapy in ITP patients. Hydroxyurea is the first line of therapy in CML patient. Rituximab is basically given for refractory autoimmune hemolytic anemias or B-cell lymphomas, which are CD20 positive. So that is the therapy here. So ruling out itself would have given you a strong choice of marking a correct answer. Right. Okay, so what is the gene abnormality of Burkitt? So there are two recalls for this question. So one was that simple Burkitt was asked. This we have discussed so many times. Burkitt looks like 8. So everything with 8, 14 is Burkitt lymphoma. Some people told, no ma'am, this was the question that was asked, whether which of the abnormalities is associated with Burkitt. So obviously it is translocation. It can be 814, it can be 28, it can be 822. What is common in all these three is 8, which has c-MYC in them. So that's a very typical pointer here. Now, this is a 45-year-old male, presents with fatigue, weight loss, and abdominal fullness. Examination shows splenomegaly, massive splenomegaly. So here clue is first 45-year-old person, massive splenomegaly. Apart from that, there was leukocytosis with shift to left. I've told you this so many times. Whenever they give you this line, leukocytosis with shift to left, think of CML. Bone marrow is hypercellular. And what is a so they are expecting you to know that there are diagnosis is CML. So what is the first line therapy for CML? It is always and always tyrosine kinase inhibitor, that is imatinib, because the rule hallmark mutation for this is BCR-ABL, which activates tyrosine kinase pathway, that is P210 domain of the tyrosine kinase pathway is activated. So transcript is P210, which activates the tyrosine kinase pathway. So therefore you have to give a drug which can block tyrosine kinase, and that drug is basically your imatinib. So that is why the drug of choice for CML is imatinib, that is a tyrosine kinase inhibitor. Okay, right. So we have already talked about the CML, how to pick it up. Leukocytosis and left shift and massive splenomegaly will take you to CML. Now let's go to the next one. A patient presents with parathyroid hyperplasia and pancreatic neoplasm. Okay, so I have told you this so many times also. There is a very typical code which I keep telling you, pyara parpit. Okay, so whenever you have pyara bacha who is having pancreatic and pituitary lesions, this is typically MEN1. MEN1 is typically associated with mutation in menin gene. Okay, so as soon as it becomes MEN2, pyara is decreasing. Okay, and pyara still is there in MEN2A. Pyara is still there, but medullary medullary and pheo will come. So because he goes to the medical school, so medullary carcinoma is there and pheochromocytoma is there. So MEN2B is associated with just medullary and pheochromocytoma. Pyara finishes. So MEN2 mutations are associated with RET mutations. MEN1 are associated with, they are associated typically with MEN1 mutations. So this we have discussed it so many times. This is just a snapshot from the workbook itself, right? So that's MEN1 and MEN2, which you should be clear. Now, patient presents with bleeding tendency. Now, this was something which was tricky. Only if you have understood the concept, you would have been able to mark this correct. Look at the factor 8 levels. It is 50%. It is low, but it is not very low. PT is normal and APTT is high. So remember, whenever APTT is high, either it can be factor 8 deficiency or it can be von Willebrand deficiency. So how do you differentiate it? So first, factor 8 is not very low. Number 1. Number 2 is ristocetin test. So ristocetin, if it can cause adhesion. So if ristocetin, okay, ristocetin basically can cause adhesion, then it is either GP1B defect or it is von Willebrand deficiency. So here the term that was given as ristocetin induced platelet aggregation, if this was the same thing in exam that was given, ristocetin induced platelet aggregation is very typically seen in von Willebrand disease. So that is very, very typical of von Willebrand, especially von Willebrand 2B. That's very classical here. So if they've given this term REPA, okay, so that is very, very typical of von Willebrand 2B, and the answer will be von Willebrand disease. Okay, so then your answer will be von Willebrand disease here. So remember, factor 8 level is mildly low, APTT is very high, and REPA is positive, then your answer has to be von Willebrand disease. So that is your von Willebrand disease here, which comes as the answer here. Okay. So if they say ristocetin does not cause ristocetin does not cause aggregation of the platelet, so that is a different term from REPA. REPA is a very particular term. If they use this is basically von Willebrand factor 2B if it is positive. Okay, so the answer is B, von Willebrand disease. Coming to the next, a patient presents with the complaint of headache, and the patient also has presence of Antony A and Antony B areas, and IHC is typically given. So this you all know, this is typical schwannoma. And nerve tumors, we have just now talked also, nerve tumors are always positive for S100. GFAP is typically positive for glioma. CK is for epithelial tumors. Vimentin is for mesenchymal tumor. Nerve tumors are always positive for S100. Again, I have taught this so many times, okay? Now, coming to this is a very classical jinx question. So, Shival dual body. This was also a jinx question which I posted on my Insta that this can come in exam. So, Schindler dual body is very classical for your yolk sac tumor. And we know that yolk sac tumor will typically produce which tumor marker? That is alpha fetoprotein. So, the answer here will be alpha fetoprotein. This is also called as endodermal sinus tumor. Remember that point. Okay. Look at this. This is a 22-year-old male presents with anemia. The peripheral smear is shown and the reticulocyte count is very high. Here, what is the diagnosis? So this is a hemolytic anemia. Now, in the option, you have two hemolytic anemias that were given to you, sickle cell anemia and thalassemia. So what is the answer? So thalassemia also, they had given thalassemia trait. So remember, thalassemias never increase the reticulocyte count. Even though it is a hemolytic anemia, the reticulocyte count is not increased to the degree of anemia. Why? Because there are a lot of cells are dying in the bone marrow itself. So that is why the reticulocyte count is not very high. So that's a rule for thalassemia, which I've already taught again so many times to you. So this is classical hemolytic anemia. So it has to be sickle cell anemia. Aplastic anemia, bone marrow doesn't have any cells. So it is decreased reticulocyte count. Iron deficiency anemia will have normal to low reticulocyte count. Thal trait, I just told you, it remains normal. Retic count remains normal. Okay. So the answer to this question is sickle cell disease. Okay, let's come to this question here. This is one of the repeat question which is asked again and again. And we typically know the tetrad, that is PAR. Okay, so whenever they give you history in a child who presents with purpuras, number 1. Number 2, arthralgias, joint pains. Number 3, abdominal pain. And number 4, renal involvement. You should always think of henoxol in purpura. And that is what was given here. So the typical history that was given here was purpuric, the patient had purpuric rashes, a joint pain, abdominal pain, and the rashes were shown here. This is so typical of HSP. Okay, that is HSP here. Coming to the next one. So here they had given you teardrop cells here, and they had typically asked you what is the next investigation. So whenever you see teardrop cell, that means there is a bone marrow fibrosis going on. And whenever you have bone marrow fibrosis, bone marrow aspirate will give you dry tap. So therefore, you should always go for bone marrow biopsy rather than aspirate. So here it is bone marrow biopsy that will give you the diagnosis. Okay. Coming to the next one. So this was typical popcorn cells that were given, and they asked you which type of Hodgkin it is. So I hope everybody remembers this is lymphocytic predominant Hodgkin's lymphoma, which will show you the classical popcorn cells. Okay. Now coming to the next, a young woman presents with dry eye, dry mouth, okay, and fatigue, no history of diabetes or drug intake. So this is very typical of Sjogren syndrome. We know it's dry eyes, dry mouth, and it's an immune-mediated disorder. Again, we have studied about it so many times. Sjogren and SLE and lichen planus, and these are some disorders which they keep on asking, and scleroderma are 4 disorders which are repeatedly asked again and again and again. So remember, SLE, Sjogren syndrome, sclerodermas are very commonly asked in the exam. So that is why you have to be very, very clear with it. Okay. Now, this is the last question. I think a patient presents with premature aging. So this is a premature aging and early onset atherosclerosis and typical progeria. So they're typically asking you, what is a gene mutation in progeria? So we have already talked about this. So the progerias can be of 3 types. Okay, so whenever we talk about progeria, either it can be a typical progeria, but it can present in infancy, and it is non-inherited. Usually there is a sporadic mutation in LMNA. So this is what is called as Hutchison-Gilford syndrome. What is this called as? Hutchison-Gilford syndrome. The second kind of progeria is usually called as adult progeria syndrome. Why is it called adult progeria syndrome? Because here the symptoms will start presenting in adolescent age. Okay, so the symptoms will start presenting in adolescent age. This is basically your Werner syndrome, which has typical mutation in WRN gene. So this is basically infancy. So it has to be LMNA mutation, because that is what is called as Hutchison-Gilford syndrome. Okay, so third option we are not sure about. What is it? So that is about LMNA, and Werner is basically defect of DNA helicase, and therefore it usually presents in adolescents. Okay, so that is about your progeria, which everybody should be super duper clear with. And with that, we finished the recalls. This was your pathology recall. I hope you did more than 70% questions correctly, and I'm sure you'll come out with flying colors. See you on the other side of the table, guys. Bye-bye.
Am I audible, visible? All good? Yeah, I think we are good to go. Yes. So, hello, dear friends. Very good afternoon to all of you. And I am really, really happy to see the number of questions they asked in Opthal. And they were all doable questions. And I'm sure the exam was good at your end. I have not seen a single student like who's sad, or everybody seems to be jovial and happy about their performances. But yes, let's talk about ophthalmology. So guys, I was told that there were a lot of images. Every other question was an image-based question, not even in pathology, but also in ophthalmology. So there were a lot of image-based questions. And I got a lot of feedback that most of the questions were there in the short images we discussed the other day. So, because image gives you a lot of pictorial memory. So I've got a lot of recalls from the students. So thank you very much, all of you, to help me building this recall session. So guys, we'll quickly go through the questions. Some of the students are saying there were 20 plus questions, but what I could gather was only 17 questions. So guys, if you get more after this discussion, kindly help me with this recall. So yes, a lot of questions. Optaka paper was like a GT paper. The only thing that I would mention is that
though there was the picture based question, but they are not straightforward asking you the diagnosis. Actually, they are asking you how to diagnose and what are the buzzwords about that, what things you should know about the treatment. So you have to read the entire topic. Cramming again is gone, guys. You cannot just cram, है ना? So you need to know everything about the topic. So there were more of PYQs only. Let's start with the first one. So I've got this image and it says, what is the best treatment if you have a small boy with itching in summers? So first of all, if we have small children, boy itching summers, can I say it is definitely a case of VKC? Yes. And the picture here is given about the Horner Tranta spot. So you know this is Horner Tranta spot, a image based question, and definitely the treatment is a combination drug, oral antihistaminics plus mast cell stabilizers. But what they have given you, they've given you oral antihistaminics. No, oral we are not giving. Rather, we give topical agents, topical mast cell stabilizers. And for initial control, definitely we can start with topical steroids as well. So this is the best thing. Surgery का कोई जरूरत ही नहीं है, not required. Usually we give olopatadine, that is a combination drug, topical mast cell stabilizer and antihistaminics, but steroids can also be given. So this was the best one. Yes, but now there's a little twist. Some students are saying probably this was the picture, and some students are saying there was another question on the Herbert pit. So suppose if this was the picture, there are Herbert pits, you can easily identify them as flat healed scarred follicles. If this was the picture, then definitely the answer is trachoma here. है ना? So this was it. Probably this was another question. Guys, help me with this if you had this image or not. Now, the next question. Papile the, okay, ठीक है. So it was Horner Tranta only. Now the next question. This picture was given, guys, so many times. We have discussed Munson sign for keratoconus, isn't it? There is a notching of lower lid. So all of you could identify this very easily. This is a case of keratoconus, right? Now, instead of asking you the diagnosis, they have asked you how to diagnose a case of keratoconus. So this is simply by pentacam topography. है ना? We have read that pentacam is done, topography is done, and this topography, corneal topography is the one which gives you the diagnosis for keratoconus. So it was a very simple question. Keratometry can be done, but the best is topography, corneal topography by pentacam. Okay, I gave you a green colored map now. Green colored, you remember? Green and red color. I told you red color is danger, green is good to go. So this was the thing which we read. Okay, now the next one. So this was a little tricky question for few students, but those who have done classes, those who have read, they must be knowing that for any refractive surgery, forget about LASIK, for any refractive surgery, the age should be more than 18 years, isn't it? So age less than 13 is definitely a contraindication. It's an illegal thing to do LASIK or any refractive surgeries because the refractive error is not stable. Now I got few students who told, Madam, हमने ये लिख दिया, बच्चा, it was 450 if you remember. So if the corneal thickness is less than 450, then we do not do LASIK. But the better answer here is age less than 13 years. I think this was right for most of us. Yes, refractive error 14 a year, refractive error more than 8 diopters can be a contraindication, right everyone? So this was easy. Now, there was a question on festooned pupil also, है ना भाई? पर उन्होंने कुछ और ही पूछ लिया. Apart from festooned pupil, the picture question, probably they have given you these many options. Which glaucoma is seen in festooned pupil? So guys, first of all, festoon pupil क्या था? You remember? गुब्बारे जैसा, clown जैसा, है ना? So this was a picture of festoon pupil. Now guys, if you have a patient of festoon pupil, you expect a secondary glaucoma. So primary angle closure, open angle तो बिल्कुल भी नहीं है. And pseudo exfoliation glaucoma तो बिल्कुल भी नहीं है. So what are you left with? Acute uveitic glaucoma. If you've used a little bit of common sense, guys, you could have answered it easily. Festoon pupil किसमें होता था? We have learned that festoon pupil is seen in uveitis, isn't it? We have learned that festoon pupil is seen in uveitis, right? So if it is in uveitis, the term will be a uveitic glaucoma. ये पूछा था ना? I think this was the question. festoon pupil mein which type of glaucoma was seen? So this is acute uveitic glaucoma. Remember, we have read this earlier, and you need a little bit of brain here. It cannot be a primary angle closure and open angle glaucoma. Okay, beta? Now, this was a question very simple because we have learned so many images on oculoplasty. Okay, I told you one question is going to be there. है ना, ankyloblephron, symblephron, trichiasis, distichiasis. So this time they have given you a question on symblephron. Kindly see the adhesion here. Can you see the adhesion? So this is very common after chemical injuries, or you can see this in case of severe dry eye, Sjogren's may, Burns may, pemphigus, and so on. You know, severe dry eye can lead to this, and chemical injury, of course. So this is a very nice picture of symblephron, a very easy question from my side. Okay. Chalo. Now, guys, this was a repeat question. Same question was there in NEET PG exam. So you must have read. This is a picture of dermoid cyst. In our CPR, we have done this picture. है ना? और surgery में तो पढ़ा ही है. What was dermoid? Dermoid is nothing but a choristoma which is present at the junctions, the suture line. We have also read about dermoid cyst of the limbus. तो यहाँ पे उन्होंने आपको repeat question पूछ लिया. It's a beautifully repeatedly asked question. I will say dermoid था, है ना? So very simple. I would say 100 marks for that. Very simple, a PYQ. You could not have missed that. Now, guys, again, I told you we'll get one question from thyroid. I have told you from my last checklist also, and this was one question. Now, guys, few students are confused. They say, ma'am, why not orbital cellulitis? But please remember, we have discussed so many times, the most common cause of proptosis in adults has to be thyroid unless until mentioned for about anything else. So can you see the lid retraction? Isn't it? There's a lid retraction, marked lid retraction, proptosis, restriction of movements. This cannot be anything else. Hai na, bacha? So this was very straightforward. This was a case of thyroid eye disease. Most common cause of unilateral, bilateral proptosis in adults is thyroid until unless mention something else. So this was again good and a straightforward question. Guys, this was there in trauma. Now, if you have no idea about what this is, use your common sense. So this, they said that there is an injury in a baby's eye with a ball. There's a blunt injury and there is nothing but blood collection in anterior chamber. And what is this term? This is called as hyphema. Even if you do not know what is hyphema, you should be able to answer. Because iridodialysis तो नहीं, iridodialysis was a PYQ. There is a D-shaped pupil. Hypopyon is white pus in the anterior chamber. So what are you left with? This is our hyphema. Very, very simple. है ना बच्चे? Vitreal injection was given. Transilluminance negative. Acha, this was the information which was given. Please tell me. Transillumination negative. Ha, bilkul the dermoid matches with transillumination negative. I am adding the information what you are giving. Bolo bache, thank you. It says that it is not transilluminant. Very good. Thank you. And anything else? Vitreous hemorrhage was given. Okay. So yes, you can also have a vitreous hemorrhage together. Yes, you can have. But this is not a vitreous hemorrhage. This is a hemorrhage in the anterior chamber, isn't it? This is hyphema. Okay, you said vitreous hemorrhage ka question alag tha. There was a different question on vitreous hemorrhage. Okay, that may be a question. Please write down the proper question if you have, beta. It would be of help for me and for the others. All right, the next. So guys, this is the only ectopic question which probably you are not able to answer because this is not, we are teaching in our regular classes. Okay, this is called as Jackson's cross cylinder. But I'm very happy that few days before the exam, I shared the video of GCC in the my WhatsApp group, and I've shared with everyone because I, you know, some kind of belief I had that this could be there in the exam. So I've shared a video about Jackson's cross cylinder, that this is JCC. It is a cross cylinder which is a combination of two spheres and cylinders. Either it could be 0.5 or it could be 0.25. So you have two cylinders on opposite meridian. This is mainly used for refinement of prescription what we have given. Suppose I have given a prescription plus 2 diopter sphere and plus 2 diopter cylinder. But I want to refine it. It could have been plus 1.5 diopter cylinder. It could have been plus 2.5 diopter cylinder. So for refinement, what is the best suitable for my patient? I can use this JCC. This is mainly for refinement of the cylindrical prescription. Okay, beta? So this is it. Now, the next one. So guys, this was a little tricky question. Some students are saying, madam, there was an image of exotropia also. Okay, if there is an image of exotropia given, the answer will become this. But if there is no image of exotropia given, the answer will become anisometropia. So guys, you have to tell me, was it an image-based question, beta? Was it an image-based question? If this happens to be an image-based question, the answer totally differs, because this question is suggestive of one eye being normal, other eye being abnormal. And there is a marked difference also. There is a difference of 4 diopters in the prescription of the glass. And if it says that there is a squint, then this is definitely a case of amblyopia, which is because of strabismus. So guys, this involves a little bit of brain. Okay, you know what is anisometropia, you know what is amblyopia, you know amblyopia can be due to strabismus also. So help me with this. Okay, this was image based. If this is image based question, then definitely the answer will become a strabismic type of amblyopia. There is a poor vision because this patient has strabismus. Okay, I hope you have understood that. ये भी मिला था क्या? ये भी था. Was 4 diopter given, guys, here? Okay, it was a deviation on medial side. Okay, so there, okay, on you marked esotropia. No, it was not esotropia. No, it was not esotropia. Bache, please read the question well. Don't just look at the image ke esotropia hai. Read the question na. Vision has not been improved. Isn't it? Vision is still very poor. So can I say it's a case of amblyopia? Hai na? And I told you amblyopia will be there when I was taking classes, because amblyopia is now very frequently asked. So remember, listen to your the rules and isometropia. Chalo, let's move to the next one. Let's hope you have marked the best answers, what you know. Now guys, there was a picture question which is suggestive of uveitis. Dekho, some students are mixing it with festoon pupil wala question. But I think there were 2 questions where in one question, they have asked you investigation. So can I say this is a picture where we are shown KPs. Now, agar KPs hai, to what is the diagnosis? Straightforward, the diagnosis is uveitis. And for uveitis, the best one here is HLA-B27. Okay, etiology of uveitis was one of the most important topics in ophthalmology. I hope you remember Puri. मैंने कहा था Puri को याद करना, angel को याद करना, और देखो we have this answer. Okay, ठीक है, everyone, if this was anisometropic amblyopia, okay, listen to me. Let's solve this question again. See, if it was an image-based question and there was also a esotropia, okay, this should have been a strabismic amblyopia if this was an image-based question and there is a strabismus. Right, everyone? Okay. Now, the next one, a very straightforward question. Please remember, this is a case of dendritic ulcer, but this time they have asked you how to treat it. So antibiotics have no role. The treatment here is topical acyclovir. We have discussed so many times, atropine has to be given to relieve the pain, to relieve the ciliary muscle spasm. So it was a straightforward question. I think there should not be any problem here. है ना? They first mentioned amylase was also there. Acha ji, serum amylase. तब भी answer ये नहीं है ना? तब भी amylase is not the answer. The best is HLA-B27 here. है ना? Thank you very much. So topical acyclovir, oral acyclovir should not be given, not required here. All right. Now, guys, this was a question. Many students, fumble and they could not find out the answer. But the history of cataract surgery is given. And there was something which was going down. So you could have used the common sense. Abhi cataract surgery ke baad kya ho sakta hai? You can have this, but if the lens is going down, this should be a picture of lens subluxation, isn't it? Yes, everyone. This was a very straightforward question. Very straight. मैंने यही बोला बच्चे, question अच्छे हैं, बहुत अच्छे हैं, मेरे लिए बहुत अच्छे हैं. But again, you need to use your brain. Okay? So just do not mug up the things they are getting into very clinical, very focused and very clinical things. Yes, image has a lens subluxation. Very nice. Now, I got a question where they have given you a long history suggestive of pterygium. That was the question which was not picture based, I hope. And they have asked you what is the best management. So, ये तो PYQ है ना? You give a treatment, a surgical treatment, excision and autografting. This was the only trick here was it was a long question. So some students couldn't read the question well. है ना? This was the only thing. ये तो बहुत simple question आया था मेरे ख्याल से. Now, guys, one question I could also see where they have given you a question where there is a picture of pupil like this, and they have given you a history that there is a patient with redness and pain, and you have given a drug to break the synapse. I think this was the word. ये था ना? To break the synapse. So which drug will be given to break the synapse? So guys, what are we using? Atropine करते हैं ना? We are not using phenylephrine or any other thing to break the synapse. You remember, in case of uveitis, topical steroids are given. With topical steroids, the most important one is atropine-like drugs, because we want to dilate the pupil. We want the synapse to be broken. है ना बच्चे? Treatment for something, okay, for stopping recurrence. For stopping recurrence, okay. And this was image-based question, na? But ये image-based question था ना? It was an image-based question, if I'm not wrong. Treatment for something for stopping recurrence. Yes, atropine will be the answer then also. Okay, same kind of image. Thank you, thank you. And the next one is about CRA. Oh, very simple, straightforward question. फिर से उन्होंने cherry red spot पूछ लिया, है ना? There was a patient where there was a sudden loss of vision and retina shows this image. So what is the diagnosis? Very straightforward. The answer was CRAO, because this was the picture on cherry red spot. Okay, cherry red spot. इसमें भी image थी. Was this also an image-based question? Pterygium. Oh my God. Oh my God, all images, my God, all images. I think I will be teaching you more images and images now onwards, okay? So guys, thank you for all your inputs. We are lucky to have students like you, that we are in lectures, but still all the students contributed and helped us with the recalls. And I'm very happy with the response I got from my students. They're very happy doing ophthal and CPR and the last images and all, this helped a lot. So again, my dear students, this time we have learned that if you do study properly, है ना, shortcut chalega, but still you make concepts in mind. Whatever you are reading, it may be short, but make concepts in your mind, and it will definitely sail you through. So 90% was image based. Yes. So all the things helped, and wish you all best of luck for your results from everybody at Doc Tutorials. Keep studying with us for PG exams also. So bye-bye. Take care. Best of luck for your results from everybody at Doc Tutorials. Keep studying with us for PG exams also. Bye-bye. Take care.
Yes, good afternoon. And the first impression that I got yesterday was the paper is very lengthy. Yes, it was lengthy. But when we got the questions, when we saw the questions, there were, I don't know about many other subjects, but at least in biochemistry, the buzzwords were there to figure out the answers. And I think that most of you have made the biochemistry part correct. Yes. So आशीष वो मेरा भूत होगा वहां पे. Yes, I was not there. So the first question was, the 25-year-old male presents with the yellow-orange papules on the buttocks. These are the eruptive xanthomas actually. The eruptive xanthomas are there. And they are saying that the chylomicrons are increased. Now, there is a clear-cut question. The moment the chylomicron increase, It is type 1 lipid disorder. And type 1 lipid disorder, it is due to defect of what? It is the defect of lipoprotein lipase. Because lipoprotein lipase is the enzyme which destroys the chylomicron. So if the lipoprotein lipase is not there, the chylomicron will be more and there's going to be eruptive xanthomas will be there, right? Yes. The second question. A 6-month-old infant is presenting with bleeding. Now, the moment we see vitamins, minerals, and the bleeding comes, one of the first thought that comes is the vitamin C. But what happens is in the vitamin C deficiency, the bleeding happens. We understand that. But this bleeding is not because of clotting factors. It is because the blood vessels are fragile. So the bleeding is happening. There is nothing problem with the clotting factors. The clotting factors are absolutely fine. So if the clotting factors are normal, the PT, APTT, they are going to be normal. So they have mentioned in the question that there is some problem in PT and APTT is there. They are prolonged. So the vitamin C cannot be the answer. Because if the vitamin C deficiency is leading to bleeding, then the PT, APTT has to be normal. If vitamin K deficiency, that also lead to bleeding. And in that, yes, there is a problem in the clotting factors. There is decrease in the activation of clotting factor and the APTT, PT, that is going to increase. This is what they have mentioned, yes. So the answer is going to be vitamin K. This is a question from the porphyria. The pathway which we usually skip, that pathway, but it is there in the notes and not usually we skip, but usually you don't want to remember that. But if you remember, we have discussed one mnemonic, right? Heavy muscle bulk, PUBG, URPG, co-PG, pre-PG, if you remember that, if you have attended the class. Now here is the heme synthesis pathway. I want you to focus on this particular reaction, the URPG, then co-PG, UPG3 and CPG3. This reaction is basically happening because of the enzyme, the UPG3 decarboxylase. So they are saying in this question is that there is an impaired conversion of the UPG3 to CPG3. It is not happening. They have clear-cut mentioned that the UPG3 is not converting into CPG3. They are saying that the enzyme is effective. Now, by chance, if you're knowing the answer, that was very clear-cut, then you will go with the UPG decarboxylase. You will go with that. But even if you are not knowing the answer, then I think that you should at least eliminate these options. At least eliminate. You should be confused maybe between B and B because they are looking very similar. They are looking very similar, right? So, but the correct answer was the UPG decarboxylase deficiency that is there. And why it is not this particular enzyme? Why it is not? Because अगर हम common sense से सोचते, then what is happening is the synthase enzyme तो इसको बना रहा होगा. The UPG3 को बनाने के लिए synthase enzyme लगा होगा, right? So synthase enzyme, if it is deficiency, तो ये कम होना चाहिए. So they are saying that the UPG3 CP3C में convert नहीं हो रहा, that is the decarboxylation deficiency is there. So we could have figured out in the exam, even if we're not knowing the answer. If we're knowing the answer, that is wonderful. How to find out the DNA fingerprinting? Now, to find out the parents, that who is the parent, that you may have discussed in patho, maybe in the forensic, maybe in the biochem also, that to find out the family members, we match the DNA. And that DNA fingerprintings, we are going to use the tandem repeats. So the most appropriate method is going to be tandem repeat. Although we can do from DNA sequencing also, but DNA sequencing is very expensive, very tedious. Karyotyping is not going to give us much thing. Restrictive fragment length polymorphism can also find, but that is again not very efficient method. So, and they are asking what is the most appropriate. So to do the DNA fingerprinting, we go for the tandem repeats. We will go for tandem repeats. Self-mutilation was mentioned. I think there were two questions, or there is one question, I don't know. One question that can be there is Leschnian syndrome is due to deficiency of what? That is HGPRTS. If they have not mentioned and they have mentioned self-mutilation, that is also the same thing for us. The Leschnian syndrome or the self-mutilation, it is due to deficiency of HGPRTS deficiency. The moment you see this image, the crumbled tissue paper appearance of the cytoplasm was there. The diagnosis was Gaucher disease, and we know that in Gaucher, there's going to be hepatosplenomegaly, there's going to be anemia, there's going to be thrombocytopenia. So all the things were there, anemia, thrombocytopenia. Yes, okay. There were two questions on Gauchers, that is fine. There are two questions on the Leschnian, okay. 20-year-old tall man presents with the height is, the patient is tall. There is some problem with the aorta. The ectopia lentis is there. The moment we see this tall, cylindrical, long fingers, arachnodactyly, flat foot, aorta problem, collagen disorder, it is the Marfan syndrome. It is the Marfanoid habitus. It is the Marfan syndrome. And Marfan syndrome is due to deficiency of what? It is Marfan syndrome is due to defect of what? It is the fibrillin 1. It's due to defect of fibrillin 1. Right. A 6-month-old infant presents with severe hypotonia, macroglossia, and cardiomegaly. We have discussed that whenever there is a glycogen storage disorder and they talk about the cardiac problem, means the pump problem. We remembered like this, pump problem is going to be Pompe disease, but they have mentioned some other things also. They have mentioned there is increase in the size of the muscle, the tongue, a muscle problem, proximal myopathy is there, hypotonia is mentioned. It is Pompe disease. And Pompe disease is due to deficiency of which enzyme? It is due to deficiency of acid maltase. Acid maltase. A 2-year-old child presents with the hepatosplenomegaly. On the fundoscopy, there is a cherry red spot. Now, I am not very sure that there were 2 questions on cherry red spot or not. Cherry red spot, one question that you have discussed in ophthalmology, cherry red spot, that is CRAO, that is there. But is this question was also there or not? If the cherry red spot, yes, they mentioned acid maltase. Yes, we have mentioned, right? The Pompe disease, the acid maltase. So cherry red spot in biochemistry, if they are saying foam cell is also there. The moment you see foam cell, which disease should come in your mind is Niemann-Pick's. And Niemann-Pick's is due to deficiency of what? Sphingomyelinase. It is due to deficiency of sphingomyelinase. The enzyme which is deficit in the Gaucher disease is associated with which organelle? Now, if you see these disorders, Gaucher, Fabry, Krabbe, Tay-Sachs, basically these enzymes are found where? They are basically the problems of lysosomes. These are the lysosomal storage diseases. Lysosomal storage diseases, right? As you are saying that there were 2 questions on the Leschnian syndrome. One was the indirect question, that was self-mutilation, word was mentioned, that is HGPRTS deficiency. And there is one direct question that development of Leschnian is due to deficiency of what? HGPRTS. HGPRTS. A 15-year-old boy presents with the neuronal problem, ataxia, peripheral neuropathy, retinitis pigmentosa, neuronal problem. There is increased level of phytanic acid. Do you remember in the class, I usually say that, or moms used to say, eat green leafy vegetable, it is going to be good for your eyes. But if you don't want to eat green leafy vegetable, if you don't want to eat spinach, you can tell to your mother that you are suffering from Refsum disease. In Refsum disease, we avoid the phytanic acid because these children are not able to digest phytanic acid, which is found in the green leafy vegetables. Why? Because they have the deficiency of the enzyme phytanyl-CoA hydroxylase. Phytanyl-CoA hydroxylase. It is okay. It is okay, Varsha. They can mention hyperextensibility of the joints. Yes, it can be there in Marfan. Now, this is a question which you may have discussed in other subjects also. Let's understand a small discussion. For example, here is a receptor and the estrogen hormones comes and attaches on the receptor. Now, from here, the signal is supposed to go all the way to the nucleus, and from the nucleus membrane, it has supposed to go all the way to the DNA. So they are saying that when the estrogen molecules are going to attach here, this signal will come here on the nucleus membrane. From there, it is supposed to go to the the DNA. Who is going to take that? It will be taken by the motif, that is the zinc figure. Zinc figure is going to take that signal. That zinc finger is going to take that signal. The zinc figure motif we have discussed that zinc finger motif. It is also called as the supra-secondary structure. In the classification of protein, we have discussed about the zinc finger. The zinc finger is going to take the signal, although it's more of the signaling part that you may have discussed in the other areas also. Yes, you may not have, because usually we don't discuss that in the biochem. Usually it is the part of the physio, or maybe in the patho also you may have discussed about the receptors, that how the signals are transferred from here and there. Yes, very good, Ajay. You did it right. And now, one of my favorite questions that came here. I don't know. For example, let's say you don't know the answer, but they have mentioned there is hyperammonia. They are saying low citrulline. The moment you see low citrulline, to सबसे पहले you remove this answer. Citrullinemia cannot be the answer, right? Citrullinemia is a condition where the citrulline has to be more. That has to be eliminated. Done. Then they said normal orotic acid. The moment you say normal orotic acid, the hyperammonia type 2 is 1. That cannot be the answer. Now I left with two choices. Type 1 hyperammonia or arginosuccinic acid urea. In arginosuccinic acid or urea also, there's going to be increase in the citrulline, so that cannot be the answer. So the answer was clear cut. It is a type 1 hyperammonia. Right? So I have got just these 14, 15 questions with me, but I hope that you have made almost all the questions correct. Maybe one or two here or there. We all are humans. एक आधा mistake तो चलता है. But if you have decently prepared for biochem, these are the, I would say that would have saved you in the first half at least before the break. And because there were buzzwords there, right? The moment you will see that buzzword, you should jump to the answer. And this is how you can save this time for the other lengthy questions. Okay. So wish you a lot of luck. Best wishes to you. And definitely the result is going to come to your side only. Let's pray for the best. Whatever was supposed to be done, it has been done. Now it's the time to relax and let's wait for the result to come. And just the beginning of the journey. It's just a launch pad that is there, and then बहुत बड़े-बड़े काम करने हैं आपको, right? So let's have some rest. And then you will go to the next step of your journey, next step of your life. So for that, let's conserve some energy for that. Wish you all the very best, and thank you. Best of luck for you.
Hello friends, how are you? I hope your exam have gone well and micro as usual was there in plenty, and I think it's a smooth forward. If you have done my lectures proper, all questions were there from my lectures in workbook. So without wasting time, let's start up. So identify the organism that shows these colonies, that is fried egg colonies on the PPLO agar. Okay, so obviously you know what is the answer of it. The answer of this is Mycoplasma. Okay, so Mycoplasma, pneumoniae, Mycoplasma, other species, they tends to grow on PPLO agar to produce what? Fried egg colonies. In Mycoplasma, the organism which does not have a cell wall, it have a cell membrane which is made up of sterol. So answer is A, and it's very clear. Other than that, which other guy was having fried egg colonies? That Malassezia furfur on the SDA. That particular one also having a fried egg colonies. So they might confuse you. Okay. Hi, Ashish. So next question. HIV positive patient presents a history of curdy white discharge. Okay, so curdy white discharge only you get the answer that what we are talking about, showing up narrow budding E cells with pseudo hyphae. Pseudo hyphae, I told you that the question is not visible. Okay. How come question is not visible? It is not visible, Ashish. Jay, question is visible or not? This particular one. I got it's visible. Acha, okay. So I have to make it slight bit more. Okay. Now is it visible? I have zoomed it somewhat. So guys, HIV positive patient, curdy white discharge. If somebody is talking about what is there in your mind, so obviously you will think of what? You will think for Candida. Candida albicans, and Candida albicans is what, guys? Candida albicans is a yeast-like. Okay, it is yeast-like. It have E cells, it have hyphae, it have pseudo hyphae. All sorts of things are there in this particular one. Okay, so yeast, hyphae, and pseudo hyphae. These all are the features of what? These all are the features of Candida. Okay, so Candida albicans will be the answer if this would have been present. So guys, these are recalls. Definitely they have some faults in them. And if you think that something else was there, do tell up in the comment section down. In the particular YouTube channel, you can put down in the comment section that that was the exact question. But still, near to that, we'll try to go. So answer is Candida albicans regarding this curdy white discharge in HIV positive patient. You know that this is one of the common opportunistic infections which happens in HIV. A patient from Tamil Nadu presents with multiple draining sinuses. Multiple draining sinuses after a thorn prick. Okay. What is the treatment of choice for this particular disease? So guys, for this particular one, thorn prick is there. I told you thorn prick, three things you need to know. That is, one is mycetoma, one is Rose Gardner's disease, and one is chromoblastomycosis. Okay, so obviously Tamil Nadu means Madurai district they have talked about, and thorn prick they have talked about, and they have asked regarding the eumycetoma here. Okay, because they have talked about what? Eumycetoma here. And in eumycetoma also, multiple draining sinuses can be there. It is not like always the actinomycetoma will have it. The eumycetoma can also have multiple draining sinuses, if at all that is there in the option. Fine. Other than that, the treatment. Do we go directly for amputation of leg? No, man. We will not go for the amputation. Obviously, we will try for antifungals and we'll try for the debridement. And a lot of patients, they do respond. But yes, the final treatment, if this does not work, then you have to go for what? Amputation. The amputation of the leg is the final stuff, not the first one. So answer should be what? Antifungal with debridement. Okay, what should be the answer? The antifungal with debridement. Is it fine? So remember this particular one also. Is it fine? Now coming to this, a sheep wool carrier presents with a black eschar. Okay, or black scar. Eschar might be this is, okay, eschar. And which particular one is responsible for this stuff? So if they are talking about the veterinary one, that is sheep wool and all, okay, and they are showing up eschar and all. So obviously we are talking about what? Bacillus anthracis. Okay. Scrub typhus also have it, but the history and all and sheep wool will not be associated with scrub typhus for sure. Okay, because trombolytic mite is the transmitter of that particular one, not this particular sheep. Okay, so basically they are talking about what? That wool sorters disease, which happens in the pulmonary anthrax. And basically, if it is sheep wool along with this, so this is basically what? This is basically cutaneous anthrax. So cutaneous anthrax and pulmonary anthrax, they can happen to the same person. So that is not the, what was the option? No history of trauma given, sir. Okay. Acha, in that question. Okay, Ajay. So regarding this sheep wool one, what's your saying regarding this? What was exactly one? The sheep wool was there? Huh? Sheep wool was there? I could not able to see what is written. Insect bite was an option too. Insect bite will not be the answer here. Obviously, the answer will go towards the Bacillus anthracis and a sheep wool with a blackish scar. Okay, most likely. But exact question is what? Let's see that. This typical feature which is being given to me is of Bacillus anthracis or scrub typhus, either of them. Okay. Now, what about this question, guys? A patient is there with Burkitt's lymphoma. Okay, a patient is there with Burkitt's lymphoma, and the Paul Bunnell test was performed to confirm the organism. Okay, Paul Bunnell test was done to confirm the organism. What is the most likely organism? So, guys, I definitely told you that the organism is what? Epstein-Barr virus. Acha. Okay. Scrub typhus is not in the option, Ranjit. Okay, fine. So basically, if it's the animal zoonotic stuff along with the black eschar, two, three things you can think of. One is mucormycosis. Okay. Another is scrub typhus. Another is cutaneous anthrax. And there is a black widow spider bite, which associates with having this particular black eschar. So if that is not there, so obviously the better answer will be cutaneous anthrax, and it is going toward the Bacillus anthracis. And if this is there, guys, Burkitt lymphoma, and regarding the Paul Bunnell test, if they talk about, so you know Paul Bunnell test is a heterophile agglutination test, and this heterophile agglutination test is said to be positive in what? Epstein-Barr virus. Okay, so Epstein-Barr virus, that is there, which does Burkitt's lymphoma, which is having starry sky appearance, because it affects up the B cells. And why B cells? Because B cells, they have which marker over them? They are having what? CD21CR2, and thereby leads to what? Polyclonal proliferation of B cells, and thereby that leads to the cancer. So this is what is the story. So answer is A, Epstein-Barr virus in this particular one. A foreigner is there present to the OPD with complaints of rice watery stool. Rice watery stool after eating the street food. Which toxin is responsible for this particular condition? So guys, rice watery stool typically, okay, is associated with Vibrio cholerae, and obviously the toxin will be what? Cholera toxin. Okay, obviously the toxin will be what? The cholera toxin. I don't know exactly what was the question and all, but still you can tell up, was it cholera toxin? And you know cholera toxin is made up of what? A and B, two components. Fine. B helps in binding to the GM1 ganglioside receptors, and A does what? ADP ribosylation of G stimulatory protein. And finally, what is increased? Increase in cyclic AMP. Intracellular water is put into lumen, and there is a massive watery diarrhea. That is rice watery stool typically, which is also seen in arsenic metal poisoning. So here, if this is there, so that will be the better answer. I suppose so. Okay. A farmer working in rice field presents with conjunctival suffusion. If this particular thing is being given, what is conjunctival suffusion? Conjunctival suffusion is red eyes without the inflammatory exudates. You're not seeing a discharge. You will not see anything of sort of inflammation. That is what is termed as conjunctival suffusion. Okay. If this is written, I already told up in the class also, number of times. This is a repeated question, and again it comes. If this is written conjunctival suffusion, your answer is leptospirosis. Okay, that are given up. Leptospirosis, Weil's disease. will the same, like these options would have been there. I suppose it's regarding leptospirosis only. Weil's disease is also leptospirosis. Okay, so you can tell up the other options if you know. And there is a icterus along with this conjunctival suffusion. Rice field, if this is talked about, so obviously we're talking about the leptospira. Okay, lepto versus Weil's. It was there. Leptospirosis is Weil's disease only, na? So what they exactly have given up? What they exactly given up in the question? Is there any renal failure they have talked about, or what else? Both given. Tricky question then. Tricky question. Tricky question. If both given, man, better answer would be Weil's disease, not leptospirosis. Because this is number of leptospira species, they do not do much of a problem. Okay. Most of the leptospira species, they do not do a problem. Leptospira enterogens. This is the only species which does the problem mostly. And that is the Weil's disease. Leptospirosis is fine, all hands about. But what is Weil's disease? That is not leptospirosis, na? Icterus. That the name of Weil's disease is what? Icterohemorrhagic fever. Okay. So icterus is there, jaundice is there, and hemorrhagic features are thrombocytopenia and all these conjunctival suffusion. That's typical of Weil's disease. And if you see, I have talked about Weil's disease only. Okay. Shivani, you marked Weil. Okay, good. So answer would be better to go for Weil's disease if both options are there. A patient presents with painful genital ulcer with undermined edges and painful lymph nodes. So anything painful, I told you, a painful genital ulcer, undermined edges and painful lymph nodes. That is typical of what, guys? That is typical of Haemophilus ducrei. Haemophilus ducrei doing what? Chancroid. Okay. And in the name only what is coming? Cry. The fellow cries in pain. I told you this. Do cry. Okay. MSC complex images was there. Okay. Vansh. So MHC1, MHC2, that was there. That MHC1, MHC2, alpha 1, alpha 2, alpha 3, beta 2, and alpha 1, beta 1, alpha 2, beta 2. Like that one must be there. No? You're telling Vansh. Fine. So Haemophilus ducrei leads to chancroid and do cry, Ajay. You perfectly tell. This is what is I used to tell her. Okay. And it is painful. Along with that, you extra thing is undermined edges are there and painful lymph nodes. That is buboes. They are also present in this particular chancroid. It needs a dark chocolate, that is chocolate agar with factor X, and school of fish and tram track appearance. That is also visible in this particular one. Okay. Yeah. Is this question was there, guys? What process this organism perform? And I suppose that is being given bacteriophage. Okay. This is being given bacteriophage. And you know what is bacteriophage? Bacteriophage is, it is a virus which eats up the bacteria. It's a virus which eats up the bacteria and it plays a role in which resistance transfer the maximum? Transduction. So answer is, I think this is the easiest. Okay. So that is transduction. So transduction plays a role of resistance transfer in certain bacteria like staph and all. Okay. Okay. So this is like simple one. Now tell about this. A 5-year-old child presents with fever, cough, coryza. If these are sufficient hints, then bluish white spots. Okay. Onset of generalized maculopapular rash. So we have discussed that this is complex spot of what? Complex spot of measles. That is rubella. Yes or no? Complex spot of measles. That is rubella. Yes or no? So remember these particular points. तुक्का लगाया था ये मैंने आशीष. Which one तुक्का लगाया था? That is bacteriophage or this one? This is complex spot, not typically complex spot. Opposite lower second molar, I told you, bluish white spots. That is there. On the 10th day after the incubation period, including incubation period, you have cough, coryza, and conjunctivitis. 12th day, including incubation period, you have these spots. And on the 14th day, you have the rash. 4 days before the rash, 4 days after the rash, there is what? There is an infectivity period of measles. So this is typical of what? Measles. What do you call measles in Hindi? Khasra. Okay. A patient with Plasmodium falciparum malaria from Manipur. So you know that this particular person will be having a different set. Obviously, I have not given taken up the options proper. So ACT therapy with some changes are there because they are totally resistant up to the certain drugs like chloroquine and all. So ACT therapy, or what exactly the options you can also tell. Okay. Okay. Sulfur toxin. Yes, that is being used here. Now coming to this, X and V factors in the culture media is used to grow which of the following organisms? I told you X and V is what? If you see my lectures in the initial part only, I told that chocolate agar. That chocolate agar, no. You tell the better options, then I will choose up and then I will put it and recall. Okay, so don't worry. So X and V factors in media is used to grow which particular organism. So you know the Haemophilus groups loves to grow in the presence of X and V because all the Haemophilus, they loves to grow in chocolate agar. And what is chocolate agar? X and V. What is X and V? X is hemin and V is nard. X is hemin and V is nard. Okay. X is hemin and V is nard. Okay. So this was there. Chloroquine you will not use Ajay. That particular protozoa is resistant to chloroquine there. Yeah, exactly. Amal Vijayan is telling right. That is what is there. ACT plus lumifantrin. He wants to tell, I suppose. Okay, so X and V factors in media is used to grow which of the following? It was there in the option. Amal Vijayan. If it's there in the option, that is what is the answer. Okay. X and V, I suppose it's okay. X and V, Haemophilus. And along with that, meningococci and gonococci. They loves to grow in the presence of X and V. The truck driver presented with single painless ulcer. Okay. A truck driver with single painless ulcer. A single painless ulcer is typical of syphilis. Okay. But I don't know what they have given up. It is around the lips also. Is it given around the lips also? A single painless ulcer. It is not towards the herpes because herpes have multiple vesicles and all. Okay, so single painless ulcer truck driver, most likely it goes towards the primary syphilis. Okay. Fine, Jay. Okay. Tell about this, Jay. What about this question? The truck driver. Proper guidelines are there for the northeastern states. Okay, so that will be covered. Don't worry. I will cover in the recall. The truck driver presented with single painless ulcer on penis. Lips also is given. On glans penis, no? Okay, then obviously the answer is primary syphilis because that is what is single indurated ulcer and along with that painless inguinal lymphadenopathy. So that's typically clear. A patient presents with fast moving serpiginous rashes. Serpiginous rashes are there. Okay. So serpiginous rashes, organ is responsible for this particular one. This sort of picture is there. Fast moving. Is this was written fast moving? So obviously the fast moving is what? Larvicurrence. And larvicurrence is done by what? Larvicurrence is done by Strongyloids stercoralis. I suppose that is what is the answer. Yes or no? A is the answer or not? Or is there something else in the question which was asked? Yes, anybody? Yes, please. Anybody? Yeah, please, sir. In this particular question, do you observe anything else? Okay, Ranjit, I got your point. एंकालोस्टोमा किया मैंने तो नहीं तो एंकालोस्टोमा भी आंसर हो सकता है लेकिन ये फास्ट मूविंग वर्ड था क्या is this fast moving word was there because the larvae of Strongyloids stercoralis moves fast under the skin इसीलिए उसको larvae currents बोलते हैं Ankylosoma brasilensis भी cutaneous larvae migrants करता है. Okay, तो Ankylosoma brasilensis also does cutaneous larvae migrants. So can you tell me that both options were there or not? And this fast moving was there or not? If fast moving is there, then just image of strongyloids. Acha, there was an image of strongyloids, somebody is telling. Okay. Ashish, what exactly the question is? I think there was a question regarding varicella also, in which something was given up around the abdomen and all that. Anyhow, if it is fast moving and all is there, then you have to mark strongyloids. Otherwise, Ankylosoma brasilensis also leads to cutaneous larvae migrants. Okay, these particular things, if this is given up, this is used to be famous in the Rajasthan before. They used to store up the water in these water bodies, and which disease used to happen a lot because of that. Cyclops used to be there in that cycle, and I tell up in the last in the parasitology regarding the guinea worm. So this particular one is typical of what? Guinea worm stuff. So guinea worm disease, now it is not there, but previously it was used to be very common in Rajasthan, and the last case reported in 2000, okay, of this guinea worm. So I suppose they have given up this because of this water bodies, the cyclopes and all, they used to be there, and this guinea worm disease used to happen from consumption of this particular water. And in this guinea worm, I used to tell, if you remember, that matchstick method is used and used to remove up through the blisters and all. So if this is was there, the answer is guinea worm. Is it fine? A immunocompromised patient presents with unilateral, painful, black, necrotic scar on his right face. Okay, what will be the ideal treatment of this disease? What should be the ideal treatment of this disease? Ajay, you marked hookworm. Why? Answer is guinea worm. Immunocompromised patient is there. Unilateral, painful, black necrotic scar. Typical of what? Rhinocerebral mucormycosis. And for that, you will give antifungals, and along with that, you have to go for surgical resection also. Okay. So answer should be C. And if you have any controversy, do tell us. What are the options and all? We will change according to that. So this is typical of rhinocerebral zygomycosis or mucormycosis. Okay. C. Fine. So guys, these were the questions which I got up, and any other which you think is there, please tell up. Like in immunology and all, if you think that something have come from antigen antibody interactions, that something have come, so do tell up me. Okay. So anything have come from general microbiology? Overthinking, sir, I marked guinea, then changed to hook. Guinea was there, na? Because if you see na, that in the images I always show guinea worm disease because of that matchstick method. Okay, no problem, Ajay, no problem. All other things will be right. Don't worry. So yes, anything about general microbiology? General microbiology, any stuff have come? Any culture media and all that, or just X and V for the chocolate agar that have come? Any other thing, guys? Any other thing in immunology? If you heard of immunology, that is there like antigen, antibody. Anything? Antigen, antibody? No. Somebody was telling like some picture was there of some worm, and it was being asked, is it roundworm or hookworm or what? Is it so? Roundworm picture was there as caris and all. Somebody was telling like that. I don't know. The first thing which comes in mind, now mostly it is correct, Ashish. So that is what is the story. That the first thing we do now. So that so best of luck from my side, guys. And if you remember any of other questions, do tell up. Okay. Best of luck for the results. MSc पर आया था. Okay. DPDQDR. Okay. Beta gamma. DPDQDR. Fine, fine, fine. चलो after the discussion chill up, and thank you so much for joining up, and do tell up. इस worm के ऊपर image दिया गया था. Okay. Scaris, microscopic roundworm. Fine. Any other, if you remember, do tell up. Okay. See you guys.
Hello, my dearest students. How are you? I hope your exam went well. Okay. So if you look at the paper this time, it was kind of a moderate paper. If you look at orthopedics also, the questions were mostly straightforward. If you have attended my MIQ sessions, there were 4 questions that were straight away that was asked from that MIQ series. This time we had around 10 or 11 questions from orthopedics, and most of them were easily doable. I hope you were able to score good in orthopedics. Yes. So before I go into the recall, just a word, just remember that all these questions have been compiled after talking to many students. So the structure of the questions might be a little bit different and the options may have slight variation. So if there is any big errors, please tell me in the chat box so I can make those corrections. Okay. There are certain questions I also need your help for arriving at the correct question. So please help me out there as well. Okay. All right. So we'll just go and look at the first question here. A 19-year-old male presents with persistent night pain at the distal femur. The X-ray is given below. What is the likely radiological name of this finding? So I am not sure whether this X-ray was asked or this one was asked. Which one was asked? Can you just help me out here? So if you look at the first one, you can see that there is a metaphyseal lesion. Both these are actually X-rays of osteosarcomas. And here you will see this triangular piece of new bone formation here. If that was asked, then it was Codman's triangle. And if instead of this was asked, where you see a metaphyseal lesion where there is this kind of hairy lines going out from the metaphysis, then this is your sun ray appearance. Can you tell me which one was asked? Okay. Codman's triangle was asked. So this was not asked. So Codman's triangle. So see here, you can see that this is osteosarcoma with a metaphyseal lesion here, and just adjacent to the metaphyseal lesion, you will see this triangular area. This is called your Codman's triangle. Codman's triangle. So that is our answer here. Codman's triangle. Thank you. Next question. A 9-year-old child presents with pain and swelling in the mid shaft of tibia, accompanied by low-grade fever and elevated ESR. An X-ray is shown below. What is the most likely diagnosis? See, this was a question which is very similar to the one that was asked in the recent INICT paper. So when it is a 9-year-old child, so tell me which are the 2 tumors you should always check in a child less than 10 years? Simple bone cyst and Ewing sarcoma, isn't it? Ewing sarcoma. Simple bone cyst is actually a metaphyseal tumor. Ewing's is actually a diaphyseal tumor. And Ewing's will have the characteristic onion peel periosteal reaction. If you look at the X-ray, you will see this fine lines, concentric lines starting out in the diaphysis. So this is a diaphyseal tumor and with this kind of onion peel periosteal reactions. Okay. So this is your Ewing sarcoma. Ewing sarcoma. Okay, so there are few variations in the options. Okay, don't worry, I'll get that corrected in the options. So the answer to this question is Ewing sarcoma. So a 9-year-old child, a child less than 10 years, coming to you with a diaphyseal lesion. Now, there can be a confusion regarding this low-grade fever and elevated ESR. This can point to an infection, isn't it? But remember, Ewing sarcoma is a tumor which can mimic an infection. Okay. It need not be an osteomyelitis. Even in Ewing sarcoma, we have children coming with fever and elevated CRP, ESR and all. Okay, so Ewing sarcoma can mimic a osteomyelitis. So keep that in mind. Okay. Next question. Again, something that I always tell my students to study. This was also discussed in the MIQ session. A 28-year-old male is brought to the emergency department for high-speed motor vehicle collision, where his knees hit the dashboard. Physical examination reveals right lower limb is shortened, adducted, and internally rotated. An anteroposterior X-ray of the pelvis is shown. Based on clinical presentation and image, what is the most likely diagnosis? So how do you arrive at the diagnosis? First clue here is dashboard injury. Dashboard injury is what? So whenever a car hits a tree or somewhere, the patient is thrown forward because of the inertia of motion. The knee would hit against the dashboard, and this hit will cause a posterior push on the femur. Therefore, what will happen? There will be a posterior dislocation of hip. So that should what be happening here. So let's confirm the diagnosis. How can we confirm? Just look at the deformity. There is shortening, adduction, and internal rotation. What is the deformity in posterior hip dislocation? It is flexion, adduction, internal rotation. Anterior hip dislocation, it is flexion, abduction, and external rotation. Intertrochanteric fracture, it is severe external rotation. And fracture of the acetabulum, you will have variable deformities. But just by looking at the question, there is shortening, adduction, and internal rotation. That suggests posterior hip dislocation. And in the X-ray also, you will see that the femur is slightly adducted, indicating a posterior dislocation. So that is the answer. Okay. Next, very straightforward question. What is the answer here? A fracture at the neck of humerus leads to injury of which nerve? So there is an X-ray showing fracture of the neck of humerus, and which is the nerve that winds around the neck of humerus? It is your axillary nerve. Yes, axillary nerve. So axillary nerve winds around the neck of humerus. So whenever you have a fracture there can be a high risk of axillary nerve injury, which can lead to deltoid paralysis and the paresthesias over the lateral aspect of arm, which is called the regimental back sign. Isn't it? Yes. Next question. Again, I need help here. So a kabaddi player twists his knee while playing. Which of the following structures would be injured? As far as I understand, an image like this was given with an injury to a particular ligament. Was that the question? Was that how the question was? I think there was an injury to the ACL ligament. How do you identify the ACL ligament? PCL was asked. Are you sure? If it was the ACL ligament would start in the inner aspect. Yes, it will start in the inner aspect of the lateral femoral condyle, and it will come and attach onto the anterior part of the tibia. See, ACL and PCL are differentiated by its point of attachment on the tibia. Okay. On the tibia, the ligament that attaches anteriorly is the anterior cruciate ligament, and on the tibia, the ligament that attaches posteriorly is the posterior cruciate ligament. I think a very similar image was given where this ligament. So how do you identify ACL? It starts at the inner aspect of the lateral femoral condyle. How is this the lateral femoral condyle? See here, this is the fibula. Fibula will be the lateral side. No, so this is the lateral femoral condyle. On the inner aspect of the lateral condyle, it is fixed. It comes anteriorly and gets attaches onto the anterior part of the intercondylar notch of the tibia. Okay, so this is your ACL there. So this is ACL tear. As far as I know, most students have told me that this is an ACL tear. Okay. Some students are mentioning that it could be PCL. If it is PCL, a posterior view of the knee should be given. Then only they can show you the PCL attachment. Okay. So that may be difficult. Anyway, whether it is attaching on the anterior part of the tibia or posterior part of the tibia, that is how you understand which ligament it is. Okay. If the ligament is in the anterior part of the tibia, it is ACL. If it is attaching to the posterior part of the tibia, it is PCL. All right. Next question. A man presents with elbow injury. He has pain and tingling sensation in the little and ring fingers. Which nerve is injured? And an X-ray is given. What do you see in the X-ray? X-ray is that of elbow, isn't it? This is an elbow X-ray. And this is the humerus. This is the radius. And this is the ulna. Ulna is on the medial side. So this is the medial side. This is the lateral side. And you can see that there is a fracture in the medial condyle of humerus. Fracture of the medial condyle of humerus. Okay. And which is the nerve that goes behind the medial condyle of humerus, which can get injured, we know. So when you get funny bones, no, when your elbow hits somewhere, the medial condyle gets somewhere, which nerve is affected? The ulnar nerve, isn't it? Ulnar nerve goes behind the medial condyle. Okay. So okay. So ulnar nerve was the answer. In the options, we had anterior introitious nerve and posterior introitious nerve. Okay, instead of axillary and radial, we have anterior introitious nerve and posterior introitious nerve. Okay, so was an X-ray given in this question or just a statement that medial condyle of elbow was fractured, medial condyle of humerus was fractured? Was an X-ray given? Yes. So the options were median nerve, ulnar nerve, anterior introitious nerve, and posterior introitious nerve. Anterior introitious nerve is injured in supracondylar humerus fractures. Posterior introitious nerve is injured in fractures or injuries around the head and neck of radius or in Monteggia fractures. Okay. Yes. Okay. Thank you. Thank you, guys. So I'll get the options corrected. All right. Next question. Palmar introcei help in which movement of fingers? Can you tell me? So we know the famous mnemonic, no? Pad and dab. Pad and dab, isn't it? Palmar introcei is for adduction and dorsal introcei is for abduction. So this is straightforward. Palmar introcei is for adduction of fingers. Palmar introcei or is for adduction. Yes. So dorsal was asked. Are you sure? Okay, if the question was dorsal interosseous, then the answer is abduction. Okay. So I think this is a very straightforward question. We know pad and dab. P is for palmar interosseous is adduction and dorsal interosseous is abduction. So whichever was asked, you can mark. Okay. Okay. So just a second. So one of my students here is saying that in this question, the question was 10 years back, there was a fracture. 10 years ago, there was a fracture of the elbow. And now the child is coming with tingling sensation of little finger and ring finger. This is also in a previous year NEET question asked 3 years back. Okay. So that is a repeat question then. 10 years ago, fracture elbow, now coming with tingling sensation, little finger and ring finger. If that was and an X-ray shows cubitus valgus. Okay, X-ray showing cubitus valgus. Okay. So in that case, the probable cause is non-union of lateral condyle of humerus. Okay, non-union of lateral condyle of humerus, and non-union of lateral condyle of humerus will also result in tardy ulnar nerve palsy. Tardy ulnar nerve palsy. Okay. Again, whether it is medial condyle fracture, if it is a medial condyle fracture, acute injury will cause ulnar nerve damage. And if it was a lateral condyle humerus fracture with non-union, then it will cause a delayed onset ulnar nerve injury, which is also called as tardy ulnar nerve injury. Tardy ulnar nerve injury. Okay. So anyway, you are lucky whether it is medial or lateral condyle. Don't worry, the answer is ulnar nerve. All right. Okay. Next question. A male presents with lytic expansile lesion of the distal radius. Histopathological examination reveals numerous multinucleated giant cells. What is the diagnosis? Very easy question, no? So, whenever there is distal radius lytic lesion, the most common bone tumor affecting the distal radius is actually giant cell tumor. And just by the question, there are giant cells in the biopsy, no? So this is GCT or a giant cell tumor. Giant cell tumor. The other name for GCT is osteoclastoma. Osteoclastoma. So that is the answer. I hope all of you have gotten this correct. A straightforward question. Okay. Yes, so a few students are saying about the question on enchondroma. I think this is the question you are referring to. A 28-year-old female presents to the clinic complaining of mild dull aching in the left hand after accidentally hitting her finger against a door frame. On physical examination, there is slight tenderness, but range of motion is preserved. X-ray is given below. What is the diagnosis? And what does the X-ray show? You see a lytic lesion in the metaphysis of the proximal phalanxes in the P1 of index finger. The P1 of index finger, there is a lytic lesion. Okay. So what is this? This is something that very often see. That is, a patient comes to you with a trauma, a mild trauma. You take an X-ray suspecting a fracture, but you are surprised there is no fracture, but an incidental finding of a tumor. Okay. These tumors are asymptomatic. So the patient will not know that the tumor is there unless there is an injury. She or he takes an X-ray and the doctor looks at the X-ray and finds the tumor there. Okay. And whenever you see hand tumors, what is the answer? The most common bone tumor in the hand, what is it? It is, yes, enchondroma. Enchondroma. Correct. This is enchondroma. Okay. Very straightforward question. Enchondroma. Okay. All right. Didn't you have a question like this? I think few messages back, I can see students asking about the question on hand injury and enchondroma. Okay. All right. And wasn't this question asked? All right. We'll see. Okay. Next, this question again, I am not sure whether this was asked or not, or this question was confused with Ewing sarcoma question. A child presents with history of fever for 2 months and pain. X-ray shows below a X-ray. What is the diagnosis? Did a question on chronic osteomyelitis come? Did a question on chronic osteomyelitis come like this? Or was this question confused with Ewing sarcoma question? This question was there. Okay, great. So a child presents with history of fever for 2 months and there is pain. X-ray shows below. In the X-ray, you can see abscess cavity here, and there is also new bone formation, so showing involucrum. And this is an infection. This is a bone infection. And what is the other name for bone infection? It is osteomyelitis. Osteomyelitis can be acute osteomyelitis, subacute osteomyelitis, or chronic osteomyelitis. Chronic osteomyelitis is infection that is going on for more than 2 months. So 2 months is given here. That itself is clue for diagnosis, isn't it? So infection going on for more than 2 months is obviously chronic osteomyelitis. Chronic osteomyelitis. Exactly this kind of image came. Great, great. Okay. So this is chronic osteomyelitis. Okay. Good. And finally, what is the diagnosis of the X-ray given below? Very, very typical X-ray. What is this? Can see that this is an X-ray of the knee joint. So this is the femur, this is the tibia, and this is the fibula. And here inside the joint, you can see multiple white lesions, isn't it? So these are all multiple loose bodies, okay, multiple loose bodies. So which is the condition characterized by hundreds of loose bodies inside the joint? It is synovial chondromatosis, okay. So that is the answer here, synovial chondromatosis. A joint with lots of loose bodies like this. Okay, if there are one or two loose bodies, it can be osteoarthritis. But in osteoarthritis and all, you cannot have hundreds of loose bodies like this. Can see all these tiny dots are actually loose bodies. Okay, so this is synovial chondromatosis. Okay, so these were the questions that were asked in orthopedics. Is there anything else you would like to add? Okay, so I think the questions were really moderate questions, and I hope and pray that all of you have done really well. And from the way that you are answering the questions in the comments in the chat box, I am very confident that all of you are going to do really well. So we'll all be praying for the results. So don't worry. The only thing is that you have worked very hard. Now you have a few more days so that you can enjoy and relax. So all the very best for your upcoming results. We hope and pray that all of you would pass the exam with flying colors, not just 150, above 200. That is our prayer. Okay. So all the best.
Pablo, how long can I take the session? I didn't understand. Like, you want me to stop at 3:40? Hello, friends. Good afternoon. See, we had around 30 questions from PSM this time, and it's keep coming. I mean, it's still, I'm getting a lot of questions, but as of now, I have around 29 to 30 questions. So we'll be seeing which are the questions. We will have a detailed session later with all the answers, options, and all. This is just to give you a insight of how the questions were, how the questions came in PSM. So let's see. Let me tell you, all questions were directly from the notes. So I'm so happy that students found PSM easy. Anyway, without wasting time, let's go to the MCQs. See, Health and Wellness Center, I have told you this will be coming. Under Ayushman Bharat is officially named as, I'll show you the official declaration which came from the government side. I had shown this in the class itself, and I've told you the new name is Ayushman Arogya Mandir, right, with a tagline. So here the answer is Ayushman Arogya Mandir. That is a new name of health and wellness centers. Okay, so we have already seen it was renamed. All these are from the notes, directly from the notes. Another question, I heard that there were two questions. One logo was also shown, and again the question was, what is it? Again, the answer is the same, Ayushman Arogya Mandir. And see, this is again from the notes. I'm unable to see your chats. I'm so sorry for that. Let me just see. I mean, it's kind of stuck. Sorry. Okay. I'm unable to see your chats. Sorry for that. And this is also, I have shown you. See, whenever you are in Ayushman Arogya Mandir, it is mandatory to show all the emblems. And the MCQ was, the image-based question was from one of the emblems. Okay, regarding the services that you give. Yes, Pearl Index, right? Yeah. So we knew that questions will be there from Pearl Index. A contraceptive method was used by 500. I'm not very sure about the numbers. This is what we have got by the recall. Same question. Yeah. Okay, then I'm happy. Okay. It was used by 500 women for 1 year, during which 4 pregnancies occurred. Calculate Pearl Index. Straightforward question. You just need to substitute the answers. See, Pearl Index. As you all know, this is the formula. You have total number of accidental pregnancies divided by total months of exposure into 1,200. Everything is given. Total pregnancies, accidental pregnancies, they have given it as 4, and months of exposure. 1 year, right? So 12 months. And how many couple were there? 500. So you have to 500 into 12 into 1,200. So you'll get it as 0.8. Okay. So here the answer is 0.8, and that option was luckily there. So I'm almost sure this was the exact question that came. Yeah, right. Something that you can write even without learning. Anemic woman who's in second trimester, she's taking iron folic acid as per Anemia Mukt Bharat. Which among the following regimen can be added to increase the efficiency or improve the efficacy? We all know that vitamin C or ascorbic acid can increase the absorption of iron folic acid. So we very well tell patients to take it along with iron folic acid. During your UG also you have learned it, right? You know, you have to take it along with vitamin C, and you have to avoid tea, coffee, such things when taking iron folic acid. So we know what all to take and what all to not, what all shouldn't be taken when you are taking iron folic acid. And something regarding the beliefs that we have, you know, something about the, something from sociology actually, which of the following fruit is commonly believed to cause the misconsumption of causing abortion, but we don't have any scientific evidence. We know papaya,
It is generally said that in some literatures, they mentioned that there is something known as papain in not ripe, no, semi-ripe or unripe. So there is something known as papain, which is actually causing abortion because it can cause the uterine contractions and it can lead to abortion. It's a general belief, but we don't have any strong scientific evidence for that. Okay. This question is, earlier till 2015, we were having MDG, right? Later, it was actually changed to SDG. So the question is, based on what? In 2015, why it was changed to SDG? Honestly, guys, there are two options which are correct. Okay, so I don't know whether the same options came. There are two options they have given. I mean, there are 3 reasons for changing MDG to SDG, to be very honest, of which 2 are, one, MDG was mainly for the low income countries. Okay. Second, in MDG, NCD was not that much included because we had actually made MDG. MDG was in the year 2000, right? And during those time, actually the NCDs were not of that much important. So we had not included NCD back then. And the reason for changing it in 2015 is we have given due importance to NCD, and we have also given it a, it's like a universal thing, not only for low income countries. So both these are answers, but definitely you have to choose one, right? If you're asked to choose one, I would say go for this one, NCD. Okay, just NCD. Yeah, right, Jay. You're right. Okay, even I go for NCD, though both are correct. NCD is the most appropriate answer here. Then something like this was there, no? This is a picture that I got from students. Okay, let's assume this is how it came. It's about doctor-patient when they are sitting in a consultation room. How should be the arrangement? So they have clearly mentioned that there was a window and there is a door. So where all they should sit for, scientifically. Actually, I would say image 1 is correct. Yes, this was the answer, no? Oh, nuchal. Okay. So the doctor should be sitting next to the window and the patient can sit next to the door. Actually, what is this? Why they have mentioned this is for, cross ventilation. There should be cross ventilation, right? There should be cross ventilation. And, for cross ventilation, when the patient, there are 2 reasons why the doctor is sitting next to window. One, he will be getting pure air from the window. Moreover, he can very well see the face of the patient. And the patient should be sitting next to door. So the air which is entering from door, if the patient has some respiratory illness, that, that will be carried out through the window as well. Okay, so there are many reasons. So this is, window was the outlet. Yeah. Yes, Jay. Yes. Window was the outlet. That means definitely this is the answer. Okay. Was it an image-based question? It was an image only, right? Okay. Then statistical test. One group, before, after, outcome is cholesterol. And I've told you cholesterol should be taken as mean or average. So before, after, just one group, it is pair t-test. Oh, okay. So it was mentioned as a dots. Okay, that I didn't get that. Okay. See, Jay saying that it was a dot center. It was a dot center. Okay, that means the patient was having TB. Then again, the answer is not changing. So here it is pair t-test, right? Okay. You know all these, right? Unpaired, when you have 2 different groups. ANOVA, when you have more than 2 groups, and if the outcome is average or mean. Chi-square test, just 2 group, outcome is given as percentage. Okay, so these are the places where you use these particular tests, which we have discussed, and I'll come with a recall later, okay, of PSM alone. Then in a study, 100 patients were telephoned and asked about if they exercise daily and if they have coronary heart disease before or after. Guys, what is this? This is just a cross-sectional study where they are trying to find out the prevalence, the prevalence of coronary heart disease. Okay, so this is just a cross-sectional study. They're trying to find out, whether they're asking, okay, how many of them had MI or coronary heart disease. So it's a cross-section study. Which of the following best defines? Doctor is not in the way of, okay. Which of the following best defines the NRR? Very much expected. I always tell you, you should know the difference between GRR and NRR, right? GRR and NRR. So which is NRR? I don't know whether the same options came. Anyway, there was one answer which is very much falling into the definition of NRR. In NRR, it is average number of girl children born by, I always say, N and N, newborn girl. Okay, so this is the answer. I'm not going to the discussion part. This is the answer, right? And this was straightforward question. Then 24-year-old female who is 4 months pregnant, and she's found to have a hemoglobin of 8 gram, which is the most appropriate treatment. We know that for a normal, in normal pregnancy, right from the beginning, we give iron folic acid. That means from second trimester onwards, you are giving iron folic acid. And how is it given? It is given as 60 milligram of elemental iron and 500 microgram of folic acid, right? This is for a person, for a pregnant woman from second trimester for prophylaxis, right? But here, look at the data they have given. She's already anemic. Okay, so what you have to see is whether she's, anemia is less than 11. I'll show you this is again from the note. This is the latest Anemia Mukt Bharat, the treatment guideline for anemia. Are you seeing? Mild to moderate anemia. Mild is 10 to 11 or 10.9. Moderate is, can you see? Up to 9. Okay. Sorry, up to, wait. You are unable to see it, right? It's stuck, guys. Sorry. Okay, so here it is like, up to 7, you have to give double dose. Anyway, I'll come with the explanation part later. We don't have that much time with us. Okay. Then, there was a question. I'm actually looking for the question. This is the answer. Yeah, this is the question. Sorry. Which is the appropriate method of disposal for a used parenteral feeding package as per biomedical waste management? Guys, this is something which is made of plastic. We know yellow, red, white, blue, right? So yellow, we are incinerating, in which we are putting, all the contaminated. Red, I have told you, you have to remember the things that you put in red as RPT. Do you still remember? RPT. That means rubber, plastics and tubes. RPT. Rubber items, plastic items, all the tubes you will put in red. So this is something which is made of plastic. So you have to put it in red only. Okay. What's this question there? Which plastic bag is not contaminated with blood? I heard such a question was also there. Which plastic bag is not contaminated with blood? Then the best option would be to go for blue. Because blue has, I've already shown you, that has, in all others, definitely you will see blood. Here blood, here blood, here blood. Okay. But here is the one which is, you are putting ampules and all. So this is, blue is the one which is relatively free of blood. So you can go for blue. This question was not there. Then how come I got this question? Students only message me. Akka, it wasn't there. Okay. Okay. I got such a question. A shopkeeper adds vitamin A to butter before selling it to consumers. With the practice best classified as, what is it? There is a confusion whether to go for fortification. Some said enrichment was there. Anyway, the answer is fortification. And since there is a confusion whether to go for fortification or something else, let me tell you guys, there shouldn't be any confusion. I've taken the screenshot of this, a picture from your Park textbook. Okay, so it is clearly, this is the latest edition Park textbook. Under food fortification, they have directly given that vitamin A, adding a vitamin A and vitamin D to vanaspati and all these things is coming under food fortification. Okay, yeah, yes. Autoclave, this is actually from microbiology, but anyway, since I got this question, I'm just telling you. Autoclaving is a method of sterilization used primarily mainly for killing spores, right? So it's better to go for biological here. On seeing this picture, even I was confused. What exactly are they trying to show? This is a step well. This is a step well. Okay, picture of a step well was shown. I don't know whether the question this was there or not. Which of the following infection is most commonly associated with the use of such a water source was the question. Okay. Anyway, this is a step well. They could have given a direct step well, but this is such a complicated step well. But, I will show you the picture that I have shared, I have used in my presentation when we were discussing about, entomology. I've told you. When you are getting into the step well, what is actually happening? So we have mentioned about some worm. Which worm? Dracunculiasis. And I've told you one of the strategies for elimination of dracunculiasis or guinea worm infection was abolition of all the step wells. Okay, so here the answer is guinea worm. It was there. Oh, drawing was given. Step well drawing. Okay. This is a problem with recall. Many students will be recalling in their own way. And I am taking an average of everything. So 4 diagrams were shown representing different materials. The same question came in NEET last time. 4 diagrams were shown representing different materials used in water purification, including images of charcoal, alum, lime, all those things. Which is used in rapid sand filter was a question. Which one, guys? It is alum. Haven't I told you that in, you are using alum, and alum flocules can actually clog the sand filter. So you have to do a backwash to remove the alum. So that was, daily backwashing should be done in a rapid sand filter. So we have already seen it. Okay. But in NEET, instead of, something similar came, but it was for, that was actually for, Nalgonda technique, something similar came. There also it was alum only. Screening. I've told you S and S. More than 100 times I have told this S and S. Screening is secondary prevention. You're trying to diagnose the disease at the earliest, and this is a table using which we have done the explanation. Okay. With the following graphs should be used to depict the data shown. I've told you when there are 2 data along the x-axis and y-axis, you have 2 different data, and then both the data will be quantitative variables. Quantitative variables. So the answer is scatter diagram. I'm just seeing image was given here. Okay. It is scatter diagram. And line diagram is to show the trend of the disease, frequency curve, again, by connecting the upper part of the midpoints of your histogram. So all this is again for quantitative. The question is when there are 2 variables, beyond doubt, you can say it is scatter diagram. This is a scatter diagram because there are 2 variables. Yeah. In an immunization, there was some confusion regarding this question, but this is what majority have told. And in an immunization session, there are 2 ANMs. Only 2 hours for them to vaccinate 40 children. There is only 1 vaccine carrier available. So how can you make the session effectively? See, there are only 2 ANMs. Okay, you cannot change the number of ANMs. You cannot increase the number of vaccine vial. Always, resource will be scarce. Okay, so how to make use of whatever available resource? What is the answer here? You have to ask 1 ANM to make records and another 1 to give vaccination. So approximately it will take around 3 minutes for 1 person to vaccinate. Writing the name of that is the one that takes a lot of time. One person can sit and write the name of the patient, then she can enter it in the register, and she can decide which is the vaccine to be given. Then she can tell the other person, and the other person just need to give vaccine. So 1 person can sit and write the recording part. That is very mandatory. And the other person the second ANM can give vaccination. Yeah, 1 record, 1 vaccination. Good. Under ICDS program, the calories and protein supplementation given to children. Guys, this is again from my notes. And I've told you to remember. Easy, 500, 600, 800. And I told you one easy way to remember, 15, 20, 25. Do you remember? I've told you. So this was a question. So it is 500 calorie and 12 to 15 grams of protein. Okay. Life expectancy of 2 countries can be compared by, of course, you know. What is it? It is HDI. Again from the class. Okay. This is in PQLI and HDI, you will find life expectancy. But here it is life expectancy at birth. And so it's always better to use HDI for comparing the life expectancy of 2 countries. And even, you know, the standards of 2 countries, all these are measured using HDI, Human Developmental Index. Because, you know, quality, PQLI has got so many other factors. So it's not easy to directly compare. Major contributor to dependency ratio is, we know dependency ratio has 2 things in the numerator. Which are they? You have young age dependence and old age dependence. In a country like India, which is more, naturally, children will be more, right? So the major... Oh, antibiotic discard. Okay, Ajay, such a question was also there. Okay, Ajay is saying that, oh, that means there were 3 questions from biomedical waste. Oh, okay. Ajay is saying that this, where will you dispose by antibiotics, expired antibiotics? Where will you dispose? Again in yellow, right? In yellow, that is given for incineration. Okay, thanks, Ajay. Thanks. I didn't know that. Okay, why Abhinav is saying roundworm was also there in the option. Abhinav, you mean in that step well, right? Okay, so answer is guinea worm only. So yellow antibiotic, guys. Okay, so total dependency ratio, since they haven't mentioned any country, I mean, let's consider it in India. So naturally, that will be more for child population. So the major contributor will be number of children. Even in India, this is less, whereas this is a huge number. Then which of the following is, oh my God. So it's something very, very, very much expected. And in FMG, they just can't do without asking about maternal mortality ratio. We know what is the definition of maternal mortality ratio, MMR, right? In the numerator, you have the number of maternal deaths. In the denominator, total number of live births into 1 lakh. So number of maternal deaths per 1 lakh live birth is the answer. Let's quickly go through the next one. Rule of half was a question. Okay. Actually, question was not rule of half. The picture was rule of half. We know rule of half is for hypertension. We know that. But here, the question was asked in a twisted manner. Okay. And they have given the prevalence of disease was 30%. Identify how many will get adequate treatment. You might have got it correct. Oh, you didn't get MMR question. Okay. Anyway, 2-3 messaged me. This was there. Anyway, this is about rule of half, right? So it is said that 50% are having disease, right? That means in a total population, 50, if there are 100 patients, if there are 100 people, 50 will be having a disease. Half of that will be diagnosed, right? So 25 will be diagnosed. You know what is rule of half? Out of total patients, only 50 will be diagnosed. Out of them, only 50 will be getting treatment. Out of them, only 50 will be getting adequate treatment. So the question is, what percentage will be getting adequate treatment? So this is total number of disease, total number diagnosed, of which only half. That means 12.5 will be getting treatment. Usme se half. That means around 7 to 8 will be getting adequate treatment. Do we have an answer? Yes, 7.5 is there. Okay, so that is the answer. And a 26-year-old child presented to PHC with, direct again from the note. See, I've told you. Koplik sport. Exact same picture that I have shown you. And I said CCC, cough, coryza, conjunctivitis. Here they have mentioned cough. Measles. Oh, prevalence was another number, 25%. Is it? Anyway, guys, you know how to do it, right? In the question I received, it was 50%. Oh, okay, Mani, okay. Anyway, you know how to do it. So if it is 30, accordingly, you can change. It will be like 3 point something. Okay. A farmer working in rice field presented with conjunctival, suffusion, and icterus. What is your diagnosis? Do you remember? I've told you, I've shown you the picture of that movie, RRR, in class. RRR, even in rapid revision, everywhere I have said RRR. What is it? Rat, rice field, and rain. If any of this mentioned, and if a patient is coming with, conjunctivitis, icterus, calf pain, the answer has to be leptospirosis. Haven't I told you? Yeah. Was this question there? A patient from Manipur was microscopically confirmed as Plasmodium falciparum, which among the following is given. That also we know Plasmodium falciparum, the treatment is ACT, right? I'm not yet done. This is what we normally give. That means ACT SP on day 1, artesunate for 3 days, and primaquine on day 2. But having said that, I've told you, if the patient is coming from one of the northeastern states, then you have to give ACT AL, right? Artemether lumefantrine. So this question was there, no? That patient, I don't know, I heard from they said some northeast was mentioned. Okay, so the answer is 50%. Oh, as rule of half, they have mentioned 50%, and prevalence was something else. Okay, nucleophile. It's okay. So the answer is this one. Okay. Artemether lumefantrine for 3 days and primaquine. A single dose. Okay. Then the rural program had increased number of vaccination and increased hospital deliveries, increased access to healthcare. Still, when compared to urban area, it was less. Which of the following pillars of primary healthcare is most likely exploited? We know, I've told you, this is again from the notes. Primary healthcare, there are 4 principles. And you have to remember it as care, right? Community participation, appropriate technology, intersectoral coordination, equitable distribution. And I've told you, under equitable distribution, the example that I had given was more PHCs in rural area. Okay, more of PHC. This is what I've told you. More PHCs are found in rural area is the example that I've told for equitable distribution. That means more for the needy. Okay, more for needy. Now look at this, guys. Here, the need is more for the rural area, but when you compare with the urban area, it is less in rural area. So the answer is no, not community participation, guys. Equitable distribution. Okay, equitable distribution is the answer. Because I've told you what equitable distribution means. It means more for the needy. The needy is not getting it. It was less. Compared to urban, it was less. Okay, so it is equitable distribution. So we are done with. And this is 29 and 30 question was what Ajay have mentioned. What is it, Ajay? The antibiotic. Discarded antibiotics, expired antibiotics will be discarded in which of the following colored bin? So that makes it 30. And I'm still getting many questions. I'll come back with a detailed recall. So by now you would have understood that these were the questions, and the questions were actually very, very easy. Initially, I got the message, madam, it was less in number. Then when I counted, I got around 30 questions. Okay, guys. So bye and chill. Exam is over. I'm signing out, and we can go to the next session. Bye. Take care.
Good afternoon, everybody. Welcome to the FMGE January 2026 recall questions of radiology. And radiology was heavily tested. There were a lot of images and some lengthy questions also, and some new questions also that were there. So it was a moderately difficult paper, but I hope you still could manage most of the radiology questions. And can we get started with the first image? I think there was a question on a Codman's triangle, and this is a straightforward question. This is osteosarcoma. Codman's triangle periosteal reaction is osteosarcoma. And there was also another image, I think, of the fibula showing a lamellated appearance or a onion peel appearance. And they also said ESR is elevated, fever in the patient. Remember Ewing sarcoma, it is in the diaphysis, right? So it's a diaphyseal lesion. And Ewing sarcoma resembles osteomyelitis. It resembles osteomyelitis. So you'll have all the fever symptoms, ESR elevated, and you will see this lamellated or a onion peel-like appearance of periosteum, permeative growth, bone within bone metastasis, moth-eaten appearance. All of this would be Ewing sarcoma. Okay, they give an image of the fibula, a pretty page of the fibula, I think. That is it. Another image, I think you have got this right. The coin in the esophagus, right? So there was a coin which was in the esophagus in a coronal plane. You were seeing it on the AP view. This is the coin in the esophagus. A coin in the trachea would be appearing a slit-like in the trachea. So this would how it appear on a frontal radiograph in the trachea, right? And let's do the next one. Did we get an image something like this? Intravenous urography image showing a cobra head appearance or adder appearance in the bladder, and they asked the sign. So this was cobra head appearance, right? So they asked the cobra head appearance of uretrocele. So cobra head appearance of uretrocele. So this was the answer. Was uretrocele asked or cobra head appearance was asked? I think cobra head, flower vase, like that, the question was there, and the cobra head appearance was asked, right? Right. Next. Another easy question they gave: bilaterally enlarged ovaries, the follicles arranged towards the periphery, giving a classic string of pearl appearance, and there is increased central stromal echogenicity, right? So increased central stromal echogenicity. This is classic of PCOS, right? So PCOS. So polycystic ovarian disease. They have central thick echogenic stroma, which is producing the androgens, causing all the symptoms of weight gain, acne, and all of that is because of these androgens coming from the PCOS. And another ultrasound image, they said a patient is having an enlarged uterus with multiple cystic areas in the uterus and not showing any fetal parts. This was complete mole or the molar pregnancy. So this was complete mole. And they mentioned snowstorm appearance, right? So snowstorm appearance. This is also an easy question in radiology, right? So this is snowstorm appearance or complete mole. And I think we got this question also clearly mentioning the lambda sign in a twin pregnancy. And remember, when we have diamniotic and dichorionic twin gestation. So when we have one amnion, another amnion, one chorion, another chorion, two chorions, this intervening septa will be thick. This intervening septa will be thick. So thick intervening septa, this will appear like a lambda. So this is called as lambda sign. So lambda sign or twin peak sign is seen in diamniotic, dichorionic twin gestation. Then they also give you a child with cyanosis, and you are seeing a concave pulmonary area and upward cardiac apex, giving a boot-shaped appearance of the heart. Boot-shaped appearance. I hope you got this all right. Tetralogy of Fallot. So there were a lot of repeat questions which would cover a lot of your radiology there. And what did you mark for this? X-ray image is shown what is the correct site for emergency needle compression. What did you mark for this? What did you mark for this? For emergency needle decompression, especially in tension pneumothorax patients, we go for second intercostal space in the mid-clavicular line, right? In the fifth intercostal space, it would be in the anterior axillary line, right? Not in the post-axillary line. So this in children, especially we go for second intercostal space in the mid-clavicular line. So this is the place where we do for the needle decompression here. What about this question, guys? Can you help me with this question? Can you help me with this question? Was there a history of fever in the child? or previous infection? Was there a previous infection in the child? Because they gave two questions. One is two options: acute disseminated encephalomyelitis and herpes simplex encephalitis. So if it is just a fever patient having a temporal lobe involvement, think of herpes simplex encephalitis. But previous infection in the child, vaccination in the child, right? 1 to 3 weeks later, he has this thing, that would be ADM, right? So basically, you have to be careful what was given. Was it a gray matter involvement or is it a white matter involvement? If there is a white matter involvement, that would be ADM, right? Acute disseminated encephalomyelitis. This would be involving white matter. This will be post-infective or post-vaccination. Whereas herpes simplex encephalitis, this will be after a patient who is having high-grade fever with temporal lobe involvement. So existing fever, and this will be gray matter involved, gray matter. So fever with fever patient, temporal lobe involvement, think of herpes simplex encephalitis. Previous infection, previous vaccination in the child, white matter lesion was there. Think of acute disseminated encephalomyelitis. Okay, many students said temporal lobe involvement, herpes simplex encephalitis. We'll go with that. And another question: a preterm baby who is having respiratory distress and a white out lung on the chest X-ray. This is easy. This is hyaline membrane disease or ARDS, right? Acute respiratory distress syndrome. Preterm, and they showed a white out lung, decreased lung volumes, right? So this is ARDS. And I think they asked a barium swallow image showing a posterior midline outpoaching. This posterior midline outpoaching is Zenker's diverticulum. And the Zenker's diverticulum, it goes between the cricopharyngeus and thyropharynx, the Killian's dehiscence, right? So Killian dehiscence, right? Hyaline membrane disease was given, okay. Acute hyaline membrane disease or acute respiratory distress syndrome, right? So fine. Next. What was this question, guys? I just want you to tell me the options on this question. X-rays being produced on linear accelerator. Some students said that there was an option of collision of fast-moving electrons. Collision of fast-moving electrons. Was there something like this? Or was there photoelectric effect? Was there something like this? Collision of fast-moving electrons. If there was collision of fast-moving electrons, right, the fast-moving electrons striking the target of anode, something like that, that would be the correct answer. Okay, so collision of fast-moving electrons striking the target of anode. If that is not there, you can choose with photoelectric effect. But many students said there was collision. You can go with that. Collision of fast-moving electrons with the target of anode would be better answer. With target of anode. Achha, two questions were there on this. Okay. Photoelectric effect and also the collision. Fine. This is PET scan. I hope you got this right. The isotope on PET scan. Simple question. 18 FDG, right? 18 fluorodeoxyglucose. This is the isotope that we use in our PET scan. Next. Next. And this is also a simple question that we discuss in our angiography topic. A young female with hypertension, and on the renal angiography, you are seeing a corkscrew appearance or beaded appearance, or corkscrew appearance or beaded appearance of the renal artery. Such corkscrew appearance or beaded appearance of renal artery, this is fibromuscular dysplasia. Fibromuscular dysplasia. Polyarteritis nodosa would have renal artery microaneurysms. Within the interlobar and arcuate branches, you will see microaneurysms in the renal artery. So if you see aneurysms here, that would be pan. But if you see a corkscrewing of middle and distal part of the renal artery, this is fibromuscular dysplasia. So the better answer is fibromuscular. Young female with hypertension, classic history is also there, and a beaded appearance or corkscrew appearance is there. This is fibromuscular dysplasia. Fibromuscular dysplasia. Next, a non-contrast CT. A non-contrast CT showing a biconvex hyperdense collection, extract collection, which is not crossing sutures, limited by the sutures. This is epitheliomatoma. I hope all of you have got this right, right? So they just asked you the diagnosis. Next. Okay. Renal artery mechanisms were also there in the option. No, but this is not aneurysms. This is fibromuscular dysplasia only. Okay, so fibromuscular dysplasia. Another question was asked, after thyroid surgery, which investigation will you do to find metastatic disease in after thyroid surgery? So if it is a thyroid cancer, a iodine scan would be better to look at the metastatic disease, right? So iodine scan would pick up the metastatic disease after thyroid, if the question was on thyroid cancer, okay, thyroid cancer metastasis. And this was, slightly on the tougher side for you all. So they asked scanning classification. And for sarcoidosis, they gave all the history: fever, low-grade fever, dry cough, ACE levels are elevated, right? And this was classic sarcoidosis. And yeah, they showed you a radiograph. If you see hilar lymph nodes and parenchymal involvement, this is stage 2. Stage 2. If you only see hilar lymphadenopathy, it is stage 1. If you see only pulmonary infiltration without lymphadenopathy, that is stage 3. And if you see bibasal reticulation, honeycomb lung, that is pulmonary fibrosis. So based upon how the image on the X-ray was there, you plan it out, right? So you plan it out. Next. Next thing. Was there a question like this? A child who is coming with, cough, malaise, difficulty breathing for the past 3 days, and a radiograph showed a right upper lobe consolidation. You are seeing the air bronchograms. You are seeing this opacification of the right upper lobe. So this is right upper lobe consolidation. Can you confirm me? Was this question there? If the question was limited to thyroid metastasis, iodine scan would be the answer. Okay, so I have not got that question. But if you are saying that it was about thyroid cancer metastasis, iodine 131 scan would be preferred. Okay. Okay, so this is right upper lobe consolidation. Yes, right upper lobe consolidation. Next. Two different questions. For one question, answer was photoelectric effect, and for another question was collision. So they asked the same thing for linear accelerator in two different places. Okay. Another question, a 35-year-old woman is having a road traffic accident, and the heart rate is 89 per minute, blood pressure is 110 per 80, and just X-ray is given, and you see opacification in the right hemithorax. So after trauma, you are seeing opacification. You should think of hemothorax. So here the answer is hemopneumothorax, right? So hemopneumothorax. Next. Then, did you get a question like this? A HIV positive male with fever, right upper abdominal pain, sense of fullness in the abdomen for the past 2 weeks. There is tender hepatomegaly. CT scan shows hypodense lesion, and you are seeing this unilocular lesion with some air inside. So air foci inside. This is a liver abscess. So this is liver abscess. So unilocular. Hydrated would be multilocular multiseptic. Multilocular multiseptic, showing either a floating membrane or multilocular multiseptate. So liver abscess is generally unilocular, right? So this is a liver abscess. Next. And there was one more question where you had a full-term delivery and there was mild respiratory distress and tachypnea. And the patient also shows fluid in the interlobar fissures, which cleared in the next 24 to 48 hours. So this was transient. As the name says, they also mentioned that it cleared off within 24 to 48 hours. So that is transient condition, transient tachypnea of newborn. Please remember how to differentiate hyaline membrane disease and transient tachypnea of newborn on the radiographs. The lung volume will appear reduced. The amount of blackness in the lung will be less in case of hyaline membrane disease. The lung volumes will be normal. The lung volume will be normal or slightly increased, right? Slightly increased in case of transient tachypnea of newborn. The hyaline membrane disease, it will show you whiteout lung. One question on whiteout lung was there, whiteout lung. And transient tachypnea of newborn, you will see perihilar fissural fluid giving a sunray appearance. Sunray appearance or around the perihilar fissural fluid. So in the interlobar fissures, in the perihilar areas, you will see this fluid in that area. So that is sunray appearance. And hyaline membrane disease, we all know, is premature delivery, and this is a term delivery after cesarean section or precipitous labor in the child. So they give you cesarean section also. So this is classic transient tachypnea of newborn, transient tachypnea of newborn. So I hope you have got your radiology questions mostly correct, and I wish you all relax now. This is the time, you have fought so well, you have studied so much, you have gained so much knowledge for the last 6 months. This is the time to relax. Just look at the recalls. If you feel you're doing well enough, chill out, relax with your parents, relax with your family. and you know, best wishes from our side for a very positive result for each one of you. So I think, you know, don't be too much. The questions were some questions were tricky, but they don't decide your result. The overall general questions that you EDH question you got, right? So many highly membrane disease questions, so 18 FDG question. So overall, your results should be on the positive side. Okay, best wishes to each one of you. All the best. Okay, thank you. The options also. Okay, X-ray was also given. Yeah, fine. Okay. Okay, please share whichever questions you feel. Fine.
Good evening, friends. We are going to now see the FMG questions of January 2026 conducted yesterday. So there are around 25 to 30 questions asked. Let us have a fast review of the questions. Just only question and answer. Any doubts you have, we will have a detailed discussion later. But identify the condition given in the image below. Yes, what's the answer? It's a external angular dermoid cyst. See, there are simple question. I hope most of you would have been correct in this. So what is the condition given in this image? This is a ranula. It's an extravasation cyst of sublingual salivary gland, a ranula. So 2-year-old malnourished child is brought with a rectal prolapse that protrudes through during crying and defecation. On examination, the prolapse is reducible and measures around 2 centimeters. There is no bleeding, ulceration, or signs of strangulation. What is the most appropriate initial management? And this is a small baby with a malnourished baby. So malnourishment is a cause of rectal prolapse. No need of surgery. You just digitally reposition it and wait for a few days. It will become all right. So no surgery needed. So most appropriate initial management. Even they are asking not the surgical. Their initial management is digital repositioning of the prolapsed rectum in a 2-year baby. That's the answer for this question. Elderly lady after neck surgery can't sing in high pitch voice. What nerve is injured? Loss of timbre of voices? No, not RLN. What is the answer? External branch of superior laryngeal nerve. So loss of timbre of voice or huskiness of voice is due to loss of external branch of superior laryngeal nerve injury. Answer is B. What is this condition shown here? It's a erythrocyte, cobra head or adder head appearance, showing you erythrocyte. Leave it. So 52-year-old woman presents with a breast lump size 4.5 centimeter mobile axillary node. Tell me what is a T? T staging of 4.5 centimeter. It is between less than 2, 2 to 5, more than 5. So T2. T2 is 2 to 5 centimeter. Then mobile axillary node is N1. So T2, N1. What does it fall under? Stage 2B. So could now 1 vanduchna 1. Could 2 vanduchna 2A. When you count, it is 3. T2 plus N1, 3. T3 is 3. That is 2B. So the answer here is 2B. In this case, that is 2B is option. Sorry, T2 N1. So what is it? It is 2B. Woman presents with itching and eczematous change over the nipple biopsy of the lesion as shown in the image, what is the most likely diagnosis? This is a classical Paget's cells. You can see the Paget's cells. So this is a Paget's disease. Paget's disease, the cells are large cells with a clear cytoplasm and eccentric nucleus. Not in the center, the nucleus is pushed to the eccentric location as you see in this picture. You can see that it's a classical Paget's disease. A patient comes to hospital with a lacerated leg injury, appears as shown in the image with no active bleeding. She is conscious and follows command. How will you triage? Red, yellow, green, black. Which is correct? This is yellow. Second, okay. This is direct table from Bayesian law. So degloving injury as shown in this picture will come under yellow. And third degree is minor laceration. Small lacerations will come in third degree. So this is an extensive degloving injury. So let us go with yellow. 25-year-old man sustains head injury after a fall. He had a brief loss of consciousness, then became completely normal and conversed with relatives. He had a lucid interval. 2 hours later, he develops worsening headache, vomiting, and drowsiness. Examination shows what is this hematoma? EDH. Can you see it's a biconvex EDH hematoma. 46-year-old woman presents with long-standing heaviness, aching of the legs, worse on standing, relieved on elevation. On examination, you can see the image provided. According to CEAP, this is just varicose veins, no pigmentation. What is this? It is C2. Only varicose veins are seen. Therefore, it is C2. If you have edema, I would have gone for C3. Therefore, the answer is only C2. 55-year-old man with a long history of tobacco chewing presents with non-healing ulcer on the lateral border of the tongue. The lesion is painful, indurated, and has irregular margin. The tongue has a suspicious of malignancy. For this ulcer, how will you take biopsy? Yeah, it is an incision biopsy or wedge biopsy. Wedge biopsy or incision biopsy. Elderly male has a progressive dysphagia, regurgitation of undigested food, halitosis, and nocturnal cough. Barium swallow X-ray shown here. This occurs due to herniation through weakness of which muscle? Ideal answer is inferior constrictor muscle. But inferior constrictor is not there in the choice. Therefore, we go for cricopharyngeus. Cricopharyngeus is the answer here. Pharyngeal pouch. 5-year child presented with emergency with difficulty in swallowing and drooling of saliva. There is no history of fever or cough. On X-ray AP view, what is this? Esophagus coin. It is O-shaped in esophagus. The child was brought to your OPD with a groin swelling, which mother noticed while the child was micturating. The swelling was going down medially. So, what is the swelling? Indirect. See, direct hernia every child grow. Question is very clear. Child will develop only indirect hernia. So, the swelling was growing down medially is mainly to differentiate you from undescended testis and direct hernia. So, undescended testis will ascend up, whereas hernia will descend down. It is indirect inguinal hernia during micturition. Young patient who underwent lumpectomy was found to have ductal cancer in situ, only 2 millimeter margin. How will you treat further? Ductal cancer in situ. What is the grading used now? Based on one grading. Van Nuys grading is used to decide further radiotherapy. Van Nuys scoring system is a scoring for ductal cancer in situ that helps guide treatment, especially regarding radiotherapy by combining factors like tumor size, margin width, nuclear grade, and necrosis and patient age. So this is a young patient and very less margin. So I should give post-operative radiotherapy for this case. What is this graft? Splits thickness graft. It is not full thickness graft. It is split skin partial thickness graft. A burns patient comes to emergency with increased levels of hemoglobin, falling saturation, and nasal hair is singed, means nasal hair is burnt. There is chances of injury to the trachea. So what should I do immediately? Intubate. Saturation is falling. The patient is probably developing tracheal edema. Immediately intubate the patient. Patient comes with a stab injury from cricoid to angle of mandible in this zone. What will you do? There is bubbling of air, means you probably injured the trachea. So what is the zone of injury? Zone 2. You should immediately explore. You have injured the trachea. Explore. During upper GI endoscopy, a constriction ring was noted at 40 centimeter from the incisor. The constriction ring is due to diaphragmatic opening, 15 centimeter cricopharynx, 25 arch of aorta left bronchus. What is diaphragm? A neonate comes to OPD with a big swelling on the neck. What is this? Cystic hygroma. It is not an emergency. We can wait for 1 year and then operate. So surgery is done after 1 year. Submandibular gland having a radio-opaque shadow. It is nothing but submandibular stone. What should I do? Removal of submandibular gland is done. What is the investigation of choice to identify extrathyroid spread of thyroid neoplasm? What is the investigation of choice to detect metastasis in thyroid cancer? Radioiodine scan. Radioiodine scan is used for detecting the metastasis in thyroid neoplasm. A trauma patient comes with the ARDS, acute respiratory distress, hypotension, tracheal deviation, absent of breath sounds. The diagnosis of tension pneumothorax is suspected. Now see the question. What is the most appropriate step? Needle decompression is the next step, but they are asking most appropriate. So which will be the best? Putting an ICD tube at the 5th space is the most appropriate step. Which artery is responsible for bleeding in posterior duodenal ulcer? So that is a gastroduodenal artery, is the artery seen posterior to duodenal ulcer, first part ulcer. 52-year-old man develops sudden chest pain following a vomiting and heavy alcohol intake. He has mild fever. On examination, there is a crepitus on the lower neck. Breath sounds are reduced on the left. What is the next step? What is this case? This is a classical case of barotrauma or Borag syndrome. I immediately should do next CT of the chest with the oral contrast. A is the best answer here. A malnourished patient with a steatoria is under investigation with a calcification in the head of pancreas. Can you see? There is a calcified pancreas which is non-malignant. Amylase is normal. What is this case therefore? It's a case of chronic calcific pancreatitis. What should I do? I should give enzyme supplement. Patient is malnourished, no? So I will give pan-lipase, pancreatic tablets to improve the nutrition. A man undergoes TORP for BPH. About 45 minutes into the procedure, he becomes restless and confused with nausea and vomiting. BP 160/90, heart rate 52, saturation 95, ECG shows sinus bradycardia. Post-operatively, post-op lab shows serum sodium 125. What is the most appropriate management for him? This is a dilutional hyponatremia, water intoxication. What should I do? Hypertonic saline should be given immediately. After that, I will also give furosemide, but immediate next is hypertonic saline should be given for hyponatremia. A junior surgeon is performing a laparoscopic cholecystectomy and accidentally cuts the common duct intraoperatively. What is the most appropriate step? The question is very important. Junior surgeon is performing. He might not be experienced with bile duct repair. So what he will do? No, avoid the procedure and put the drain. Update drain which he should refer to higher institute. So the answer is avoid the procedure and put a drain. If a senior surgeon is performing, what we will do? Repair the bile duct. Simple question. It is already asked AIMS question. During parotidectomy, which anatomical landmark is commonly used to identify the main trunk? Conless pointer is the place where the facial nerve starts. It is at the junction of external auditory canal, cartilaginous part and bony part. It is Conless pointer. Answer is B. Which is the primary vein involved in varicose vein? Yes, great saphenous vein. That's all. These are the questions. We had around 30 to 35 questions. Hope you are strong in these questions. So thank you all for the session. Sir.
Okay, good evening, my dear doctors. So, as you know, we will further we will do recall in the more clear form. So, whatever answers we are having, according to that, question number one: patient came with history of road traffic accident. So, identify the pattern of breathing shown by patient as shown in the diagram. So, you can see very clear cut crescendo and descendo. So, I think there is no doubt in this diagram. Most of you are agreeing with this diagram that there was a crescendo and descendo, and it is a clear cut Shane stroke breathing. So whenever there is a apnea, apnea means what? Increase in the PCO2. So whenever there is a apnea, automatically PCO2 will increase and causing hyperventilation. And when hyperventilation will set out, CO2 become normal and this again become normal. And then again there is apnea. So when there is a apnea, crescendo and descendo, it is Shane stroke breathing. So here I think there is no doubt in this answer. Shane stroke breathing. Small breathing, you know, it is the air hunger, mainly in diabetic ketoacidosis. Biot breathing is mainly the head injury, and apneustic breathing is when there's a prolonged inspiration. So when there's a mid-pontine damage where vagus nerve is intact or cut, it is cut. In that condition, there's apneustic breathing. But here it is a clear-cut Shane stroke breathing. Okay. So proper recall we will do at the app. We know that. So a tourist who visited a mountain range developed nausea, vomiting, and headache while descending rapidly. So what is the treatment of choice? Now, so many, options people are telling. Some are saying that question was that he was descending, and some people are telling that dexamethasone was a separate option and oxygen therapy was a separate option. Okay, can anyone tell me the exact option? I will discuss each and every option here. Acetazolamide is actually to enhance acclimatization. It is there to enhance the process of acclimatization because it is carbonic anhydrase inhibitor. So carbonic anhydrase inhibitor is given so that all the bicarbonate will go in urine, creating metabolic acidosis and respiratory alkalosis. How? By causing hyperventilation. So you are creating artificial hyperventilation so that you can get acclimatized to the environment. So acetazolamide is a wonderful drug, but for acclimatization, here problem is different. Some of you are saying that answer question was pulmonary edema. Okay, anyway. And nausea vomiting, ondansetron is only for nausea vomiting, not for this mountain sickness. Descent to the lower altitude is the first thing which we do. The first is oxygen therapy and immediately go down. What we say? Go down. But oxygen therapy, if it is given alone, it can be the answer. But students are saying dexamethasone. So dexamethasone is given in high altitude cerebral edema. His. And they're asking about pulmonary edema mainly. So, according to the question, answer will change. We will further research on this question. What is the exact option? And I will again recall on that. Third question is very clear cut. This is a pressure volume loop curve. If you remember, I have discussed so many times this diagram in the PYQ session, in the main video session. It is one of the most important diagram which is coming every year. So they are asking point C. What they are asking, doctor? They are asking point C. So you know, point A to B is ventricular filling. Point A to B is ventricular filling, and BC is isovolumetric. What is this? You can see pressure is increasing, isovolumetric contraction, and C to D is ventricular ejection, and this is your isovolumetric relaxation. So from point A to point B, if you remember, we have discussed so many times, doctor, point A to point B, volume is filled. It is ventricular filling. So volume is increasing, ventricular filling. But from point B to C, what is happening? Isovolumetric contraction. And point C, aortic valve will open and rapid gush of blood will happen in the aorta. So aortic valve will open. What will happen at point C? Aortic opening of aortic valve, isn't it? So this is a clear cut question where answer will be aortic valve open. I think there is no doubt in that. Okay. Now, then again identify the point marked A, B, C in the given diagram. See, this is the first diagram which we discussed in the general physiology. Number one is Rio base. So minimum threshold the minimum threshold, you can see the minimum threshold, okay, which can create the minimum threshold which can create stimulus is this one. You can see here this one. This is the minimum threshold. And this point A is called as Rio base. So what is Rio base, doctor? Rio base is the minimum threshold which can create a stimulus. So A will be Rio base. And what about B? B is twice the Rio base. Twice the Rio base. And that is called as Cronaxi. So B will be Cronaxi. And C is the time taken by Rio base. It is called as utilization time. So you can see here answer Rio base. Answer will be Rio base, Cronaxi, and C is utilization time. Okay, so answer will be here A. Now, a patient present with the history of head trauma, on examination he has hypertension, bradycardia, high intracranial tension. Identify the reflex. Very clear cut question. Cushing reflex. Cushing reflex is having a triad of hypertension, reflex bradycardia, and irregular breathing pattern. And this happens whenever there is head injury because of increase in the intracranial tension. So whenever there is increase in the intracranial tension, there will be hypertension, BP will be high, reflex bradycardia, and irregular breathing. So there is no doubt answer is Cushing reflex. Bain-Bridge reflex, if you remember, tachycardia due to right atrial distension is called as Bain-Bridge. J reflex, everything will come down. BP will be low, heart rate will be low, apnea will be there. So J reflex is different. Bejold gyrus is also different. Okay, so here we are getting a typical Cushing triad. So answer will be Cushing reflex. Okay, now in this action potential graph, at which point of total refractive period, the sodium potassium conductance ratio will be least. So if you remember the action potential, okay, you know this point is called as depolarization. What is this called as? Depolarization. This is called as repolarization. This is called as hyperpolarization. And what is the question? Question is that sodium potassium conductance is least. The sodium conductance is maximum here, and it is going to minimum at 0.4. Hyperpolarization. So here answer is going to be 0.4. Okay. Now next question. A male patient come with a head injury. He can talk fluently but cannot understand diagnosis. Now some students are saying that question was that there is an injury in the part of superior temporal lobe. Even then answer will be Wernicke's area, because superior temporal area is for Wernicke's area and inferior frontal gyrus is for Broca's area. In the Broca's area, words are broken. Fluency is lost. But here, he can talk fluently. Yes, Dr. Niveda, supratemporal was mentioned. Okay, then it is a clear-cut Wernicke's area. If superior temporal is mentioned, there is no doubt. And he is talking fluently and he can understand. Comprehension is there. So answer will be Wernicke's area. Okay, so there is no doubt here. Now, this diagram I'm discussing for last 5 years, and every year they are asking this question. Why? Because there is a misunderstanding. People are considering urinary bladder as an elastic structure. It is not elastic, it is plastic. Lungs are elastic, bladder is plastic. And for that, there is a diagram called as cystometrogram. So the pressure varies till 400 ml, then rises disproportionately to volume after 400 ml. What is the reason for this phenomena? See, when urine is only up to 50 ml, this will cause first urge of micturition. So when 50 ml urine is there in the bladder, we will have first urge of micturition, 50 to 150 ml. And from 150 ml up to 400 bladder is although filling. See, Laplace lies P is equal to 2T by R. Now, when tension is increasing, radius is also increasing, so pressure remains constant. So at this point of time, he will not have any urge of maturation. Sometimes you feel immediate urge of maturation. Yes, doctor? The question asked about the mechanism by which pressure can. Yes, mechanism is Laplace law. This is the plasticity. This is the plasticity. That your bladder is plastic. So why it is plastic? Because of Laplace law. Answer is not this. Answer is Laplace law. Compliance of the bladder. So although that tension is increasing, radius is also increasing. So Laplace law is P is equal to 2T by R. Okay, doctor? So if tension is increasing, radius is increasing. And this is the beauty of smooth muscles, that they can be plastic, they can be elastic. So your bladder is not elastic, otherwise urine will go back in the kidney. Urine should not go back in the kidney. Bladder should retain, your stomach should retain the food. Bladder should retain the urine. Uterus have to retain the baby. Baby should not come up to 9 months. Why? Because bladder, uterus, they are plastic. And which law is explaining that? Answer is Laplace law. Laplace law. Clear? Now, in a pregnant female in a third trimester, she experiences shortness of breath. What is the clinical coherent? So, if someone is hyperventilating, CO2 loss will be there, and CO2 loss will cause respiratory alkalosis. So, respiratory alkalosis due to hyperventilation. When I am taking class offline or online, I always say from pH chapter. I usually take 1 hour to discuss pH. There are at least 8 MCQ in physiology, biochemistry, medicine. You cannot skip this chapter. That is why in the main app, I have discussed in a detailed manner. Okay, the pH. Okay, there are so many questions this time also. This is again from the ABG. pH is 7.2. PCO2 is low. Bicarbonate is low again. Yes, this was the exact question. Bicarbonate is low. pH is acidosis. And base is also low. So metabolic acidosis with compensatory respiratory alkalosis. Metabolic acidosis with respiratory compensation. Okay. So these are very simple question, but I tell, if you are advising a junior, please tell them, please discuss, pH chapter in detail, because it is an integrated topic from physio, biochemistry, medicine. And you can get 6 to 8 questions directly or indirectly from this chapter. Okay, the buffer physiology, the kidney, how kidney is excreting the urine, what is RTA1, RTA2, RTA4. So this topic is very important. This time also they have asked 2 or 3 questions directly, I have told you. Now, a scientist is performing experiment on a nerve. He applied a stimulus during refractory period. Excitation does not happen because, now this question when I was explaining, if you remember the diagram, I have drawn this diagram that voltage gated sodium channels have one activation gate, other inactivation gate. And when I was teaching this, people are saying, why are you going in so much detail? It is not needed for FMG. Then I say, no. Nowadays, they're asking detailed concept in FMG as well. So now almost concepts are same for INSCT, NEET, PG, FMG. Okay. So this is called as activation gate. This is called as inactivation gate. And there I have discussed that this is the resting period. In the resting period, activation gate is closed, inactivation is open. During depolarization, my dear doctor, both gate will open. But during absolute refractory period, if you remember the diagram, activation will open, inactivation will close. So I don't know exactly what is the option given, but the answer will be sodium inactivation gate will close. This will be the exact option. The inactivation gate of sodium will close. Now sodium cannot come inside. And this is creating refractory period. This is really, actually, this is a repeat question from INSCT 2014. Okay. Now, a 54-year Female present with the complaint of hot flush because of the menopause, night sweat, amenorrhea. So what would the hormonal profile you know? FSH, LS goes high, estrogen goes low. So FSH, LS go high and estrogen low. It is a clear cut. It is a one-liner you can say. Okay, so this is it from physiology. Yes, anyway, sodium channel closed was the option given. Yes, answer will be sodium channel closed. Okay, thank you. But if they have given inactivation, then that will be proper. Inactivation, sodium channel gate will be closed. If inactivation is not given, then answer will be sodium channel closed. Okay, not potassium channel. Properly, I will re-record it with the proper options. So that recall I will again do. But for that, I have to research what are the correct options. And only then I will do the proper recording. Okay, till then, bye-bye, all the best.
Hello friends, Dr. Dhawan here, your ENT faculty with doctorals. I hope the exam went well for you. And ENT had lot many questions this time. And my apologies for the video quality, audio quality, because I'm recording it from one of the airports in Kyrgyzstan. So it may be a little bit less audio video quality. Please bear me with that. And this is not a full final recall. It is just the first impression of the paper. What kind of question came in ENT? What kind of domains they asked over there? And we'll touch upon those domains and what was the question over there, and we'll come to the answer also as per the the choices given by the students till now. However, except disclaimer is there will be certain changes in the days to come in the full sentence of question and the choices, and we'll finally upload that on the app as well after refining all the questions one by one. And there may be additional question in addition to what we are going to show you now. So let me start with the ENT question number 1. Very much expected question, and I think you remember we discussed in the QRP video also. A patient underwent thyroid surgery, unable to sing song properly after that, and which nerve got injured. I think time and again we discussed in the video lectures also that whenever patient underwent thyroid surgery, you have to take care of two things. If patient is unable to breathe properly after thyroid surgery, it's a bilateral RLN injury situation. And if patient is not able to sing the song properly, it is due to SLN or ELN injury question. And I think answer given, information shared by the student is the SLN nerve was there. And I think we know the external nerve is a branch of SLN, and it's by the cricothyroid muscle. And cricothyroid is the main tensor of the vocal cord. And due to loss of tensor property of the cricothyroid, we get the poor quality of voice. Therefore, patient is unable to sing a song. I hope all of you got this question correct, because this is discussed pretty at length in the MIQ section also, most important question section of the app as well. Second question, very, very popular domain again. I'm sure you will be happy seeing this question, laryngomalacia. The infant has got stridor since birth. And I think we know most common cause of neonatal stridor is laryngomalacia. And they give ample number of more clues over there. The stridor is increasing on crying and increasing on breastfeeding and all that. And the question asked, as per my understanding, was that what is true about it. So it's omega-shaped epiglottis. And the second thing they gave along with that the stridor improves in prone position. So I'm sure you will be remembering laryngomalacia, omega-shaped epiglottis. I would like to share with you that this was expected question, and it was again one of the question in the MIQ section as well of the app test and discussion videos as well. So please share with me in the comment section what was your feeling when you saw the thyroid surgery question and the laryngomalacia question over there in the exam over there. Okay. Now, the third thing is what again very much I think we put a star on the page of this, that chronic smoker with the husky voice and image given. I think very beautiful image. Ring case edema. Ring case edema is bilateral diffuse swelling of the vocal cord. And the most common cause is smoking. So gave the very ample number of hint into the visual question also and ring case edema. And I'm sure you would have scored all these three questions correctly, because these were really very, very expected MCQs also and very commonly discussed question as well. Sorry for the announcement during the airport. I'll wait for that. Now the construction worker with hearing loss. So construction worker with hearing loss, there is a subtle kind of clue over there that patient must have been exposed to high level of noise, because noise induced hearing loss is definitely a possibility in the people who are working in the shipping industry, metallurgical industry, textile industry, or construction industry. Because construction industry involved a lot of drilling over there. So, and they give you image-based question, and 4,000 hertz dip over there, and this is called the acoustic dip or boiler's notch. And what the diagnosis in this case was noise-induced hearing loss. Noise-induced hearing loss was the answer to this question. Okay, fine. And I'm sure you would have attempted this question also correctly. A lot of time discussed in the lectures and in the test and discussion format as well. Again, audiometry. Second question was, again, as per recall given by the students, I do accept that there may be chances of certain question being here and there over there. So they showed you an audiogram, one on this side, one on the other side. And the very beautiful thing was, if this was the question right side and this was the left side, and both the audiogram had AB gap over there. So this AB gap is indicative of conductive hearing loss? The answer of this question was bilateral conductive hearing loss. Please do share in the comments that was the learning made in the classes helped you during the real exam as well, because the whole endeavor of doctoral's team is to create that kind of material which actually is utilized by the students for the exam purpose also, because on the exam day we should be of value by making you solve more number of questions correctly. So we would love to hear from your side also that how are your emotions when you see such kind of question over there. Now again, audiology, one more question, tuning folk test. They asked a very beautiful question again, as per the recall given by students, that they say that patient with a hearing loss, Rene was positive on both sides. Air conduction better than bone conduction on both sides. So Rene positive can be seen in two situations, either normal or it can be SNHL. Normal was not in the choice. Normal was not in the choice. Both were either right SNHL or left SNHL. So two choices were there, right and left. But now they're saying that Weber is heard in the left ear. Weber is heard in the left ear. I hope remember, in SNHL, Weber is heard in the better ear. In SNHL, Weber is heard in the better ear. So it means that left ear is the better ear. Better ear. Okay, fine. So it means that the patient will be having right SNHL. I explain one more time. Why SNHL? Why not conductive? Rene is given positive, it's SNHL. Why not left Rene? Because in SNHL, Weber is heard in the better ear. In this case, the Weber is heard in the left ear. So left ear is the better ear. Patient must be suffering from right SNHL. I hope you got this question correctly. Cancer larynx, they were saying two questions were there. I'm not sure about that. But one question which everybody is sharing is that glottic cancer with limited cord mobility was given over there. Limited means that it's not fixed. It's not immobile. I hope remember, fixed or immobile vocal cord is T3. It's not T3. For T3, it has to be fixed or immobile vocal cord. When they say limited, it means it is still moving. It is T2. And I hope remember, for T1 and T2 cancer, we go for radiotherapy. The choices were laryngectomy, chemoradiation, radiotherapy alone. But this is a T2 glottic cancer. The best treatment will be radiotherapy. Why not T3, sir? Because for T3, the word is cord is fixed or cord is immobile. Limited cord mobility will go towards T2. And I think anyway, it's simple. T1, T2 go for radiotherapy. Laser was not the choice anyway. There was no choice of laser over there. Very simply, T1, T2 go for radiotherapy. So I think we know the answer. Laser was not the choice. So there was no confusion over there, as per the recall shared by the students. Then very much expected question of rheumatology with ENT, vaginal granulomatosis. And I think this question must have given you a smile, because this was supposed to be a little high level question, but saddle nose deformity with crusting in the nose and necrotizing vasculitis over there. Vasculitis. I think ample number of hints over there. It is not leprosy, it is not tuberculosis, not syphilis, vasculitis, and I'm sure you know from your autoimmune knowledge about pathology topic, rheumatology topic, that vaginal granulomatosis is also polyangiitis. Polyangiitis, it is actually, the very, very common rheumatological disorder which is presenting in the ENT as well. Okay. So why it is not other possibility? Because they gave you the history of the patient along with pathology picture. Pathology interpretation was there, necrotizing vasculitis. And the answer is very clear, vaginal granulomatosis or polyangiitis can say over that. Okay. Now, what could have been better? They asked you rhinoscleroma treatment. Woody nose caused by Klebsiella rhinoscleromatis. And the treatment is, of course, medical treatment, tetracycline and streptomycin. The medical treatment is what? Tetracycline, streptomycin. And for the cosmetic part, you might do the surgery also along with that. But I think they gave you the treatment option as that, which is very, very easily discernible. It is the tetracycline, streptomycin was definitely in one of the choices over there only. So anybody remember rhinosporidiosis, D, Dapsone come in rhinosporidiosis. In this case, come tetracycline, streptomycin, woody nose. That is the drug of choice. That was the correct answer in this case. I think we would have done this question correctly. Mucormycosis treatment, pharmacology, ENT overlap question. I think we discussed this question in the most important question also, and in the CPR session also we did that. That in mucormycosis, don't write just amphotericin B. The best answer will be liposomal amphotericin B with the debridement. Because if you don't do the debridement, the drug will not be effective. So I hope you scanned all the 4 choices correctly and you went down over there. It was liposomal amphotericin B along with debridement. So that was again a very scoreable question over there. Now, beautiful question, microtia. What is a cosmetic surgery year? Which age you do the cosmetic surgery? I think bat year. Bat year, we remember the absolute antihalix, and the plastic surgery of pinna is called otoplasty, and the age of surgery is 6 years or above, because let the pinna grow fully and then we do the surgery. The same rule applies here also. And the choice, one of the choices was 6 to 7 years, and that's the correct answer over there. Okay. I hope you could interpret bat year to microtia and get this question correctly over there. Okay. Now, there were 2 questions of oropharynx actually. Picture based, because I don't know exactly what they asked, but yes, one of the questions which everybody agrees in the various group is, they ask, what is this? I think we all know that this is palatine tonsil. They ask, which one? Adenoid is nasopharyngeal tonsil. And this real tonsil is what? Palatine tonsil. This is one question, definitely, which was asked. 2 questions were asked on this picture, but the second question is not yet clear. The final recall, we will be collecting more data and we'll be uploading on the app in the week to come over there. This is palatine tonsil, the other name of tonsil. Okay. And again, oropharyngeal, we did a long discussion of palatine tonsil lined by, non-keratinizing stratified squamous epithelium. It is also called palatine tonsil over there. Second question I'm yet to find out. We will definitely work on that with the other students. Surgery question, coin story, esophagus, whenever there's a dysphagia was given. When dysphagia is there, it can't be tracheal foreign body. The 3 foreign body, airway foreign body are laryngeal, bronchial, tracheal. They are what? The airway foreign body. Any full, circular shadow in the AP view with dysphagia given, it's an esophageal foreign body. It's a very easy mark to crack over there. Now, and lastly, I'm not really sure about again this one. Tympanometry based question, image based question came, and they asked this time that they gave the image of the some curve. I hope you remember the multiple type of curve we know, A curve, B curve, AS curve, and they gave something like this, they say, or maybe this thing, and they asked what is the name of investigation, is tympanogram. However, again, recall is having, some scope of improvement for sure. So overall, if you ask me, around 16 to 17 question were pure ENT question this time. And I really hope, I really pray that you would have scored majority of them correctly. And people who have revised the main content and main notes, they would be definitely having at least a smile during the ENT part of the paper too, which will make our journey better. Let us hope for a wonderful outcome. Do not really, start analyzing your paper, because paper looks little tougher. But if you combine paper 1 with paper 2 and overall we'll pass the paper, let us maintain a very, genuine hope of passing. Don't get anxious unnecessarily. Don't waste this time. Be with your parents, be with your friends, spend some quality time with them also. They also are looking forward to spend time with you. Do not really just keep on sulking, interpreting the paper in this way or that way and expecting a bad outcome. Do not do that. Have a good time, relax, you deserve actually. And pray for yourself, pray for your friends also. May everyone pass the examination. Good luck, and we'll coming back to the app once again after 1 or 2 weeks with the more refined recall with all the 4 choices and 4 statement. I wanted to keep it like this only because I'm not sure about a lot of choices being shared, and I don't want to create undue confusion over there. Thank you very much. Good luck over there.
I think we're live. So, okay. Good evening, everyone. I'm Dr. Sandeep Sharma, your pediatric faculty at Dr. Tutorials for NEET PG, FMGE, and INISET. And I'll not take much of your time. It's a Sunday. You all have prepared well for the exam. You have done well in the exam, I'm quite sure. And I'm going to rapidly go through the questions. Let me tell you a fact. This recall is based upon what you people have told, right? I have not sat in the exam. So if there is something missing or something which needs to be changed, most welcome to point it out. Detailed version where I am, pointing out every single option that I will be taking up separately later. For now, you need to have an idea how the exam was. Talking about pediatrics was a bit atypical because there was no malnutrition. In fact, in the last 7 years, I would say, first time there was no direct question on malnutrition. In one way, it was atypical. Second, neonatology had more questions and systemic tilt was seen. But at the same time, if you have been thorough with the Dr. Tutorials videos, QRP videos, MIQ session, and the workbooks, you should have scored at least 90-95% questions correct. One question was a twister. We will talk about that. Let us not waste any time. Start with the session without wasting any time. So, good evening, everyone. Good evening. So I'll try not to look at the comment section so that I can finish off the session on time. Any doubts, you are most welcome to reach out to me. Let us start with question number 1. APGAR score. I've discussed with all of you in innumerable classes and I've put questions in my RDX series and MIQ series also. Question number 1, newborn is evaluated immediately after birth. Baby is blue in color, weak respiratory effort, no muscle tone, heart rate less than 80 and shows no response to stimulation. What is the APGAR score? Let us calculate the APGAR score. 5 components of APGAR score. Baby is blue in color means you give a score of 0. Completely blue, give a score of 0. Weak respiratory effort, you give a score of 1. No muscle tone, limb flaccid child, score of 0. Heart rate less than 100 per minute, you can see here, we give a score of 1. And no response to stimulation, score of 0. So 1 plus 1, the total is 2. The answer is B. Most of you have got answer B correct. Many of you might be thinking, ki, sir, ye to aasan tha. See, if you know the topic, if you are well prepared, it's an easy question. If you are not well prepared, for somebody who did everything and left APGAR score or he or she was not very accurate, it will be a tough question for that student. So 1 plus 1, 2. If you have got it 2, you are safe. One step closer to the goal of 150. Let us go to question number 2. And question number 2 was the problem area. I've tried to take this image because students said, sir, blue pant, blue color ka kuch dala tha, and it was a animated image. I'm not sure what the question was. This was what I got from multiple students. In case there is a change in the language, you can ignore that. What question is saying is, on examination of a baby, Moro's reflex is present, but it is asymmetric with reduced abduction of the right arm. Infant has mild delay in upper limb milestones on the affected side, and there is persistent ATNR as shown in the image. What is ATNR? This is a reflex seen in newborn. In a supine child, when you turn head towards one side, there is extension of limbs on the same side and flexion occurring on the opposite side. This is called as ATNR. ATNR is nature's way of ensuring that 3-month, 2-month, 1-month child, 4-month child does not roll over and fall from the bed. Once ATNR goes away between 4 to 5 months, rollover as a milestone comes in. So if there is ATNR persisting, the child, when you try to roll over, karvat lena jise kehte hain in Hindi. So when you try to roll over in bed, the child will go into a fencing posture like this. This is called as locked in posture. And locked in posture does not allow the child to roll over. Basically, examiner converted. Very similar question, unfortunately, was asked in some of the other entrance exams apart from FMG and NEET PG, where they had mentioned that if ATNR persists, what is the milestone which will not come? The answer is rollover. What they did was they converted it into a milestone. Please remember that if ATNR is persistent, rollover will not come. What is rollover? Rollover requires turning over the child, and this locked posture prevents it. It's a direct line taken from Illingworth textbook of pediatrics, people who do their internship or people who prepare for PG entrance and people who prepare for super specialty also. It's a simple one-liner, but it is a cruel question. It was a tough question. If you got it right, great. If you did not get it right, it's okay. There are always some, every exam I told you, there are about 40, 50 questions which are very tough. So this was a tough question. The answer is rollover and there is no doubt about this, right? Let us not have any falsehood कि sir कुछ और हो सकता नहीं हो सकता, because it's a repeat question. It is just that it is not a repeat for FMG or NEET PG. It is a repeat from other higher entrance exams which they have put it. It's a cruel question, I would repeat, but the answer is rollover. Moving over to question number 3, it's an integrated MCQ. Now there are two versions. Some people said, sir, 14-year-old tha. Some people said 19-year-old tha. Does not matter. If there is a person who's having extremely long limbs, there is diminished vision, and there is bilateral subluxation of the lens, you are thinking of Marfan syndrome in the patient. And in Marfan syndrome, it is FBN1 gene. FBN1 gene. FBN1 gene, which is mutated, and because of that there is deficiency of fibrillin-1 gene, fibrillin-1 protein, which is responsible for the manifestations. It's a type of connective tissue disorder which is a genetic oriented and does not have any autoimmune basis. So answer to this question is B, fibrillin-1. It's an easy one, it's an indirect repeat one, and I'm quite sure most of you have got it correct as well. So I think right now, even if you got question number 2 wrong, 2 out of 3 should have been correct. Moving to question number 4. Very similar question discussed in all Q banks of doc tutorials as well as in our things. Why am I saying this is not to claim anything. Why I'm saying this is because if you're a junior listening to it, majority of questions were from probable areas. It is just that malnutrition was not there in the pediatrics part. So 34-week preterm baby, respiratory distress and tachypnea after LSCS, chest X-ray is as shown. In the chest X-ray, you can see that there is a diffuse collapse which is happening. Air is black. When collapse happens, the bilateral air spaces become white. The cardiac shadow is not discernible easily. So preterm child, this type of appearance is called as white out lung. White out lung. So white out lung means the entire lungs become white, both the sides, and the cardiac shadow is not separately visible. Everything pointing towards surfactant deficiency and hyaline membrane disease, also called as respiratory distress syndrome, is your answer. Answer change nahi karna hai. If you change your answer, you fall into trouble. I have told it so many times, not just me, but all the other faculty members also say, even if we pass this exam, yes, we will pass this exam. I'm quite sure most of you will pass the exam. But tomorrow when you prepare for NEET PG, my advice to you, please do not change your answer. You change your answer, 9 out of 10 times it always goes wrong. So first answer is always the correct answer. So this is the answer, hyaline membrane disease. Let's move further. Question number 5, child with cyanosis. So I just got a message before I started the session. Sir, cyanosis ke saath poor feeding also was mentioned. That does not change the answer. It is the typical boot-shaped heart which had been shown. Boot-shaped heart, also known as core and sabo, which is a feature of tetralogy of Fallot. It's a repeat question. And if you actually count out of these 5 questions, 4 are easy and solvable. Let's go further. Question number 6. Term newborn delivered by cesarean section. He had tachypnea with the rate of 70 per minute. X-ray was showing prominent vascular marking and fluid in the interlobar fissure. There was improvement within 48 hours. Term baby, cesarean section, fast breathing, improving with time, and chest X-ray showing fluid in interlobar fissure. It is pointing towards transient tachypnea of newborn. Transient tachypnea of newborn. TTN is a condition in which there is no sufficient time available for the fluid of fetus to be absorbed from the airways. And when the child is born, there is fluid in the lungs, there is fluid in the fissures, and that causes mild fast breathing in the child. With conservative management, patient improves. For future exam, you can get an X-ray. If you see on the right side, this white arrow is the one which is showing you fluid in the interlobar fissure. So this is this arrow, which I'm now marking it as red, is showing the fluid in interlobar fissure. Typical X-ray asked in the exam. Similar X-ray, it is a question which is similar to INI set MCQ. It is a very similar question to INI set PYQ. And if you have attended not just doctor tutorials, but any other platform classes also, and you have been thorough with pediatrics, it was again a solvable question. Everything pointing towards the diagnosis of TTN. If you rule out that milestone question, 5 out of 6 are solvable, right? Let's go further. Question number 7. CFTR gene mutation affects which channel? Some students said, sir, this was there in the paper 1. I'm not sure. CFTR gene mutation is cystic fibrosis transmembrane conductance regulator. It's a type of chloride channel, and deficiency of this or mutation of this leads to a disease known as cystic fibrosis. Some students said, sir, ये question nahi tha. Some students said, sir, ये tha, but I took only 20 seconds in marking it. This is the problem. If a question is too easy, you immediately mark it and you move forward, and it just doesn't get registered. But a question on which you have spent a lot of time, like there was some PSM question where you had to decide, number of vaccines needed and all. Those questions you tend to remember better because you have spent a lot of time. So I'm not sure. But depending upon the recall, you can ignore if you feel this question was not there, but at least 2 different unrelated students have sent the same question. So I have included it here. It's a integrated question between physiology, pediatrics, and medicine. The only thing is you should have read about the topic, right? So chloride is your answer. Question number 8, incomplete recall. Now, this is a recall which is very different from the recall at other platforms. But this student said, ki, sir, they were not asking about stage. They were asking the mother, like a mother has brought her girl it's an adolescent girl to the hospital. And when you examined, the breast development was present. It had just started. Thilarki had just started without any nipple discharge. Nipple development occurs in the late stage, stage 5. Pubic hair is sparse but pigmented. So pubic hair has just appeared. There is no growth spurt yet, no systemic symptom, no vaginal bleeding. So menses have not yet started, which means Thilarki has happened, pubarchy has happened, onset of puberty has happened. This is stage 2 of Tanner staging. We have discussed it in the classes also. And if there is Tanner stage, already puberty has started by 10 years, it is not precocious or delayed puberty. Reassure the mother that it is a normal pubertal development. So if they ask you the stage will be stage 2. If they ask you reassure the mother, then reassurance is your correct answer. Reassurance was mentioned in the question, and this is your correct answer. C and D options were not recalled. See, wherever I have not got the recall, I have tried not to create anything of my own, right? I would better accept ki nahi mila rather than, trying to make something out of myself. So that you people have an idea that this is what happened in the exam. Again, if you apply logic and if you are a good student, you have just gone through OBG and pediatric part of pubertal development, it's again a solvable question. 7 out of 8 solvable so far. Question number 9. 2 versions I have. Stage 3 नहीं है. Dr. Ivermectin stage 3 नहीं है, stage 2 है. क्योंकि sparse pubic hair is stage 2. Curling begins is stage 3. If they did not mention the word curling has started, then it is not stage 3, it is stage 2. This is something I have taught in my classes also. And I've made you say in the break between the sessions also, if you have attended the offline class. So version number 1. Now there are 2 versions of this question. You people decide which version was there. One version is child presents with recurrent cough and cold, acyanotic heart disease suggestive of VSD, which murmur will be seen. Second version, student said, sir, a diagram tha of a cardiac shadow, and they had formed an arrow going from left ventricle to right ventricle, suggesting a VSD, and they asked about the type of murmur. So in VSD, what is the type of murmur that you see, that you hear? It is a pansystolic murmur, which is considered to be a hallmark of these patients. So VSD murmur is pansystolic. Again, it's a simple, easy, doable question. Depending upon which version was asked, I have not sat in the exam, so I have given both the versions to you. So second version was more likely because, again, images I could not find anywhere. So I've just given you the what I got. Question number 10. Ductus venosus bypasses the liver to continue as or become as. Basically, ductus venosus is nothing. Look at this photograph. Ductus venosus connects the umbilical vein. It arises from left side of umbilical vein and merges into inferior vena cava, which is coming from the lower body. And so ductus venosus continues or becomes a part of inferior vena cava. Now, options were written in ductus venosus to inferior vena cava, ductus venosus to portal vein. This is how options were written. This was told to me at the last minute, so I could not change the option, but you do get the idea that IVC IVC is the correct answer. Ductus venosus connects umbilical vein with inferior vena cava. In fact, ductus venosus becomes a part of inferior vena cava. Next question, number 11. It's a repeat question. The language has been changed. 5-year-old child, fever, cough, runny nose, conjunctivitis. Small blue-white pinpoint spots with erythematous base were mentioned, and photograph was also given. And there is a generalized maculopapular rash which appeared after this. This is nothing but buccal spots. Buccal spots, also called as Koplik spots, because they were described by a person by the name of Koplik. So buccal spots or Koplik spots goes in favor of measles. It goes in favor of measles. Okay, Dr. Ivermectin. So as I said, we are trying to be as close as possible, but again, the exact question cannot be known. So answer is measles. Before we go further, except for question number 2, which was tough, where if you got it right, great. If you didn't get it right, still 10 out of 11. At least 9 to 10 out of 11 should have been correct. Let's go further. So pediatrics was tougher than previous years, but it was still solvable. Question number 12, indirect MCQ. Not indirect MCQ, it's actually a indirect repeat MCQ. Indirect repeat MCQ. The repeat word got missed when I was, typing the question numbers. Child presents with fever and palpable purpura in lower limb, colic abdominal pain, painful swelling of the ankle joint. Platelet count is normal. Platelet count is normal, cannot be ITP. ITP का एक separate question है. What is the likely diagnosis? This is Henoch-Schönlein purpura. Henoch-Schönlein purpura का diagnostic criteria क्या होता है? Hallmark is petechial rash on lower limb and buttocks. The criteria says purpura or petechiae on lower limb and buttock along with any one out of these 4. Diffuse abdominal pain or histopathology showing IgA deposits, joint involvement like arthritis or arthralgia, and renal involvement in the form of nephritic syndrome, proteinuria or hematuria or both. They are being fulfilled in this question, and so the answer is HSP. I would say it is an indirect repeat question of FMG exam 2022. If you have been through PYQ, image was not there, but this time they showed the image as well. So this is Henoch-Schönlein purpura. Absolutely solvable. Question number 13. Which of the following integrated between ophthalmology and pediatrics, and PSM people also enter inside. So which of the following is the earliest sign of vitamin A deficiency? Symptom alag hota hai, sign alag hota hai. Symptom is what the patients say, sign is what we find. We have written separately in the classes, night blindness is the earliest symptom. Patient बोलता है, patient नहीं बोलता मेरे को dryness हो रहा है. Patient says, I have difficulty in seeing in dark, or my eyes take a long time in adjusting when I move into a dark room. That is the symptom. What do you find? You don't find night blindness. You, the doctor, when you find something, you call it as sign. Dryness of conjunctiva is the earliest sign. Separate MCQ, if they say earlier symptom, the answer will be night blindness. If they ask earlier sign, the answer will be conjunctival xerosis. Now, there is one school of thought which says this question was not there. If it was not there, you can ignore it. I don't know why, but this question is there across all recalls and all platforms also. If it was not there, I'm quite sure you would have got it right. Right? If you want to consider it as correct. But if it was not there, you can ignore when you are calculating your score. Okay, let's go further. If you did not see this question, we will put it as doubtful recall. I'll write doubtful recall. When I do a detailed recall separately, then obviously I will remove this question. Okay, question number 13. Let's continue. Let's not stop the flow. Question number 14. Was this there? Child came with bleeding. Obviously, it was not just this. There was a 2-line question, I was told, and vitamin deficiency they were asking. So bleeding occurs due to coagulation factor deficiency, which is again a feature of vitamin K deficiency. So you just need to see if such a question was there or not. If it was there, it was a very, very easy thing. Yes. Question number 15. A baby came. This was there. This is definitely there, and it is a solvable question. Pleomorphic rash. Pleomorphic means variable types of morphology in the patient. Centripetal, coming on trunk, going to the face. Pleomorphic centripetal rash goes in favor of chicken pox, that is varicella. Chicken pox, that is varicella. One question doubtful, one question tough. The question number 2. If you see, so technically we have done 14 questions. Out of them, 12 to 13 should have been correct. You understand? So many of you who are thinking कि मेरा पेपर अच्छा नहीं गया, maybe it has not gone as bad as you are thinking. Just stay with me for 5 minutes more. I'll finish in the next 5 minutes. Question number 16. Case scenario, neonate with less abdominal and limb tone. Abdominal muscle tone was less, limb tone was less. Wide open fontanelle was mentioned and something more information was given, and they had asked the likely diagnosis. Options are not there, but such a question is definitely there because two of the students said कि sir वो उन्होंने description बताया, which the description which I discussed in the classes also. So they said कि sir वहां पर immediately हमें याद आ गया that the diagnosis is congenital hypothyroidism. Again, it was there. The other options have not been recalled. But if you find any infant with less abdominal tone, persistence of neonatal jaundice, any umbilical hernia happening, wide open fontanelles which are not closing or they are abnormally wide, or they are, not bulging, but they are, full fontanelles, your diagnosis will go in favor of congenital hypothyroidism. And if they mention macroglossia, large tongue, and umbilical hernia, then the answer becomes congenital hypothyroidism, also known as cretinism. Also known as cretinism. Again, it's a repeat MCQ. It's a repeat MCQ. It's a solvable repeat question. Let's go further. Question number 17. There was a question where they had 3 lines long question. Fever was there, petechia was there, and there was fever was not present, was initially present. Then the child developed petechia. There was no hepatosplenomegaly, and there was increased megakaryocytic activity in the bone marrow. Likely diagnosis is acute ITP. Some people said acute word nahi tha, ITP tha. Remember, whenever there is fever followed by onset of 1 to 7 days later, onset of petechiae purpurae, but there is no hepatosplenomegaly, no lymphadenopathy, no joint pain, no GIT involvement, you will think of likely ITP. And when you do bone marrow examination, you will find megakaryocytic hyperplasia. Megakaryocytic hyperplasia. Treatment in these patients, generally treatment is not needed, but if platelet count falls below 20,000, you have to give IVIG followed by steroids. Very similar scenario in MIQ series I have discussed on the YouTube. It is there on the YouTube. You can have a look at it. Again, I'm not claiming that it was exact question was there, but similar description was there that you need to know. Only ITP was there. That is the answer. Thank you, ivermectin. At least isi bahane you remembered me. So question number 17, acute ITP. Again, one question was not there, one question was tough. 15 questions should have been correct. Even if it is 14 out of 17 is an excellent score, dear friends. Question number 18, was there infant of mother with HIV? I don't know. Like one of you have said, sir, there was a question, statement-based question, in infant of mother with HIV. मुझे recall नहीं मिला, तो मैं अपने आप से नहीं बनाऊंगा, right? So how many questions were there? This time again, it was back to about 15 to 16 questions in pediatrics. But if you see, compare it with some other subject, still, out of these 18 questions, let us say two were actually not there. Actual question number is 16. Out of this, another 1 to 2 questions, they are integrated. You can solve from other areas also. One question was very tough. But look at the other number. 13 to 14 questions were very, very solvable. So if you got 13 to 14 out of these 17, 18 questions right, you are very much in the game. Remember, you need to get 50% correct. So if one subject has gone bad and your pediatrics, you have done 13, 14 questions correct out of these 18, you are very much in the game. You are actually, picked up your strike rate in this cricket match which is going on. I'll not take much of your time. Yes, if there is a 65% in all subjects, there is a very good probability. The only thing is recall should be proper and you should remember precisely what did you mark, right? Okay, if that was not there, that is what I said. Let us assume 16 questions were there. Out of 16, 13 to 14, out of 16, it's almost 90%, which is doable. So pediatrics, verdict, it was tough this year, but still solvable. So don't ignore the child. And yes, you will pass the exam, have a positive frame of mind. Once you pass the exam, give the right message to juniors. Don't neglect the child. The child saves the adult sometimes in the exam. Okay, thank you so much. Thank you for your... Yes, one question on DMD was there. Question number 19. DMD was there, but I have not got the recall. Recall is missing. So when I do a detailed recall, which will be put up shortly on the channel also, YouTube channel also, on the Dr. Tutorial app also, detailed DMD. This was again given to me as a message, but recall is not, the options are not there, so I will not frame the question myself. Okay. Yes, you are in the game. Okay. Take care, everyone. And let's continue the session. And shortly, Pallavi ma'am, our dermatology faculty is joining us. A lot of questions in derma also, many integrated ones. Let's see how did you do in derma. Thank you, everyone. Take care. Good night.
Hello, everyone. That's a lot of questions from dermatology. How was your exam? First, tell me, how was your exam? Is my audio video okay? The tech team, is the audio video fine? Just let me know. It's always good to come to the recall questions, especially when you know you have discussed it all in the exam. And it's even better when I get to know from all of you that these were the points that you had studied, that you remembered, and you recalled them in the exam. I hope dermatology went good for all of you. Give me a thumbs up on your dermatology questions. I sincerely hope from the bottom of my heart that you got these questions correct, because these were the questions that were expected. Almost all of them previously asked questions, previously asked topics. So these are all PYQs, PYTs, and just make me happy, make yourself happy. Tell me you got them correct. Yes, Ashish, nucleophilic, all of you over there, let me know how your exam went by. I did get about 11 questions in dermatology. So let's begin with our discussion. If these are strictly recall based questions, if there is any discrepancy that you note in the language of the question in the options, do let me know. That will help us in compiling appropriate exact exam based recall. So starting with question number 1 in dermatology, a 40-year-old truck driver presents with a A 40-year-old truck driver presents with a single painless ulcer in the oral cavity. On further examination, there is a painless ulcer in the oral cavity. So that's a new thing for them to ask in the exam, a ulcer in the oral cavity. On further examination, there is a painless ulcer on the penis and the corner of the mouth. Based on this clinical presentation, what is the most likely diagnosis? So what do you think is the correct answer here? There is a painless ulcer in the oral cavity, and there is a painless ulcer in the genitalia. So based upon these two questions, what do you think is happening here? What do you think is happening here? So aphthous ulcer, let's look at the options. Aphthous ulcer is always painful. There was a point in the FMG exam, maybe 2017, 18, 19, where they loved asking an image of aphthous ulcer, where they loved giving you a question of a painless ulcer in the oral cavity, which was well defined on an erythematous base, had a yellow necrotic slough on the surface, which was an aphthous ulcer. They loved asking that. After a lot of time, they've put that in the option. But remember, aphthous ulcer is always a painful ulcer. So this cannot absolutely be the DD of a painless ulcer. Herpes labialis, again, it is painful. So this is also out. Oral lichen planus can present with a patch with lacy reticulate stria. Yes, if there is an erosive LP, this can have a burning sensation, but will that have pain? No, it will not be painful. Yes, it will have a burning sensation if it is erosive LP, but it is not painful. So when you have a painless ulcer, if it was just in the genitalia, your answer was straightforward, it was correct. But the point that's confusing here, which puts you in a limbo, that is the presence of ulcer in the oral cavity. But remember, when it is syphilis, the chancre which develops depends upon the type of sexual activity. If it is a normal penovaginal sexual activity, you will get a genital ulcer, which will be on the genitalia. But if it is a peno oral type of sexual contact, then the chancre can be present in the oral cavity, which is in fact the most common site of extragenital chancre. We always read that in the classes. So this can be a site for an extragenital chancre. This is what the question is asking you, which is more common now with different promiscuous activity, with different types of contact that are happening. So chancres in the oral cavity are a common thing now, and this is what the question is testing. So aphthous is out, herpes labialis is out, oral lichen planus is out. The correct answer here is primary syphilis, just by virtue of knowing that this is a painless chancre. So based upon what the question is telling you, remember that primary syphilis can present in the genital area. It can present in the perianal area if it is a peno-anal contact. It can present in the oral cavity if it is a peno-oral contact. So basically, the site of inoculation of the treponema just depends upon the type of contact. So the correct answer here is option C, that is primary syphilis. Now, coming to question number 2, there are 3 questions from the sexually transmitted diseases. You know, whenever we discuss this in the regular classes, we discuss it in the rapid revision sessions, which are the HIT sessions, or we discuss it in the MIQs, I always tell you that STDs are the karta dharta, they are the mama, papa, dada, they are everything of your entrance exams. Because by asking STDs, they are asking you dermatology, microbiology, STD, even ObGyn, multiple subjects covered by one question, and that's what this exam also did. So coming to this question. Oh, excellent, Ashish. That's good. In fact, I would be happy to say that if you see your 5 questions were from the MIQ, the 20 questions that I discussed in the MIQ session before the FMG exam, there are 5 ditto, I would say, questions from those topics. So important topics remain important topics. PYQs remain PYQs, and so do PYTs. That's all that all of you who are going to give the exam again, for those who are watching, I hope for all of those who've given the exam, you don't have to give it again. For those who are watching and who have to give the exam, for you, this is a Bible which you have to know. So coming to this question, a patient presents with a transient genital lesion followed by a painful inguinal lymphadenopathy, which is a bubo. Which chlamydia trachomatis serovars are responsible? So this question was long in the asking. We always discuss this. Tell me, when I tell you that chlamydia trachomatis as an organism has different serotypes. When you look at the serotypes, A, B, BAC, what does this cause? This causes trachoma. D to K causes non-gonococcal urethritis as well as non-gonococcal cervicitis. K के बाद क्या आता है? L. So L1, L2, L3 causes what is LGV. So these are the 3 different diseases which are caused by chlamydia trachomatis. It's different serovars. Now look at this patient here. He has a transient genital ulcer followed by painful inguinal lymphadenopathy. Which out of these do you think is the disease happening? Is this involving the eyes? No. Is this coming with a urethral discharge? No. So non-gonococcal urethritis is out. This is presenting with what is a bubo, which is the secondary stage or the inguinal stage of lymphogranuloma venereum. So the diagnosis, as mentioned in the question, is the LGV bubo, and this is caused by the L1, L2, L3 serovars of chlamydia trachomatis. So this was a question which was very much in the asking. In the 2024 exam, they asked you what causes bubo. Bubo is caused by chlamydia trachomatis, where disease you see bubo, that is lymphogranuloma venereum. Plus, they keep asking you different types of STDs. So this was a question which was very expected, and I hope you all got it correct. So the correct answer to this is L1, L2, L3. D to K causes non-gonococcal urethritis. A, B, BAC causes eye infections, which are trachoma in the eyes. Now, what about this one? A patient presents with a painful genital ulcer with ragged edges, with tender inguinal lymphadenopathy. What is the most likely causative organism? So, I tell you, whenever we talk about STDs, that is genital ulcers. In the genital ulcers, we always classify the disease into painless genital ulcers and painful genital ulcers. In the painless genital ulcers, we have syphilis and donovenosis. In the painful genital ulcers, we have chancroid and genital herpes. So, what is happening here? Is this painless or this is painful? Look at the question here. This is painful. So if it is painful genital ulcer with ragged edges, with tender inguinal lymphadenopathy, you go towards chancroid because this is the characteristic ulcer which has ragged, undermined edges. So that is the characteristic finding of chancroid. With herpes, it is more of grouped vesicles. Those vesicles rupture to form erosions, but you don't get ulcers with ragged edges in genital herpes. So when that is mentioned, you know they're talking about chancroid. What is the causative organism for chancroid? Treponema pallidum? No, this causes syphilis. Hemophilus ducreyi? Yes. This is the one that causes chancroid. Chlamydia trachomatis L2 variant is causing LGV. Klebsiella granulomatis is causing donovenosis, which is a painless ulcer. So if you just know your basics, if you just know this basic approach to genital ulcers, you can very easily solve all these questions which come with genital ulcers. So the correct answer here is option B, that is Haemophilus ducreyi, which causes chancroid, which is a typical painful genital ulcer which presents with ragged edges and tender inguinal lymphadenopathy. And the kind of lymphadenopathy here is a suppurative lymphadenopathy. So if the question was mentioning this, that would have taken you further towards chancroid as the correct answer here. Any doubts in this? Any changes that you want to suggest in the question or in the options that were asked? Nope. So we move forward. Now, coming to the fourth question here. Again, a very expected question. A patient develops fever for 3 days. Now this is followed by a centripetal vesicular rash. What is the most likely diagnosis? They love asking this question. It's there in almost every alternative exam. So again, this is a very, very expected question. I know that you just recently saw this in the pediatrics discussion also. So that is what is the beauty of integrated questions. By asking these, they ask you pediatrics, they ask you dermatology. This is also discussed in community medicine. This is also discussed in microbiology. So by asking infections, it kind of caters to so many subjects at the same time. That is why this is such a favorite topic for the examiners. So whenever you read this keyword, centripetal rash, that should ring varicella in your mind. Vesicular rash, I always tell you, the only disease which has generalized vesicles all over the body, you have to think of varicella. That is the only point that has to come to your mind when there are generalized vesicles all over the body. Nothing else that you have to think. And what causes varicella is the varicella zoster virus. But what is the question asking us? Question is asking us most likely diagnosis. Is this smallpox? No, this does not happen anymore. Measles presents with a maculopapular red rash. It's actually a blotchy rash that develops. There are no vesicles in measles. Chickenpox, yes, it can present with vesicles. Dengue either presents with a red maculopapular rash or it can present with petechiae, but again, there are no vesicles in dengue. So what is the correct answer here? You know it. Even by elimination, you come to the correct answer, which is varicella or chickenpox to this question. However, if this was a patient who has vesicles on the hand, foot, and the mouth, what would your correct answer would be? That would be hand, foot, mouth disease, which is caused by Coxsackie A16 or the enterovirus 71 virus. So depending upon where the vesicles are situated, if they are present all over the body, you have to think of varicella. If those vesicles are present on the hand, foot, and the mouth, you have to think of HFMD, which is caused by Coxsackie A16. All these other diseases, they do not cause vesicles. Smallpox anyway does not happen anymore. So even though it causes vesicles, you will not consider it because it is not a disease that we see commonly. Measles, dengue is out. The correct diagnosis here is chickenpox. Coming to this question, a patient with borderline tuberculoid leprosy on MDT presents with an acute inflammation of existing lesions and there is neuritis. What is the most appropriate management? A similar question was asked last year in the FMG July exam. Similar question in multiple NEET PG exams, INICT exams. So this is a very favorite of the exams. They love asking leprosy. In leprosy, they love asking leprosy reactions. So what do you think is happening here? What do you think is happening here? Tell me. What do you think is happening here? So this is a patient who has BT leprosy, that is borderline leprosy. He presents with acute inflammation over pre-existing leprosy lesion with neuritis. So there is probably a leprosy reaction happening here. If you talk about leprosy reactions, there is a type 1 leprosy reaction, there is a type 2 leprosy reaction. So type 1 leprosy reaction generally happens in the borderline leprosy patients where there is redness, edema over the pre-existing leprosy lesions. Along with that, there can be neuritis. However, type 2 leprosy reaction always happens only in one variant of the disease, which is the lepromatous leprosy, that is the LL leprosy, in which there are new lesions of ENL, which happen all over the body, that are the red tender nodules with fever, with arthralgia, with systemic manifestations that happen all over the body. So what is this patient? This is a patient of borderline leprosy. So he is a case of borderline leprosy. He now presents with acute inflammation, that is redness or maybe swelling that's happening over the existing leprosy lesion. There is neuritis. So this patient is probably suffering from a type 1 leprosy reaction. As you can see that in the image also shows that the lesion of leprosy is red. It is inflamed. So this is one of those questions where you don't really need an image because the text itself is telling you what it is talking about. Now, what would be your management? Would you stop MBMDT and start prednisolone? Yes, you would start prednisolone, but you would not stop MBMDT. You have to continue killing the bacteria. You cannot stop MBMDT. You continue MBMDT, yes. You start prednisolone, yes. You stop MBMDT, no. You start thalidomide. Thalidomide is maybe a treatment for type 2 leprosy reaction, but even though it is a treatment for type 2 leprosy reaction, it is not the first line of management. So you would not even do this. You would not do this. Continue MBMDT, increase clofazimine? No. Increasing clofazimine is again a management for type 2 leprosy reaction. It is not the management for type 1. So what is this here? This is a type 1 reaction. You would continue MBMDT. You would start prednisolone. Correct answer here is an option B. So this is a very this is a question which is actually testing whether you can make out if a leprosy reaction is happening. Plus, for all of those who may not be sure whether you can make out it is a type 1 reaction or it is a type 2 reaction. Basically, whatever is the leprosy reaction, whether it is type 1, whether it is type 2, the initial management of choice remains the same. You have to continue the MBMDT and you have to start steroids. So the initial management remains the same. You do not really have to differentiate based upon the type of reaction. Neither is this question asking you that. It is only and only asking you what would be your approach to management, and it would be to continue MBMDT and start prednisolone. Now, in this question, I hope you all got it correct. Am I there with you? Sorry for my throat. So, are we there? Should we move on to the next? Yes. So, in this question, an individual presents with a chronic, progressive, enlarging swelling of the foot associated with multiple discharging sinuses. The discharge contains grains. Examination of clinical picture shows black granules. Microscopy of the grain demonstrates hyphae. What is the best management strategy? What else can a question give you? What else can it give you? You know, a similar question was there in the NEET PG 25. It was there in the INI 25. It was there in the MIQ. And now this question is there in the FMG paper. So this is like, if you don't know this, then you don't know it. But this is a question that you cannot not know, because mycetoma or subcutaneous mycosis, they are going to ask in every exam. One out of sporotrichosis, chromoblastomycosis, or mycetoma, they are going to ask, and they have asked. So what do you get out of this? When you look at the image, you see there is a swelling of the foot. There are discharging sinuses, as is mentioned in the question. So one of the triad of swelling, second triad of sinuses, third is the grains. So when these three components are present, what is your diagnosis? Your diagnosis is mycetoma. So your diagnosis is mycetoma. At this point, we do not know whether we are dealing with the fungal or the eumycetoma, or we are dealing with the actinomycetoma, which is the bacterial etiology. But next point says there are black granules. So when there is a mycetoma with black granules, you have to think of Madurella mycetomatis. You have to think of Madurella mycetomatis, which is further strengthened by the point that the microscopy shows hyphae. So when it is black granules plus it is hyphae, you know you are dealing with eumycetoma. You know you are dealing with eumycetoma. So when it is eumycetoma, what is the management of choice? Would you give antibiotics? No, not at all. I am dealing with fungi. I am dealing with hyphae, black granules. Why would I give antibiotics? No. Would you do amputation? Not by itself. Would you do dapsone-based multi-drug therapy? That could be the modified Weld regimen, which is given for actinomycetoma, but not for hyphae. Would you do antifungals with surgical debridement? Definitely yes. Management of eumycetoma is long-term antifungals. That is itraconazole with a surgical debridement or a surgical debulking. That is the treatment of choice for mycetoma. This is what we teach, this is what we study, and that is what the questions ask. So over the last many years, they limited themselves to asking, okay, what is a diagnosis? Is this mycetoma? Then the last two NEET PGs, they asked whether it is a mycetoma or it is an actinomycetoma. Here, in this question, they came to the management. So remember, the exams are ever evolving. They are ever changing. They will not stop at asking you the diagnosis. They will now ask you the management, whether it is investigations, whether it is treatment. This is what the exams are moving towards, and that is what we have to study for. So please do not limit yourself to just studying the management in terms of diagnosis identification. Please move to the next point. This is of paramount importance for all of you out there. So the correct answer to this is option B, that is antifungals with surgical debridement. So that was about the infections. We now move to other dermatological questions. Again, this is a sort of repeat from August 2020 FMG paper. In there, instead of rheumatoid arthritis, it was a patient of inflammatory bowel disease. Here it is a case of rheumatoid arthritis who presents with a rapidly progressive painful ulcer on the leg with undermined edges, violaceous borders. What is the most likely diagnosis? So for all of you out there, tell me, what is your most likely diagnosis? Patient who is a known case of rheumatoid arthritis now presents with a painful ulcer which increasing. It has violaceous borders, it undermined edges. What is the correct answer here? Yes, these are all questions which are there in the CPR, which are there in the MIQ. I urge you all to please give enough importance which is due to these questions. They are there for a reason. Venous ulcer, it is not rapidly progressive. First of all, it is a slowly progressive ulcer. Secondly, venous ulcer has punched out borders, and it will have history of chronic venous insufficiency. It will not have violaceous borders. Necrotizing fasciitis, a completely different picture. It will not have undermined edges. It will not have violaceous borders. It will be a deep infection which will be exposing the bone or the fascia in the patient. So not a venous ulcer, not a necrotizing fasciitis. Next, what are the options? Is this pyoderma gangrenosum? Is this ecthyma gangrenosum? Both of them sound similar. Both of them seem like infections. So what do you think is happening here? What do you think is happening here? Yes, very good. All of you, correct answer. Ecthyma gangrenosum is an infection which is caused by the Pseudomonas bacteria, which is a sick patient in the ICU with a pseudomonal sepsis who presents with multiple ulcers with a eschar on the surface. So it's a very different clinical picture. You already have a patient who's sick, who's in the ICU, who probably has a pseudomonal sepsis, and now there's a shower of bacteria to the skin, and on the skin they're causing multiple ulcers with a black eschar on it. That is what is ecthyma gangrenosum. This is not the clinical picture mentioned here. Rheumatoid arthritis, ulcer, undermined edges, violaceous borders. This takes you to pyoderma gangrenosum, which is a neutrophilic dermatosis. There is a dense neutrophilic inflammation in the skin, which causes formation of ulcer. This is a rapidly increasing, more than 1 centimeter a day, intensely painful ulcer. It has violaceous borders. It has undermined edges. This is a typical case of pyoderma gangrenosum. And in fact, this is not an infection. All cultures are negative. all cultures are negative in these patients. That is something that you have to remember. This is what you see in pyoderma gangrenosum. What would be the treatment of choice? Treatment of choice for pyoderma gangrenosum would be steroids. That is the treatment of choice for pyoderma gangrenosum. A woman with diabetes mellitus reports an asymptomatic skin lesion which is present for a year. Examination shows a non-scaly annular lesion similar to the image below without itching, without pain. What is the most likely diagnosis? Another question, which is an FMG August 2020 repeat. So there are multiple questions from the August 2020 paper. The hints in the question, this is asymptomatic, this is non-scaly, this is annular, there is no itching, there is no pain. Image also shows us a annular lesion which is ring shaped. There is normal skin in the center. The margins are skin colored. What is the diagnosis here? Is this annular lichen planus? Lichen planus would number one be purple. This would be itchy. So this is not purple. This is not itchy. This is out. Tinea corporis would have red. This would have scaling. This would be itchy. Again, not the correct answer here. Annular psoriasis will be red. This will be scaly. This would be though non-itchy. So this lesion here, skin colored, non-scaly, rules out psoriasis. The correct answer here is granuloma annulare because the image as well as the description in the question matches that of granuloma annulare, making option C the correct answer here. Coming to this question, a female presents with grouped vesicular lesions on the upper lip as seen in the clinical picture. So in the clinical picture, you see grouped vesicles as mentioned in the question. Target lesions on the so in the question here, you see lesions which have 3 concentric rings, which is the target lesion. Now, what is the most likely diagnosis? Is this pemphigus vulgaris? No. Pemphigus vulgaris would show flaccid bullae. It would not show target lesion. Is this bullous pemphigoid? No. This would show tense bullae with itching. Is this dermatitis herpetiformis? These would be itchy lesions on the extensors. What do you think is the correct answer here? The fact that this patient has a history of herpes labialis, this patient now has target lesions, which are the 3 concentric rings. The correct answer here is erythema multiforme. Another repeat from the MIQ paper, exact similar question I had put in the MIQ because in the INI November 25, they had put a question on fixed drug eruption, which you had to rule out from erythema multiforme. So it was quite anticipated that they would ask a question on either of these two in the FMG paper also. So for all of you watching, please remember that you have to look at the INI papers which happened before the FMG paper. A lot of topics remain the same. So the correct answer here is option B. This is erythema multiforme. Herpes simplex infections are the most common infectious cause of EM. You see these typical target lesions with 3 rings. That is what gives you the correct answer. This is erythema multiforme. A child presents with itchy rash, which is predominantly involving the extensor surface. There is positive family history of asthma in the father. Based on this presentation, what is the most likely diagnosis? So there is a itchy rash on the extensors plus a family history of asthma in a first degree relative, which is a father. What is the correct answer? Is this cradle cap dermatitis? That's a seborrheic dermatitis of the scalp. You will have a yellow, greasy scale. This is out. Scabies, yes, would be itchy rash, but there is no history of atopy here. And the itching here is in the skin folds in the circle of Hebra distribution. There is nothing to suggest contact dermatitis. The correct answer here is option B. That is atopic dermatitis. With this, we finish our discussion on the dermatology questions. I hope you got all these questions correct. any modifications, any changes in the options or the questions, please let us know. Thank you so much for the discussion of the dermatology. I sincerely wish that you all get the result that you were hoping for, that you have worked hard for. Thank you so much for watching.